My name is Darek Dawda. I'm a clinical psychologist. And here behind this shield is Neil McArthur. He's a philosophy professor, an ethics professor. And we are here to talk about MDMA-assisted psychotherapy and in a broader sense about psychedelic assisted psychotherapies. Um, so I am a part of Enhanced Therapy Institute, a Winnipeg group that is preparing for medical delivery of MDMA assisted psychotherapy when it's legalized and available. And I encourage you to visit our website at enhancedtherapy.ca. We have an informative blog. We have the blog, we have a demonstration video about how MDMA assisted psychotherapy will work when it becomes available. A week ago, I did a 2-hour interview with Rick Doblin, which was really quite an adventure, and that interview will be the first episode of our Enhanced Therapy podcast. So that will be available soon. So if you'd like to sign up at enhancedtherapy.ca, you will get all the updates and access to all this information. I should say that my life and business partner, Jessica Gonzalez, was supposed to be with us here this morning. However, we have a pretty bad COVID situation in Winnipeg, and we decided that she will stay home. She will, however, be our chat moderator today, and she will make sure that everybody is respectful and kind. And we have Thomas, who is our tech guy. If there are any problems, you can contact him. And just as a matter of quick introduction, I can't think about better times to talk about new healing technologies. It's I think most of us would agree that we can use more effective healing methods for connections, relationships, and trauma. And MDMA assisted psychotherapy is showing great promise right now. Pretty amazing research results are rolling in as we speak. In fact, we may have, if we're lucky, I don't think I should be saying anything, but we might have a pretty big announcement here today during this conference regarding some of the research results. But of course, we can't get carried away because MDMA is a very powerful psychoactive substance, and it's illegal right now. And MDMA-assisted psychotherapy poses a unique set of ethical and legal issues, and that's why we organized this conference to talk about ethics, legality, some clinical issues related to MDMA-assisted psychotherapy. I'll pass this on to my co-conspirator, Neil McArthur.
Thanks, Dark. So my name is Neil McArthur. I am usually the director of the Center for Professional Applied Ethics at the University of Manitoba. I'm actually just away from that position for a year to serve as the head of the philosophy department, but I will be returning to the Ethics Center next year. And this conference was organized partly under the auspices of the Ethics Center. What the Ethics Center is a center at the University of Manitoba that's devoted to promoting discussion and debate around issues of contemporary interest and concern. We don't advocate for any particular position. We don't do lobbying or anything like that. We just try to have public events and promote discussion and debate. And so We wanted to get involved with this conference because we saw it as an opportunity to address an issue that could potentially be important, and as Darek says, has a lot of potential to address some of the challenges that we currently face. Uh, and so again, yeah, we're certainly not gonna, we're not pushing any agenda here. We just wanted, we wanted to bring some really smart people and some interesting people together, which is exactly what we've been able to do. And so I'm maybe going to have to lean in a little bit. So Jessica's telling me that I'm hard to hear. So okay. Anyway, uh, I wish we could. I wish we could have this conference standing in front of everybody, but and actually meet people and chat with people. Hopefully, there will be a time in the future when some of the great people who are involved in this and some of the many people who are interested in this will be able to gather in person. But that is not the time we live in right now, as everybody knows. I'm not sure what else I need to say about the Ethics Center. I would love it if people who are interested in our public events, which are now currently all like this via Zoom and accessible anywhere in the world. In more normal times, we have them around Winnipeg on campus at McNally Robinson, places like that. Our public events are open to everyone. They are usually meant to be of interest to a wide audience. So if you join our Facebook group, uh, Center for Professional Applied Ethics, University of Manitoba, there are actually quite a few similarly titled ethics institutes. So you just have to make sure you get the one at the University of Manitoba. And you will find out about if you like that page or do whatever you're supposed to do on Facebook now. You will find out about our future events. So that would be great if you did that. And that's all I have to say.
All right, so maybe a couple of technical points. We first of all, we promised you private chat, so there's a general chat there, so you can talk to everybody. We promised you private chat, but didn't happen. This is the first time we're doing this, and we haven't figured out how to do that. So apologies for that. Another point is please make sure that you ask questions in the Q&A box. Don't ask questions in the chat because that is scrolling pretty fast and we might not catch your questions there. Our chat moderator will make sure that that's happening. We hope that we're not going to have any issues here in terms of crashing and any big disasters. But if anything happens, just log back in. We'll take 5 minutes to reboot this and figure out what's going to happen and how we need to solve this. So before we start with the presenters, what we have a little bit of time. Before we start with the presenters, I would just like for those of you who haven't, hi Jazmin, for those of you who haven't heard much about MDMA-assisted psychotherapy, I just want to make sure that you have a little bit of an introduction to the basics. This MDMA-assisted psychotherapy is a very unique kind of therapy. It's unique in the way that the drug and the therapy is inextricably linked. The way healing has been happening up to date is that you do your psychotherapy and then maybe you do your medications. You do your medications and then maybe you do your psychotherapy. They're not really, there isn't much connection there. MDMA-assisted psychotherapy and other psychedelic-assisted psychotherapies, the psychotherapy itself is designed around the healing properties of the medication. So in that respect, it's unique. It's also unique in the way that you will be working with a team of professionals. With the medical delivery of this kind of therapy, you will be working with a team of professionals. There will be 2 therapists and a prescribing doctor or a psychiatrist. And regarding the structure of MDMA assisted psychotherapy, there's four kind of different points, different stages. The first one is screening, and screening is very important, again, because MDMA is a powerful psychoactive substance. There is a whole bunch of exclusionary criteria that are being developed as we speak. And essentially, the purpose of screening is to make sure that this therapy is safe for you and that it will be useful for you. Once you are in therapy, what you do is go through several preparatory or preparation sessions. So, preparation sessions are designed to prepare you for the dosing. That's one purpose, but also, of course, all the other psychotherapy aims are take place during the preparation session. So developing a working relationship with your therapist and just essentially doing psychotherapy. And then after preparation sessions, say you have 3 preparation sessions, then you will have a dosing session, which is a several hour long session. And then after the dosing session, you will go through integration sessions. And integration sessions are designed to integrate the gifts, the insights from the dosing experience into everyday life. So this sort of therapy, this kind of therapy is often referred to as integration therapy, because the point of this therapy is not so much to have the experience, the MDMA experience, though some will argue that MDMA experience is important in itself. But the purpose of this therapy is to integrate the insights and the gains from the MDMA experience into everyday life. And hence it's called integration therapy. One other thing to point out about MDMA-assisted therapy that is very important is that it's not that you might only have one administration of the MDMA during MDMA-assisted psychotherapy. So the current protocol that MAPS is using in their FDA approval research has 3 dosing sessions. So essentially their structure right now, to give you an example of how this might look, is that they have 3 preparation sessions, followed by a dosing session, followed by 3 integration sessions, followed by a dosing session number 2, followed by 3 other integration sessions, followed by a dosing session number 3, and followed by another integration session. Three integration sessions. So 12 sessions in total. And this is the kind of design that MAPS has been using for their current research aimed at FDA approval of this kind of therapy. And perhaps we can, I think we can move on, and I'll give this to Neil McArthur.
Thanks. So what we'd just like to do, first of all, is to start with a land acknowledgement. We have people from many different places. That's one of the great things about Zoom, and I hope that as we move from fall into winter, all of you will get outside and experience the land where you are. And I will call for the land acknowledgement. I will call on Jazmin Pirozek. Jazmin is a member of the Kenossissippi Norway House Cree Nation in Manitoba. She lives in Kenora. She is trained both as a biologist and as an anthropologist. She has extensive academic training. She has traveled widely sharing her knowledge and we are very lucky to have her. So maybe I will call on her to give us the land acknowledgement for today.
Hello, everyone. Thanks for having me. I'm really grateful to be here with so many like-minded individuals. It's strange for me to do a land acknowledgement through Zoom. Very exciting, but how do we all acknowledge the land that we're on? And I just like to note that we are all, we are not separate from our land, and we are not separate from each other. And so when we do a land acknowledgement, we're acknowledging ourselves first. Even though it seems like we just have to acknowledge treaties or things like that, it's really acknowledging where we come from, where our food comes from. And the issue with a lot of even mental health distresses is that we've separated ourselves from the land. And this is what I know from my own experiences, as well as from watching others and their experiences as well. So I want to acknowledge where I am. I'm in Manitoba. I'll call it Manitoba because I'm about an hour from the very sacred sites in Manitoba, Bannock Point, Tide Creek, where all the petroglyphs or petroforms are. And we do have quite a few petroglyphs too. So we have a very powerfully ancient history. Biologically, I like to say that I live about 5 minutes from the place where the the volcano of the Canadian Shield erupted. And so I want to acknowledge the rocks in a big way, because that's what we're made of. And I like to acknowledge what we're made of, because that's who we are. And when we ask the world and the rest of humanity and the rest of life for help, the options that they're giving us are things like MDMA, psychedelic-assisted therapy, or any other medicines that are available to humanity. So I want to acknowledge our medicines of the land. I want to acknowledge our knowledge of the land. I would love to acknowledge all the clan systems that are in our region as well. Large amount of Bear Clan in our region. And unfortunately, I can't speak the language, which is something I'm slowly learning. But it's really important that land and language are used to make the acknowledgement. I introduce myself as Mainganangkwe Nadishnikas, Migizi Nadodam. So they call me the Wolf Star Woman, and I come from the Eagle Clan. And when I make my thanks, my gratitudes of my acknowledgement of our place in the world and our place with medicine, I like to sing a song. So this is an ikoro, well, a hymn that I learned in South America from my teacher, Juan Flores. And he's singing about the power of the water and the steam and helping us to all recover. So it'll just be a brief, but I want you all to try to feel it with me. En la casa del Señor siempre hay vapor, hay vapor. En la casa del Señor siempre hay vapor, hay vapor. de las aguas cristalinas nace el vapor de las aguas cristalinas. Nace el vapor, vaporcito por mi cuerpo, cura mi alma y mi espíritu, vaporcito cura mi cuerpo, cura mi alma y mi espíritu. Thank you, everybody. I hope that you have a really great conference, and I'm looking forward to having more chats with everyone.
Thank you so much, Jazmin. That was so beautiful. And again, we were going to spend the day on Zoom today, so I really hope everyone will be inspired by Jazmin to go out after this conference or during lunch and experience the land where they are. So we're at 9:50 now. Technically, our first talk was supposed to start at 10, but maybe I will just, I see Zach is with us, and maybe I will just ask him if he would just like to begin his presentation. I see Zach. What do you think?
Yeah, sure.
You seem okay. Great. I think it doesn't hurt to have a little extra time. I'm not going to go extensively into each speaker's bio because we posted it on the website, and they are all incredible speakers with incredible backgrounds. Zach is, I'm going to say, a friend of the Ethics Center. He's from Winnipeg originally, and he is currently teaching at the University of British Columbia. He has, as well as being trained as a therapist, he has an extensive publication record when it comes to all sorts of psychedelics and marijuana use and all sorts of other really interesting and relevant issues, and runs a lab at the University of British Columbia that studies some of these issues. So he's really honestly one of the if not the leading academic-based experts, university-based experts on these topics. So we're really lucky to have him, and so thank you, Zach.
Thanks for having me.
So I think the way we were planning to structure our session then is that I was going to ask you some questions, and you will answer those questions, and then you will also, as you see fit, bring in other points and go in other directions, because really this is your session. So, so I wanted to ask, first of all, just something, just if you could give everybody a sense of what it's like to be an academic studying these kinds of issues, and whether, I mean, academics is, we are so dependent on university support, hiring support, grant applications, who can get tenured, all these things that make some sorts of topics may be more difficult to study than others. And I just wonder what the landscape looks like for academic study of these issues.
Yeah, I mean, I'm just before getting started, I just want to acknowledge that I'm coming to you from the unceded territory of the Okanagan First Nations. That's where I work, where the university and where my home is right now, where I'm presenting from. So I'm grateful to be presenting from that location. And also, what I'm going to be talking about today will just be my own opinions, but I should also just say from a conflict perspective that I'm on the board of MAPS Canada as an advisor, and also an advisor to Numinous, which is a private company that's looking to provide psychedelic psychotherapies. So back to your question though, what is it like to be an academic studying this? I'd say it's very exciting. And, you know, there is still a lot of stigma, I think. So, you know, I think it varies from location to location. I really got into this area starting with cannabis, and I feel like in some ways there's more stigma around cannabis. It's just so much more familiar to many people, and such maybe a more pronounced marker of some of the culture wars that continue to rage, even though I feel like they're losing steam happily, at least around drug policy. They're sort of shifting to other areas. So personally, coming from starting off in cannabis under the Harper regime, I felt a lot more pressure and concern about what implications that would have than the current psychedelic renaissance. I think the recognition that things like PTSD and perhaps addictions, opioids particularly, that those are so top of mind for so many of us in health, that, you know, looking at novel approaches is really something that I think few people are wanting to interfere with. And I think the psychedelic substances, particularly the way that you know, MAPS and other organizations have gone about it, emphasizing the medicinal value, and also you know, I think the way we talk about them. So I know some colleagues, when we talk about which psychedelics are being pursued, things like LSD might have more of more stigma and more baggage, whereas psilocybin, when we talk about it as psilocybin, for most people who are involved in, of course, make that association with magic mushrooms. But for other folks, and for people who are less informed, and I think those are the people who might carry much of the stigma, these seem like new compounds. And I'll my colleague Peter Hendricks, who works in Alabama with psilocybin, and I've talked to him about it and how he deals with stigma in a place. I'm fortunate to be in the interior of British Columbia, where I think there's less stigma around some of these substances than other places, certainly than Alabama, I would guess. And he talks about describing himself as working with serotonin agonists, if depending on the audience. So I think it depends on how we talk about it in terms of stigma. I think that people who are concerned about it, there's really a counterbalance with so much enthusiasm. So I'd say in general, it's quite rewarding, and it isn't a barrier to work with. In fact, people are excited to talk about it. They're excited to hear about it. The university encourages me, really, because I think it's, you know, it's a nice way to interface with the community, because there is a public interest in these substances. So I've been really supported, and I can't say that I've come across a whole lot of stigma working with psychedelics. And I think it's just breaking down more and more. So yeah, you know, compared to cannabis, where I found that people were a little, you know, have their ideas about people being stoners, or this is just a gateway drug for youth or whatever, I don't think that there's as much baggage with psychedelics. Yeah, I'm really hopeful about it, and I think that those barriers are maybe not as prominent as we might expect.
That's great to hear. Maybe actually, before we sort of get into the meat of it, you could walk us through. So there's legalization, there's decriminalization, there's medical legalization. Could you maybe just give people the necessary vocabulary to make sense of what we're talking about there, what the different options and approaches are legally?
Yeah, I mean, and just broad strokes, you know, there are medicines that can be prescribed by physicians that are given sometimes it has to do with a DIN number, although in the case of cannabis it's been a little bit different. But I expect with MDMA, which we're focused on now, there'll be a specific drug number, and it'll go in the pharmacopoeia, and then physicians and perhaps other medical professionals will be allowed to prescribe it, and to access it without prescription would still be prohibited. On the other end of that, there's full legalization like we have for cannabis now, and even though we call it legalization, it's still illegal for some people, for young people. Though I'm sure there would always be some restrictions on who could access it. But general legalization means that adults can access it from a store without having to go through a physician as a gatekeeper. And then decriminalization is sort of neither. It just removes the criminal penalties associated with possession, usually just with possession, not with manufacturing or distribution. And in that case, it removes criminal penalties for people who are using the substance, not for the people who are providing it, as I said, which is a problem. And it doesn't provide safe access necessarily. So it's just that there aren't legal consequences for having it, but there's not a safe and legal way to access it. So that would be decriminalization. As opposed to legalization, it would be like any other substance, where it's something that can be, regulated and you can access it through some kind of commercial avenue.
And when it comes to MDMA, I mean, we're seeing, I think last Tuesday, we saw some jurisdictions that have decriminalized mushrooms, and we're seeing more and more jurisdictions decriminalize cannabis. Has there been any jurisdiction that is either legalized or attempted to legalize or decriminalized for medical use, anything like that when it comes to MDMA? Is this still unique in being more or less completely banned?
Yeah, well, to my knowledge, there haven't been any jurisdictions that have decriminalized, and there's different ways to decriminalize. There can be municipal moves where the police are directed not to make it a case of lowest priority, or it can, that's one way to decriminalize. And I don't know that that's happened with MDMA. I think the only legal access that I know of to MDMA is through the clinical trials currently.
And so, as somebody who's studied, the clinical trials and who knows the research, I mean, when you look at the risk profile of MDMA versus some other kinds of drugs, either the ones that have been legalized in some jurisdictions or the ones that haven't, where does MDMA fall along that kind of risk continuum?
Well, I mean, there can be a variety of ways to conceptualize risk. First of all, I believe it to be quite low risk, perhaps not as overall as low risk as something like psilocybin. If you take a lot of MDMA, there can certainly be negative physical consequences, negative health consequences. There's issues with potential dehydration and with increased heart rate and stuff like that. But compared to something like, say, alcohol, it's much less dangerous than that. One risk that regulators get concerned about is the risk of developing habitual abuse, or what they call, abuse liability, and that really has to do with how pleasant a substance is, how much people want to use it again, and the idea being that you might encounter it therapeutically, and then it takes on a life of its own and can become habitual. And again, I think we tend to problematize that across the board in a way that we might not. With a substance that has relatively low risk, like something like coffee, we're not at all concerned that people become addicted to it, even if they were to encounter it in a medical setting first. So I think one of the risks with MDMA being a pleasant drug, being having a reputation as a party drug, and I think for people who are familiar with it, they say, yeah, you can have a real good time on MDMA. So there is a potential that people would want to take it in an extra medical setting. Depending on your paradigm, I suppose that could be a problem. I don't necessarily think it's a big concern, given what's going on in the world today, and given the variety of psychoactive compounds that are available to people. I think having access to MDMA wouldn't be at all a deficit to public health. So I think realistically the risks are very minor, and the risks are much greater of keeping it illegal, because then we can't get regulated sources. And I get calls from the media of people saying, oh, what's up with this bad MDMA? And you'll hear terrible stories about young people at music festivals or whatever. And often the media portrays it as bad ecstasy or bad MDMA. And in fact, it's usually not MDMA at all, or it's MDMA that's been very much adulterated with other things that are dangerous. often the adulterants are much easier to access than the actual MDMA. So those things aren't, the things that are killing people are not regulated, which is why people use them as adulterants, because they're easier to access. So if anything, legalizing MDMA would increase public health by reducing contaminated poison drugs, and we certainly see the potential risks of contaminated drugs with the opioid overdose crisis, where opioids are contaminated with fentanyl. So I think we want to see legalization for public health for no other reason, because it reduces rather than increases the risk.
So, I mean, I guess that's kind of the downside, the risk. In terms of the upside, the potentials in a therapeutic context, whether it's for relationships or for PTSD or whatever, of MDMA, I mean, what do we know based on the research that we have right now?
You know, I think the research so far has been really powerful, particularly around PTSD. So, you know, and it's been replicated in a bunch of settings and across time. So it's not just like it's one study or one group of folks. We've seen across diverse PTSD communities, whether it's combat or non-combat or assault, that it seems to really facilitate healing from PTSD. And PTSD is such a difficult condition to treat, and there are good treatments out there. You know, there's good behavioral treatments, and I think those should be front line. And if there is any risk to these psychedelic therapies for PTSD, it would be that I would down the road, people might ignore some of the behavioral options. That's the kind of risk that I would worry about. But I think the therapeutic potential is tremendous. It's not an obscure disorder. There are a lot of people who suffer with PTSD. The consequences can be profound if it goes untreated. So I think any new treatment that can reduce suffering around PTSD and other mental health conditions that may not be identified as PTSD, but that may have trauma either as part of the pathology. I think there's potential there as well. So I think there's tremendous therapeutic potential for MDMA, for PTSD, and for other conditions as well.
I guess we just don't have the same degree of research on relationship therapy, MDMA relationship therapy. I guess it's just kind of a little earlier in the day for that.
Yeah, I mean, it's a more difficult thing to study, and I don't think it's as much of a health priority. Perhaps it should be. I mean, we know how important relationships are, and to overall well-being and health, whether it's psychological health or even physical health. People who are able to have meaningful relationships have greater life satisfaction and better health and fewer healthcare expenses. So I think we should be looking at relationships, but when it comes to a specific diagnosis and something that is amenable to the type of clinical trials that are so important to mainstream science, PTSD is a more powerful target, I think, and certainly one that's I think has a special place in the public imagination, because we recognize trauma and we recognize some of the folks that undergo trauma as being so important to our society. So I think when it comes to initial targets for treatment, PTSD is powerful.
So, and I mean, you already talked a little bit about sort of there's both a fascination and a fear among the public with a drug like MDMA, because it's known as a party drug. It's also known as a way to have a good time. In terms of sort of addressing the public and saying to them, you know, here's what you should know about MDMA therapy. Is there a message that I mean, I know you get a lot of media calls. So kind of what's your sort of takeaway message when the media says, look, you've got, you know, 30 seconds for a soundbite, give it to us on, you know, what is the role of MDMA in therapy generally? And what should the public know about it?
Well, I think the public should know that it's not identical to what they've come to associate with ecstasy. So, you know, that, and the importance of set and setting. So even though it may have something in common with these, with a party drug, and that when it's used in a therapeutic setting, it's something that's quite different, and that it's not just the drug. It's really psychedelic assisted psychotherapy, or MDMA assisted psychotherapy, and that set and setting is key. You know, when it comes to public hysteria, I think we were a little unfair to Timothy Leary. He tends to get blamed for all the stigma against psychedelics, but really, Leary made some profound observations, and the importance of set and setting being one of them. So if there's one thing that I would want to communicate to the public, first of all, that these are not drugs that need to be villainized or that they should be scared of, even outside of a medical setting. But that within a medical setting, it's different than just having a doctor give you the drug and then you trip that way. That there's an entire apparatus around it that creates quite a different experience than what people might be familiar with from a non-medical setting. Even though, I think there's benefit for non-medical use. I don't think it should be something that's stigmatized. And I don't think we, in our rush to endorse medical use, I don't want to say, yes, I agree, non-medical use is bad, medical use is good. So I think, we want to advocate, first of all, for medical use for people who are suffering and whose suffering can be profoundly reduced through MDMA therapies. But I don't want to throw people who are using it non-medicinally under the bus.
So, and when we talk about, I mean, if we sort of take an optimistic view and think that this is going to be a road that we're going to go down, what are some of the things we should sort of have our eyes on, maybe in terms of, for instance, equity and access? Is this something that, different communities may have access to different ways? Is this something that we need to, are there equity issues we need to worry about as we move towards using it in this context?
I think absolutely. The burden of the war on drugs has been not been borne equitably across different intersection classes. So, we want to make sure that those who suffered from the war on drugs are also relieved of it. And one of the things that's concerning around psychedelic psychotherapy is as it's difficult to access, at the front of the line tend to be people with more cultural capital. And I think across healthcare, we have to pay more attention to equity, and this is no different. So I would hate to see it be a boutique type of thing, which is, perhaps the way it is developing in some ways, where people who can afford it or have the connections are the only ones who can access it. And, with underground therapy, that's kind of the way it is now. It may not be entirely socioeconomic in terms of who can access it, but it certainly is a sort of an elite opportunity. And I think we need to broaden that. And that's one of the things that I think is so hopeful about the kind of work that you guys are doing and the broader move to make this accessible. And, when we look at that, we have to keep costs at front and center. And when I say that, I mean, I think we have to look at the cost of the disorders and the potential cost of other treatments. So as we do research showing the potential for this, I think we want to speak in terms of health economics at the same time and say, how much does it cost for someone to be untreated with PTSD? And, even though acutely these therapies can be quite expensive because of the burden of having having therapists and trained professionals on call and people involved in preparation and integration. So it's heavy lifting during the therapy session, but I think it can be quite, I think you can make a good economic argument for it, given the reductions in the longer term costs. So I think it can have a place within our socialized medicine, and it doesn't have to be a boutique or elite option. And in fact, it mustn't be. But I think if we make our arguments appropriately, we can clearly make the cost that this is financially saving as well as reducing suffering.
Yeah, and I guess, I mean, we also know that trauma affects different groups differently, and all these mental health issues are not, equal opportunity here either. So it may be even, more important, obviously, to ensure that there's new accessible therapies. I wonder, when you look at the history of legalizing and maybe legalizing cannabis, but also just the kind of drugs we use right now for psychotherapy, whether there are kind of any lessons as we move towards MDMA therapy. Would there be anything that you say, okay, let's not do that again, or let's do that again, maybe?
I think we can learn a lot from the path that we took with cannabis. And as I said earlier, there's I think there was perhaps more stigma around cannabis, even though there's more familiarity and there's a lot of acute worry around psychedelics that people will have some kind of terrible accident when they use psychedelics. I think understanding the therapeutic potential and starting with more extreme cases, more severe suffering, and we see that with the psychedelic movement where we're looking at PTSD, at people who have often made sacrifices for the greater good and now are suffering due to the consequences of those sacrifices. So if you think of first responders or veterans, there's a lot of sympathy, rightly so, in the broader community, and people are very reluctant to argue with anything that might be helpful for those groups. And I think we can really move outward from there once we, have that sort of foot in the door towards asking, if these things are not so dangerous, then why can't they be more broadly accessible? I think about an analogy I make with cannabis that I think is, also apt for psychedelics is if we think about, humans' relationship with dogs. Dogs could be a nuisance. Dogs sometimes bite kids, and you might make an argument that dogs should be criminalized or regulated. And if you were to do so, I think the first people you would allow to have dogs would be people who required them because they are visually impaired. And then we might say, people who have mental health issues that can have a companion animal, maybe we should let those people have dogs. And then eventually you might just say, dogs aren't so bad after all, and everyone can enjoy having a pet and having a relationship with this other species. So in that way, the analogy might be better for things like psilocybin and cannabis that are species that have evolved alongside humans. But I think it applies to MDMA as well. Is once we make the more perhaps obvious argument that it's available for some people, we start to say, well, what about everyone else? Other people are suffering as well, and if their suffering can be alleviated through the use of these medicines, why are we prohibiting them? So I think that's maybe the path that we can use in communicating with the broader public who may not be as sympathetic or as familiar with these substances, and who may have understandably have some fears about them because there's been a very active program of misinformation. So no one should be really blamed for being scared of these substances. There's been the medical establishment and government have waged war on them. So I think it's understandable that we need to gently lead people back towards a more realistic understanding of the actual risks of these drugs and how do they compare to the risks of things we might be comfortable with, like, say, alcohol.
So I've got a couple more questions for you, and then I'm going to turn it over to some of the questions that have been posted in the chat. And I'm actually too blind to see the chat. So maybe what I'm going to do after, I will turn it over to Darek, and he'll sort of select some questions. But I would like to sort of draw on you're at the intersection of being a therapist and being an academic. And I wonder whether I could ask you some slightly more in the weeds questions about what would be some of the issues around designing a therapeutic program using these substances. Are there some issues that you've thought in terms of, training therapists, and would this be something that psychiatrists would be engaged in versus psychologists, and those sorts of sort of implementation issues? And is there any that jump out for you?
Well, with the regulation, and I don't expect, I like to be optimistic, but I don't expect that we're going to see full legalization or even dramatic liberalization of regulations right away. So I would expect that, given the pathway that we seem to be following, there'll be a period where they have to be prescribed by a physician. So I think we'll see, a physician, probably a psychiatrist on teams. But the way mental health is being delivered these days, it's not across the board, but many psychiatrists are not as hands-on when it comes to providing therapy. So often there'll have to be a social worker or a clinical psychologist who does the therapist, and I'm a clinical psychologist. So that might be a clinical psychologist or social worker doing the hands-on therapy, and a psychiatrist overseeing the medication as sort of a gatekeeper in that way. So what you get there is you have to have a couple people on the team. And I think ultimately, as we find our footing around the best practices, I think it's probably good to have a couple people working on the team, as long as it doesn't turn into a financial burden for the patients. And I think, you know, with socialized medicine, as I said, we can make a case that this is cost effective as well as being beneficial to patients. I think we have to make that argument. So I think the team will probably be some kind of a physician and also a mental health expert. You know, there's talk about whether or not we want to have sitters there as well. And I think that can be a way of reducing the burden, maybe on the therapist. So, you know, with the therapy model, and I think we'll get into this more detail later in the day. But, you know, there's a lot of downtime where there should be someone present and attentive, but it may not be someone who needs to have an elaborate skill set. You know, as long as the person with the more elaborate skill set is on call, we could have paraprofessionals trained to do the sitting, if that, and it depends on the volume, it depends on who's going to get, how many people are going to be referred for the treatment and what kind of resources there are. But at minimum, there has to be someone there during the entire session. And depending on your resources, you might want to get someone who doesn't have advanced training for that. I think there's so much interest in training psychedelic psychotherapists right now, something that I'm certainly interested in and working with teams on. And, you know, the discussions around that is one of the big issues, and one, you know, not to jump ahead in the questions, but I know one thing that people like to talk about is what kind of experience do therapists need to have with the psychedelics if they're going to be therapists. And I think for those of us within the community, there's really an emphasis to say, hey, we want to have therapists who have had the psychedelic experience themselves. And embedded in that is the question of, well, if these substances are still so regulated, how are we able to provide those experiences to therapists who want to administer them? And I think that's really a live issue that requires more discussion. You know, I think on its most of us, and I'm okay to out myself, most of us in this field have fairly extensive experience with diverse psychedelics, so it's not so much of an issue. But as we standardize that, I do wonder what constitutes a psychedelic experience. If you've had an experience with MDMA, or that you then qualified to administer psilocybin, if it's just psilocybin, can you then be an MDMA therapist? How much MDMA? If you've had one small dose session, is that enough? Do you have to have had a large dose? If you've only had a large dose session, do you know what a small dose session? I don't know the answers to these questions, but I think it draws on us to consider, what is it that we want therapists to know and why? And I think those are issues to be discussed. You know, in other interventions, certainly you don't have to have undergone the intervention in order to be able to provide it. So why do we think that people have to have had a psychedelic experience in order to be effective psychedelic psychotherapists? I don't know.
So just maybe before I yield the floor, then I just want to pull you back into the academic study of this a little bit and ask sort of what you think are the research questions that haven't been answered or that are being addressed right now that are the most urgent, or, you know, where is the research program on this going?
Well, you know, I think there's a couple pieces there. There's the one piece, which is, I think we still have some work to do in demonstrating the effectiveness of these therapies. So the initial findings have been really good, but we're still a little ways out from having a body of evidence that we can say this works for this group of people, and here's the ideal dose, and all the rest. So I think there's increasing specificity that will in turn increase confidence in regulators and physicians of how to use the medicine in terms of dose and indication. At a more basic level, I think we really want to know what are some of the mechanisms and how do we best support these therapies? What kind? There's so many different approaches to psychotherapy, which is going to be the best form of supportive psychotherapy. Is there's one that's more efficient than another. Psychedelic psychotherapy, in a way, was on ice from the 70s, when it was basically prohibited, until now. And some of the therapeutic approaches that are being brought back up are approaches that were prominent when the therapy was put on ice. So I think there's interest in some psychodynamic approaches. I don't know if those are going to carry over to contemporary psychedelic psychotherapy. And at the same time, there's been a lot of development in psychotherapy. I'm particularly interested in third stream behavior therapies like ACT and DBT, and how do we integrate those with psychedelic psychotherapy is of interest to me. But I'm staying agnostic. I don't think we know what is the best adjunctive therapy, or perhaps there are several adjunctive therapies that are equally useful, or maybe they differ according to indication or patient characteristics. So I think personalizing the therapy and understanding the range of things that we can do and what matches with what substance for what condition, I think there's a lot of questions to be answered there. And also from a basic perspective, what are the mechanisms? Some folks will tell you it's mystical experience. Others will say it's a profound new learning experience. If you're a brain-based person, you might say that it's about the default mode network. And I don't think that those are mutually exclusive. So I think there's a lot of places we can go with the research around mechanisms and around application.
That's really terrific. Thanks so much for that presentation. There's just so many questions right now that I think I better just yield over so that people get a chance to have their say.
Thanks, Neil.
That's great. So one question I have for you is FDA granted MDMA-assisted therapy breakthrough status, which is a very rare status. And essentially what breakthrough status means is that this therapy shows promise to be a better form of treatment for PTSD than anything else that is out there. So has anyone done actual sort of comparison research between MDMA-assisted therapy data and compared it to some existing therapies, and if so, what's the word on that?
Well, the effect sizes that we see from the MDMA trials are larger than what's required for FDA approval, as you say. So when they see these initial effect sizes, they say, wow, this should get breakthrough treatment. When we compare the effect sizes to existing therapies, I think it's tough to do the side-by-side comparison, because the people who are in most of the MDMA trials were treatment resistant. So these are people who typically had not been successful in prior therapies. So if it was a frontline therapy, we might see even stronger effects, but the effects are favorable, if not superior, to most other frontline treatments for PTSD. And when I say that, I mean behavioral therapies and also some of the pharmacotherapies that are out there. And when we talk about research down the road, that's really, I think, going to be, one of the powerful later steps, is if we're able to do comparative efficacy trials where, in one stream, people are getting psychedelic psychotherapy, and in another stream, people are getting, just exposure or just some kind of SSRI. And then we can say side by side, which is more effective. But there's a lot of complexities there because it is psychedelic assisted psychotherapy. There's so many components to it that I don't know what is the best comparison. Is it psychedelic assisted psychotherapy with placebo? In which case, I don't think that's a great comparison, because the whole therapy apparatus is predicated on having the psychedelic experience. So I don't know if you can just sort of sub in a placebo for the psychedelic and say, hey, we've done the test. So, compared to some other medications that don't have as profound an experiential component, those lend themselves well to placebo. I don't know if a placebo-controlled trial is the best way with psychedelics to see how it compares to other medications. But side by side, when we get into larger trials and have maybe matched groups, and then we can really do the foot race around which treatment is more effective. And even then, with clinical trials, often there's a short, relatively brief follow-up. So, we have to look over time, which is more effective. It could be that some of the more acute therapies are effective, immediately, whereas something like MDMA, the profound effects of a psychedelic experience may be more lasting. So what do we mean by effectiveness, and how do we measure it? But certainly that's the long answer. The short answer is psychedelic psychotherapies, MDMA, look very good compared to what we have now for PTSD.
Okay, thank you for that. And so we have a few questions here from the participants. One question, you might be able to answer that one, is when in the future or in current clinical trials, when people do MDMA-assisted psychotherapy, and what happens when they are currently on SSRIs, SNRIs, when they enter MDMA-assisted psychotherapy?
That's a really important point, and part of the reason why I think we want to have a psychiatrist involved in the team is to manage issues like that. There can be concerning interactions, and I don't want to get into those in too much detail. I don't think this is the best forum for it, but there can be acute interactions because they're both operating on the serotonergic system. So there can be those kind of acute medical concerns. What I think some of the signal from the MAPS MDMA studies was that folks and people were titrated off their SSRIs, I believe, before participating in those studies. But even after being titrated off SSRIs, I believe there may have been less positive effects because the titration may have not been complete. So certainly that is one drug-drug interaction that we want to be aware of, and that I think should be addressed on an individual basis with a provider. But definitely something to be aware of is SSRIs and psychedelics, because they're operating similarly. There's a chance acutely for some negative results, maybe even dangerous, but also a chance that the psychedelics will be less effective, and MDMA will be less effective amongst people who are using SSRIs. Just for pharmacological reasons.
Am I correct that in the current research by MAPS, the FDA approval PTSD research, that they wean people off SSRIs before they enter MDMA-assisted psychotherapy?
Yeah, I believe that that's the case, but that's not as straightforward as it might sound. I'm sure as a psychologist, you've seen many people who it takes, even though the official weaning may be a couple months or even a couple weeks, for some people it can take longer to get off entirely. So there's weaning, and then there's truly being off SSRIs.
Okay. And a related question here from Christian. Are there concerns around damage to serotonin receptors? Are there long-term follow-up studies to see longevity and benefits and possible negative consequences of the medicine?
Yeah, I mean, because they operate on the serotonergic system, that would be where you would focus if you were looking for that would be one place you'd focus if you were concerned about long-term consequences. And of course we are. Because of the novelty of the field, we haven't been able to look long-term at the consequences of MDMA. Most of the research that has looked at the more longer-term consequences of MDMA use have looked at it in an illicit setting, and in those cases it's very difficult to establish what exactly the person has used, what other substances they might have used, what was the composition of the supposed ecstasy that they are taking, whether it was MDMA or a mixture of MDMA and other things, and was it even pure. So I think we want to be careful extrapolating what we know from illicit use towards medical use. Having said that, the consequences there, well, whereas some research has reported negative consequences of long-term MDMA use, the risks, as I said earlier, don't seem super profound, even based on those biased analyses. And I say they're biased towards finding risk, because when you're looking at illicit drug use, you're more likely to include some of those risk factors that may not be relevant to medical use. But that is something that we'd want to keep an eye on with this therapy. Most of the individuals who would be candidates for this therapy, the consequence of continued suffering with the condition that they have are much more dire than the potential harms of the treatment. But with any kind of therapy, we always want to weigh those risks and benefits carefully. And I think the weight on the scale in terms of risks when it comes to MDMA, based on what we know, is acceptable compared to a lot of other medications that people take to address, PTSD and depression and anxiety.
Okay, that's great. There's a very interesting question here from Gordon. So I think this question is about the current landscape of integration therapy. So for people who use illegal substances, I understand that they can still enter integration therapy. The integration therapists are working within the harm reduction sort of paradigm. And the question is from Gordon is, can I, as a psychologist, attend a psychedelic therapy session in which the medicine has already been given without legal risk?
So as a therapist, can you address someone's past psychedelic use?
I think the way I understand this question is that Gordon is asking, if I understand correctly, he's asking if he could enter integration therapy, do MDMA himself, and then do integration therapy in that way. If you understand, Gordon, if you're there, if you want to clarify your question, but that's my understanding of this, without any legal risk. So obviously you're doing an illegal drug, so there is a legal risk from that. But the
therapist would be taking the drug during the session, or I'm not just not.
So let's just assume that it's somebody who would like to have an experience of the MDMA-assisted psychotherapy right now, but it's not available. Clinical trials are not available. But he, let's say he's a psychologist. He wants to try this form of therapy right now. How can he do it without any legal risk?
Well, if he's not, legal, I don't know what kind of legal consequences there would be for discussing psychedelic use with a client. I guess it might depend on how active a role the therapist takes in the procurement, and if and I guess any role in procuring the drug could be problematic legally. You might have regulatory risks with your body of psychologists, whether they would how they would feel about potentially seeing you as advocating that a client take it. That might be problematic with the and I see there's a comment here, if the client finds MDMA on their own and takes it, can the psychologist enter the space and sit with the client after the MDMA has been taken? Yeah, I mean, I think it's threading a bit of a needle, particularly with a regulatory body, and how you negotiate that space around how involved you are with directing and procuring the drug. Subsequent to people using a psychedelic, though, I don't imagine that there would be a problem discussing that use. As a therapist, we discuss all kinds of potentially prohibited behaviors that our clients would undergo. And then I think, when and yeah, and you might have policies around whether or not you see clients who are intoxicated, and what does that mean. You know, if you're seeing someone who's, you know, if you're working with problematic substance use, would you send a client home if they came intoxicated on alcohol? I suppose it would depend on how intoxicated they were. So I think that can be a personal policy that you would have. But if you're not involved in procuring or directing your client to access it, and again, check with your body. But I wouldn't see a problem discussing post hoc someone's experience.
So
In fact, part of the job.
So by the way, Gordon clarified that he was only interested in attending a session of MDMA-assisted psychotherapy to see how it works. That's all he asked for. So I guess the answer to that would be that I don't think you can answer. Can you add anything else to that?
Legally, I don't know what the crime would be. So I guess it would be a question of how the College of Psychologists in Manitoba would see that, as whether or not that's ethical or allowed.
Yeah. So so we'll just move on. We have 3 more minutes. Maybe I'll give you one more question. Zach, how's that?
Sounds great.
We chatted a little bit a couple of days ago. What do you think regulatory bodies, psychologists, psychiatrists, what can regulatory bodies be doing right now to prepare for this development?
Well, I think inviting, I think, conferences like this are terrific, and I hope there's people from regulatory bodies here, because, as I said, there's been a program of misinformation, a very active program of misinformation around these substances. So I think one of the first things that regulatory bodies should be doing is orienting themselves to this burgeoning field, because it's going to be coming across their desk sooner or later. So hopefully they're getting ahead of the game. And I know we do see that in BC, at least. A lot of the health, the regulatory bodies have been quite positive. I know Vancouver Island Health Authority has been working with therapists to understand this issue. I think there's communications more broadly with Health Canada. So I'm hoping that, some of the lessons learned from cannabis and the broader, what I hope is sort of an end to the war on drugs and some of that stigma, is leading to an openness, and I just hope the regulatory bodies will be open to these new modalities and recognize their potential, and try to assess them the way they would other interventions, without prejudice, and with a focus on putting the patient first and on the potential to alleviate some suffering, because that's what the bodies are there for.
Great. Zachary, thank you so much for agreeing to be with us today. We really appreciate it, man.
Yeah, it's been a real pleasure. It's been great. Glad to be back in Winnipeg, even if it's only virtually. And
right, you're from Winnipeg originally, right?
Yeah. Oh yeah.
We're gonna drag you back here to actually speak to some live people when we can do that again, now, if you're willing. So
anytime.
Sweet, thank you, Zach. So we're gonna have Anne Wagner soon. Anne, are you there? I see. Yes, she's there. There you go. So can you switch me? There we go. So Anne Wagner, Anne Wagner has a place. She's a psychologist. She has a place in Toronto called Remedy, and it's a. Could you put me on?
Sorry.
Could you put me on?
Yes, you're on. You're on the screen right now.
Oh yeah, good. And so Remedy, a place in Toronto, is a mental health innovation place, and Anne also does research at the university, and she's been involved in quite a bit of MDMA-assisted therapy research. And what I would like to say here is that one of the mandates of our institute here, Enhanced Therapy Institute, is to support research around MDMA-assisted psychotherapy for relationships. And Anne Wagner has been a leading researcher in MDMA-assisted therapy for relationships. So what I did maybe like a month ago or something like that, I set up through MAPS Canada a fundraiser for this very important study that Anne is currently setting up and getting ready for. It's a study that Anne can tell you more about. What I would like to tell you about is that I set up this link, we put it on our website, and we have donated. However, I didn't have any time preparing this conference to promote this fundraiser. And this is the only fundraiser we are doing. We're doing a fundraiser for Anne Wagner's upcoming research. So I would encourage you, if you are interested in seeing relationship therapy move forward in terms of approvals, in terms of research for us to find out whether it's effective and all that, and whether it's safe, then you could go to enhancedtherapy.ca. On our website, there's a direct link to donate through MAPS Canada to Anne Wagner's study. She's doing amazing work, and now we're going to hear from Anne Wagner.
Thanks so much, Darek. It's so great to be here. And what I'm going to do is I'm going to share some slides to help us orient ourselves as I'm chatting. And we're so grateful that there's interest in this work, and are so super grateful for the fundraiser as well. So I can share what that would be going towards, but contextualizing it in the work we've done so far. So I'll pull up my slides here. Okay. So what I'm going to be talking about today is MDMA-assisted relationship therapy, therapeutic roots and current research. And so I'm going to acknowledge that, so as Darek mentioned, I'm with Remedy, which is in Toronto, and I'm also affiliated with Ryerson University. And the work that I've been doing has been either sponsored or funded by MAPS and funded by MAPS Canada. So when we're thinking about expanding the use of MDMA in therapy, we see that relationships are fundamental in our worlds. And that's really the case if they're present, if they're absent, if they're supportive, if they're stressful, any way that they exist or don't exist, they impact us in how we relate to the world and how we function in it. And MDMA's empathogenic qualities make it really a nice fit when we're thinking about doing relationship-based work. So specifically around the fostering of tolerance and accepting of emotions, the ability to support communication between people, and supporting feelings of connection. And that can happen for both the people within the relationship as well as with the therapist. So therefore, we really think it's potentially a powerful tool to work with within relationships. And we're definitely not the first people to be thinking about this. There has been a long history of use in couples therapy, predominantly above ground when it was legal to use it prior to its scheduling. So it was used as an adjunct to psychotherapy until 1985, and it was predominantly used for relationship distress, PTSD, anxiety, as well as couples concerns. So early reports of use in couples therapy, or specifically with Anne Shulgin, was using it immediately after it was resynthesized by Sasha Shulgin in therapy context. And so Anne was really a pioneer in its use with relationships. As well as George Greer and Requia Tolbert. So they were using MDMA in couples therapy prior to legalization. And the reason I've highlighted them here is that these two groups have talked about it and written about it, that you can access some of these early writings, which are fantastic. And so really when we're thinking about how can MDMA be useful for relationships, there's a number of different ways. So I'm going to highlight some of the psychological effects here. I'm not going to go deeply into neurobiology or any of the hormonal or neurotransmitter effects, but I'm going to really focus on the psychological components. So firstly, it can enhance acceptance of self and others and increase a sense of empathy. We used to think that was because there was such a high oxytocin release with MDMA, but we realize it's actually not just the oxytocin. There's many different factors that are increasing that sense of empathy and relatedness between folks when they're taking MDMA together. And there's a tolerance of emotionally upsetting material that can happen when people take MDMA, and the ability to address this upsetting material without extreme disorientation. And that's very, very important when we're thinking about a therapeutic setting where people are either going to be talking to each other, working through things, and wanting to stay with, as opposed to turn away from some of the material that might be coming up. There's this idea, and I'm putting some quotes because I'm still working on how I want to talk about this, but this idea of ease of cognition, so that you can get to the end of a line of thought, get to your conclusion about it very quickly and very easily. There's not the same stuckness, there's not the same challenge around that can happen. So that provides an opportunity in that moment to express how you actually feel, and that can be ambivalence about something. That's really can be useful. And there's also a decentering or changed relationships to thoughts and memories that can happen with MDMA. And as well, there's an increased openness to experience. And that can be really central, especially when people are going into and talking about things in their relationships that they would not necessarily want to in other contexts, that they're open to what they might receive coming back. And so there's some possible therapeutic mechanisms of action, and that means this idea of how we think they're working psychotherapeutically that have been proposed. And so I'm just going to highlight a few here that I think are interesting. One is this idea of a reduction in experiential avoidance. And so the idea that you're not going to, as I mentioned, turn away from difficult sensations, emotions as they're coming up. There's also this idea about the reduction in arousal. And so it puts you in an optimal window of tolerance, so you can sit with things that are challenging or difficult. There's also the theory around the relaxed beliefs under psychedelics, and this is the rebus model, and this idea being that you're less attached to the prior belief that you may have had before. It becomes less connected in your mind. And then there's also the idea that you can, the mechanism action might be around acceptance. So accepting, embodying, and connecting with yourself and with others. So when we're thinking about this relationship-based work with psychedelics and MDMA in particular, these are some of the things we're holding in mind that are helping guide, but also the data starting to inform which of these theories can help us explain what's going on. So when we think about the use of it right now, and so the work that we've been doing has been specifically for PTSD, using couples therapy for PTSD with MDMA. So I'm just going to highlight briefly why we would want to do couples therapy for PTSD, because sometimes it doesn't seem like a natural fit. So the first is that the individual and those surrounding them are impacted by trauma. It doesn't occur in a vacuum, right? We don't live as purely individuals. We're living within families, within systems, within communities. And so the impact of the trauma or PTSD will impact people around that person as well. And so when we're treating the aftermath of trauma in the context of our relationships, it has strong potential power, not just for the person with PTSD, but also for their loved ones. And that approaching the healing of trauma as a system can have wider reaching and potentially longer lasting effects. And so we think about that as not necessarily only holding this individualistic frame, but going in a broader context of healing as well. And some of the mechanisms of action that we're thinking about when we're thinking about specifically healing trauma include the idea that we want to have non-avoidance. So we want to have people approaching things and experiencing things from their emotions, from their behaviors, somatically, all of those components. That we work with meaning making, which can tie into this idea of cognitive flexibility, if you've ever heard that term before. But the idea is you're trying to make sense of what's happened and bring it into your everyday in a way that doesn't feel stuck and isn't rooted necessarily in the past. And so you're able to work with that in a more flexible manner. And the idea that we want to enhance the relationship. So there's longitudinal studies with trauma that show over time that with less negative social support, so meaning less challenging interactions, less interactions that are disheartening or non-supportive, then there's less PTSD over time. But then over time, PTSD can erode social support. So really you want to get in there and be able to support people to maintain the relationships that are positive and supportive throughout the course of their healing from trauma, and that can have really positive effects. So what we've done is combined a type of psychotherapy called CBCT. That's a short form for cognitive behavioral conjoint therapy, which is a couples treatment for PTSD with MDMA. And the idea behind this was to create a safe and mutually understood framework for the couple to be using to do the PTSD MDMA work together. And what CBCT really focuses on at the beginning is providing skills and tools, and especially for a couple that's trying to communicate together through not only a psychedelic session, but also through talking about trauma. That can be extremely important to create a safe environment. And we allow for whatever experience comes up in the MDMA sessions. I sometimes get asked, like, why would we use a cognitive behavioral treatment with a psychedelic or MDMA? And what I want to highlight is that that's really when we're thinking about the frame or the base work that we're doing in terms of preparation and integration of the MDMA sessions. And especially I find for couples that can be really helpful to have a shared language. And it's always the experience of the individual or the couple that is populating what the content is of that frame. And so it's not this prescriptive didactic thing that people sometimes associate with a protocol-based treatment, but rather provides this safe place to tether to so people can dive even further into the MDMA experience, and we allow for whatever comes up during that. And then they integrate the MDMA sessions using the skills and tools that they've learned through the CBCT. And we're creating a scaffold to tether the experiences to. So CBCT consists of 3 phases. The first is psychoeducation and safety building, and that's for within the relationship psychoed about PTSD, how it's impacting the relationship, how it shows up in their lives, and then moves into phase 2, which is relationship enhancement and reducing avoidance. And so here we're doing a lot of communication skills. This is super fundamental in terms of being able to do that work and trying to notice the things that the couple is avoiding and start to put those back into life. And then phase 3, we move into challenging thoughts. And those are really that meaning-making component of working through the different perspectives and ideas that have gotten stuck since the trauma. And so with this study, what we did is we had 6 dyads who participated. So this is really a pilot study, and we're really grateful to have been able to have the opportunity to run it, and the idea that it's really just sowing the seeds for what we hope is to come. And that would be a much larger study that would demonstrate this on a grander scale. So for our 6 dyads, one partner had PTSD. And we actually were open to recruitment. It didn't have to be a romantic dyad. It could be any 2 people who wanted to do this work together, and because they were closely associated with one another. But it just so happened that it ended up being all romantic couples, which does tend to be who wants to do dyadic work together. And then both participants received the MDMA, and that's really important. We had both people, even though only one person had PTSD, both received the MDMA. In the first session, they had 2 MDMA sessions. The first session, they received 75 milligrams with an optional supplemental half dose at 1.5 hours. And in the second session, they all went up. They had the option of staying at 75 or going up to 100, and I believe everyone went up to 100. And then they also had an optional supplemental half dose there. And when we're looking at our outcomes of the study, which we call our primary and secondary outcomes, we were really focused on three things. We looked at others, but I'm going to focus on these here today. So the first was PTSD symptoms. So what happened with that from the perspective of an independent rater. So someone who is not their therapist, but someone who is using what we call the CAPS, which is a clinician administered PTSD scale. Then also from the perspective of the person with PTSD and their partner. And that's really important that we encourage this your own evaluation of what's going on for you, and for the partner to also be understanding and seeing what's happening there. And then we also had a measure of relationship satisfaction, and that was what we considered a really important outcome as well. So when we look at what it actually looked like over the course of the treatment, this is what we call our protocol flow for the study. So the stars, the yellow things, are the assessment time points. And so we had assessments at baseline, mid-treatment, at primary endpoint, which was 1 month after their last therapy session, at 3 months follow-up and 6 months follow-up. So we're wanting to make sure we're tracking them over time. And how it looked is we would do 2 prep visits, and that was really when we're doing informed consent and we're starting to talk about just logistically what that's going to look like. Then we did in-person CBCT. The days of in-person, how I wish that was a possibility right now. We had in-person CBCT. So we were together for an intensive day. And that day, normally CBCT is 15 sessions, usually spread weekly. And so we did the equivalent of 3 sessions of CBCT in one day, the day before their first MDMA session. So then that next day, we did a little bit of CBCT in the morning, and then we had the MDMA session. And once we started the MDMA session, we weren't giving any of the content of CBCT anymore. It was using it as the prep to go into the MDMA session. Then the next morning after the MDMA session, we did integration, which was just talking about the experiences that came up, anything that we wanted to make sure we wanted to highlight going forward. And then over the next 3 weeks, we did 4 telehealth sessions of CBCT. This is before the days of COVID. We did that logistically because we all didn't live in the same place. And so I was going back and forth between South Carolina, where we ran the study, and Toronto, where I live. And so we would do those 4 sessions, which were really our integration sessions, but we're using CBCT as the integration. Then we did another day of in-person CBCT before the second MDMA session, integration next morning, and then finished out with 4 telehealth sessions. So just as a snapshot, what does an MDMA session look like for a couple? We really emphasized maximizing time spent inside. So meaning internal in the experience, and folks were given eye shades, headphones. We used the classic model that has been described in early LSD psychotherapy, early other models of trying to keep the experience inwards. And we had a music playlist that we would use. And then, of course, as much as we were maximizing that, there would be many periods of time where the partners would be conversing together or with us as the therapist. There's always 2 therapists in the room, but we don't hold to the model that some folks have used previously, where it had to be male-female therapist dyad. We had same gender dyads as well. So we learned how to coordinate conversation between the partners, which was an interesting kind of dance between that, wanting to make sure that both partners felt ready to have a conversation and not necessarily always gearing it towards, for example, when the partner with PTSD was ready, oftentimes their partner would be, really eager to hear what they had to say. And we would encourage that wanted both people to have a fulsome experience in the internal world. And we allowed for whatever cognitive, emotional, somatic, so meaning in the body experience would arise. And we were really supporting non-avoidance, so moving towards embodied and experiential learning. So having the direct experience of something in that moment. And this is the therapy room where we did the study. So you're in the perspective of the therapist chair right here. And then the dyads would sit in those chairs, and they're recliners. So they had the opportunity to lie back or to sit up, and they could swivel, and they're close enough that they're able to hold hands. And then if they needed support from us as the therapists to be closer with them, we had these little camp chairs that we would bring and we would sit beside them. So some results from that pilot. So what we found was, this is the PTSD outcome. So I'll orient you to what's going on for folks who aren't so familiar with statistics. I'll walk you through this. So the CAPS-5, that's the clinician independent rater measure. So that means someone external that doesn't have a horse in the race, right? They're not the ones who were the therapists. They're not gunning for something. They're independently rating this. So pre-treatment, that's the score that folks had, the mean before treatment, and this is post-treatment. And what that indicates to us is the vast majority, so actually 5 of the 6 people with PTSD did not have PTSD anymore at the end of the treatment. And this effect size over here, Hedges G, is the pre to 6 month follow-up, and anything over 0.8 is actually considered a very large effect size. So over 2 is an enormous effect size. And then this is the patient rating. And so there was a huge drop in the patient rating of their own PTSD symptoms and a massive effect size there. And then the partner as well. You can see that all of these post-treatments are quite in line with each other, and a massive effect size there for the partner. And then when we flip to relationship satisfaction scores, so this, I'm not showing you full results. I'm showing you results here from this one item measure that we would give at every time we saw them. And so that one item is here. On the scale below, please circle the number that best indicates the degree of happiness, all things considered, of your relationship in the past week. And 0 is extremely unhappy, to 6 being perfect, and 3 is the threshold for happy. And so I'm very skeptical when anyone answers that things are 6 perfect in their relationship. That makes me wonder, because there's never anything that's perfect. What we want, or what we're kind of hoping for, is that people will be 3 or higher, right? So happy, very happy, extremely happy. And so before treatment, folks were not quite happy on average. So some folks were in the unhappy range. That wasn't a requirement to be in the study. They didn't have to be distressed, which I think is important too. And then post-treatment, on average, the mean was people were in the happy range, and actually moving to very happy. And that was maintained as 6 month follow-up, which I think is really important. And then for the partner, it continued to grow from there. And with the full results, with the full measure, that holds as well. And so we see our effect sizes are really large there too. So what does this mean? So with safety, we had no serious adverse events in that study. Granted, 6 couples, right? So take it with a grain of salt, but good starting point. We had no dropout. It was feasible, and we did it in condensed delivery. So what normally takes people about 4 months to get through CBCT, we did in about 8 weeks for folks. And compared to outcomes to other CBCT studies, so this is effect sizes. So they're slightly different. So D versus G just is based on the number of people in the study. But you can essentially compare them. The CAPS range for other CBCT studies are generally from 1.09 to 1.82 is the highest, and we were at G of 2.24. So far, it's looking higher than other CBCT on its own without MDMA. We see that same for the patient and the partner ratings. And then compared to other MDMA studies, we're actually seeing so far stronger results than we've seen for other studies. That does not mean that that's going to be the case overall, but we think that's really interesting that we're with this protocol model plus the MDMA, we are seeing equivalent, if not stronger results than we would see with the inner-directed supportive model that you would see with other MDMA studies. So I know we're almost at time for questions. I have just my last thoughts here with this idea of combining these approaches together, it really, for me, illuminates the possibilities moving forward of this dyadic framework for relational healing. And we're able to demonstrate with clinical and non-clinical participants that this is safe and effective. And I think that's really important. So that means that it's people not just with PTSD who are able to take MDMA and have good therapeutic impact. And so my hope is in the future, that's going to open the doorway to the broader use of MDMA and psychedelics in the realm of healing and growth and beyond psychiatric diagnoses as well. So what we're looking at next, and this is a thank you to my team here, Candace Monson, Michael Mithofer, Annie Mithofer, who are my co-investigators on that pilot study, as well as the whole MAPS team. We're going to be doing we have our next pilot study is one of cognitive processing therapy, which is an individual treatment for PTSD plus MDMA, but then moving into a large trial of CBCT plus MDMA, which we're really excited for. And we're also have just started in the works, getting ready. Hopefully, we'll see if we'll get approval for this on a grander scale to do a study of just couples therapy. So not for PTSD with MDMA. So that's the hope. So thanks. I'll stop my screen share and turn it over because I think it's time for questions, right?
Yeah, that's wonderful. That's great. So first of all, before we go into questions, I just want to mention to everyone that we're going to post a couple of polls right now. Is that how we pronounce it? Polls? And one of them will be about where you're from, and the other one will be about your profession. Just so we get a little bit of an idea about who's in the audience. Thank you for doing that. I'm just going to put this down here. All right. And thank you so much. That was wonderful. So a very, very promising study so far, a small sample size, 6 couples, but a very promising results. And the effect sizes, again, for those who don't know statistics, effect sizes are independent of how big the sample is. So the bigger the sample, the more stable the effect size is. So you still want a big sample so that you know that the effect size is stable. But these effect sizes that Anne is showing are an indication of a pretty strong effect that this therapy has so far. And I just wanted to remind everybody that I'd like to encourage you to donate to Anne's upcoming relationship study that she's setting up, and that study will contribute to the future medical legalization of this therapy if it goes as well as it's going so far. A couple of questions for you, Anne. One question is, there's this interesting phenomenon that we see with MAPS PTSD study that after the MAPS, I'm talking about the FDA approval, the large multi-site research that is going on right now, that MAPS is doing. Right after the therapy, when they measure PTSD, 1/3 approximately of people don't have PTSD anymore. Now, if they measure the same people, they don't do any more therapy after that. And when they measure the same people a year later, 2/3 of people don't have PTSD. So there is a very interesting and so far consistent effect that the initial gains that you have shortly after therapy, a few weeks after therapy, actually increase as time passes. And you are showing a little bit of those results, especially in relationship satisfaction. You just showed that there is a little bit of that further increase. Would you like to talk a little bit more about this phenomenon and what do we understand about this phenomenon?
Absolutely. Yeah. I think it's a really interesting one, because that to me is actually one of the most important things when we're thinking about psychedelic assisted psychotherapies and the power of integration afterwards, is that it's an evolving process. And so I often am talking to folks when they're finishing a treatment for, you know, the active component of a treatment, that's just your starting point, right? That's the idea is it's hopefully creating a new baseline that you continue to grow from. And so we actually see that phenomenon in a lot of evidence-based treatments for PTSD, is that your result right after the treatment can continue to improve if you're continuing to engage with the tools, skills, learnings that you've had. And so when we're seeing that with MDMA assisted work, I really think it's the same phenomenon that's happening, and that it continues to unfold over time. So, you know, Annie and Michael Mithofer, who are the ones who've been running the phase 2 studies and are colleagues and mentors of mine, and they'll often talk about that really we have to trust the unfolding process of medicine. And, you know, when you're in the middle of an MDMA therapy experience, I really want to emphasize that it doesn't feel good, right? Most people are really in the depths of moving through and sitting with really, really challenging experiences. And that's still quite fresh at the end of therapy, right? Like that period of time when it's just finishing. And so that can continue to make sense, to ease, to improve over time as we go forward. And so what we would see with some of our folks when we would do our follow-up calls, like at 6 months later, is they talk about this experience of they'd be feeling well, and then, you know, something would come up in life, which inevitably it will, like, you know, there'll be a reminder, a stressor, an anniversary of a traumatic event, something will happen, and they may go back in for a little bit. They may have another wave of experience or more memory that comes up, or filling in or of something that they have remembered. And what they'll notice is that they'll have the experience, but they'll move through it in a different way, and they'll come out the other side and go, oh, interesting, I didn't stay there in the same way that I had before. And so that tends to reflect then the ebbs and flows of life that we're all going to go through, that we're all going to have these ups and downs. It's not going to be the steady, you know, or linear path to happiness that's continually ever going up, right? We're going to have ebbs and flows. And so what I notice is that people continue getting better because they navigate the things that are coming up in their life in a different way.
That's great, thank you. And another comparison, again, your study is a small sample size, 6 couples. Mm-hmm. Did you look at and remind? I missed it. Did you have 2 or 3 dosing sessions?
We had 2 dosing sessions.
2 dosing, so it's a little bit harder to compare.
Yeah.
But I wonder whether it's possible, whether you have some sort of an indication of effect sizes between a couples conjoined therapy, where you have couples, versus MAPS individual PTSD studies.
Yeah. So that last slide that I showed with some of the comparison. So compared to other MDMA studies, the pooled sample size or the pooled effect size, I should say, for all the phase 2 studies. So those are the ones that are not ongoing right now, the ones that have been completed. So that includes 6 different studies that happened at different sites. Their pooled effect size was 0.8. And our effect size is over 2 for that study. However, some of the individual studies had very high effect sizes. So one of the kind of seminal phase 2 studies had a 2.8 effect size, and that's one of Annie and Michael's original studies. So yeah, we're seeing a range of like from the pooled effect size of 0.8 to 2.8, and ours is at like 2.28. So we're upper end of the studies. Yes. So far. Yeah. I mean, hard to compare given we've got, you know, teeny sample size.
That's wonderful.
Yeah.
Okay. There's a lot of specific questions about that are not directly related to your presentation. I can ask them to you in a second. Perhaps could you speak about what do you consider to be the most important ethical issues around MDMA-assisted psychotherapy? What should we be thinking about in terms of safety, in terms of ethics?
Wow, that's a big question. I think there's a lot to consider with that. I think, well, as we move to a place of a potential legalization, which I think is so exciting, and we're kind of on the brink of that we can see, and I apologize for the sound in the background there, we got a doorbell, but that I can see one of the most important issues being the equitable access to care. I really think that's going to be a massive one. So, you know, we're thinking about that a lot at Remedy, and we're thinking about that in terms of who's going to be able to access this. Who are we testing these treatments with, right? And a lot of the samples, you know, by virtue of who it's being, you know, not who, but where it's being run, and the therapists who are currently trained to do this treatment. Therefore, it's gearing the samples towards, you know, white middle class folks who it's just like, we don't know, we can't make larger claims of effectiveness beyond that. So I think one of the really important things we need to be thinking about is diversity of providers, diversity of folks who are participating in the studies, and therefore the equitable access to care in all the different ways when it goes forward. So.
Great. How about one more question? I understand that you participated in MDMA-assisted psychotherapy training, and that you used MDMA as a part of the training. Would you feel comfortable telling us about the first-hand experience of being on MDMA and being in the therapeutic context on MDMA?
Sure, yeah, I'd be glad to. So I had the opportunity in 2014 to participate in a study in the US which was for therapists. So it was an FDA approved, DEA approved study for therapists who are going to be working on these MDMA assisted trials to have their own therapeutic experience as part of their training. And actually it was a very strategic move. And I've talked to Rick Doblin about this a number of times, going, you know, that was the reason why I started doing this work. And so, and I've openly shared this before, like I had never touched a psychedelic prior to that. And so I had no idea what no prior reference point for that experience. And and so the way it was set up is I had one MDMA session and one placebo session. And it was, I have to say, the most educational experience for me, and probably the most important therapeutic experience that I've ever had. And, you know, as someone who's deeply engaged in my own work, that felt incredibly promising as a tool. And as I felt so fortunate and lucky that thankfully I don't have PTSD. So to have the opportunity to have that experience was fundamental, really, in me pursuing this work. And so I'm really hopeful that we'll be able to do that going forward. There is a protocol that's under FDA review at the moment, and I think it's DEA review right now, that hopefully will increase access to that for other therapists who are going through the training. However, we'll see what gets approved, but my hope is that will be available and accessible. Mm-hmm.
Well, thank you for sharing this, and thank you for your presentation. And that's great. We're really honored to have you here, and hopefully we'll see you in person one day after
Absolutely.
This COVID situation calms down a little bit.
Absolutely. Thanks so much for having me.
Thank you. So we will have Bruce. We will have Bruce Sanguin. How do you pronounce this name? Sanguin. Bruce Sanguin coming up, and Bruce is a psychotherapist. Is a marriage and family therapy psychotherapist. He lives on Denman Island, and Bruce has written 7 books, and has a kind of I understand, a little bit of a colorful history. And I invited Bruce. You know, Bruce, I don't know you very much, but I heard you speak at one of the conferences,
Hmm.
And you spoke so beautifully about love, the
Hmm.
healing power of love, then that it really touched me. And I told my wife, and I said we need to invite this guy to the conference.
Ah,
So here he is, Bruce Sanguin.
thank you. It's thank you for this opportunity. It's a real honor. And thank you, Anne, for your presentation. I learned a whole bunch about from your words. So I'm not coming at this primarily as a scientist today, but as a clinician who works with psychedelics, including MDMA. And I do this in the context of harm reduction. And I have great respect for those of you who are scientists and are doing the necessary research. Thank you. I need to also say that I don't procure the medicine, nor do I administer it, but I employ it as a tool in the context of ongoing work with both individuals and with couples. I thought it would make a nice adjunct to Anne's presentation to actually get sort of down and dirty and personal, and instead of use a story of one of my clients, that I'd start with my own story in the experience of MDMA in the context of my marriage. So it had been a recurring frustration in our marriage that my wife wanted more connection with me. And I was a bit frustrated by this because I thought of myself as this sort of sensitive therapist, prided myself on being a sensitive male, and it wounded my image of myself as such a wonderful partner. And when my wife would make bids for connection, and despite my best efforts and intentions, I would find myself eventually getting angry, and I might go on the attack. But underneath all that, there was a feeling of inadequacy. Somehow, despite doing my very best, I was always coming up short. And I started to take it very personally. I wasn't enough, ever, is how I felt. And she seemed to exist to point this out over and over again. And she became the one in my mind who was the source of my suffering, at least from the point of view of my trauma self. This is how I interpret it. So we take MDMA, and I'm determined to listen to her and not be reactive, and to stay out of my own narcissistic tendencies to make this all about me. And then the medicine comes on strong. And she, once again, very, with equanimity, lays out what's going on for her. And to my surprise, I feel deep empathy for what it's like to be her. I see her frustration with me. I feel compassion, and then the coin drops and the words come out of my mouth. Oh, you just want more of me. And with a look of relief, she says to me, yes. So unexpectedly, I hear this as new information, not as a personal attack. It's not about my inadequacy. It's not about me at all. In fact, my beloved finds me so compelling, she actually wants more of me. And then I say something like, how lucky am I that you, this beautiful, radiant person, want more of me. And then I wanted to know how I could make her life more beautiful. Now, to say the least, this was a change in the dynamic around this particular issue. And so if I was to talk about, this bears out a lot of what Anne was saying in terms of the impact of, potential impact of MDMA, of how MDMA helped me in that situation in the context of my relationship. And everything I've stated is borne out in my experience in my work with other couples as well. So I would say, first of all, that my default defense system, that is, I am inadequate and therefore must compensate by always being adequate or being seen as adequate. And if I'm not seen as adequate, watch out, that's my defense system, was suspended long enough for me to put it colloquially, take my head out of my butt. Second, my heart opened and I saw and felt her. In other words, I escaped the narcissistic ego looping of making this all about me. And there was also a fundamental shift in this experience from self-loathing to self-love or self-compassion. And for me, I see this a lot with this medicine and other medicine, that this is often the pivot point of healing. We have these deep, unconscious feelings of self-loathing that were set up early in life through experiences of failures of love. And when this shifts from into self-compassion for that little one who is so hurt, healing begins to happen. So in this situation, I saw myself not as an unworthy human being, not inadequate, but as a desirable human being who this woman wanted more of. And then the question comes up, and to address sort of the tag theme of this, the ethics of altered state disclosure and bonding, it's true that I was altered, but I didn't, as a result of that, disclose anything that I didn't want to. And I think there's perhaps a common misperception that this medicine or any psychedelic hijacks or overpowers the mind. And I can assure you that I was in my right mind. The medicine helped me, if you like, to be in another mind, which I would call the heart mind, which is closer to my true nature. And it was a great relief for me, and my experience of clients is it's a great relief for them to experience in and through the medicine this more essential aspect of myself getting some airtime. In fact, when I'm in the mind of my ego, which can be called the false self, the performative self, the trauma self, then I'm actually out of my mind in my normal orientation. And yet it's from this trauma mind, in my experience, that most of our social institutions are set up and function, and from which we run our own personal lives. So these medicines have the potential of tearing back the veil and revealing the truth about this. They are potentially then, and hopefully, disruptive. And just as an aside, this is why I have some concern about the corporatization of these medicines, with pharmaceutical companies, patenting their special synthesis of molecules for purposes which potentially are directly opposed to this subversive potential, and that is to help us function more creatively, optimally within a dysfunctional system, to be yet another biohack to increase our efficiency as citizens of a capitalist system that's not always working. So end of rant, but this experience of when I'm in the medicine actually being in my right mind, and rather than out of my mind, I think is an important perspective to hold when it comes to the use of these medicines. And the word psychedelic, as you know, means soul revealing. When we're speaking from that soul, just call it the depths of our being, from the truth of what's actually happening. We are actually in our right mind. And it's a huge relief. So these medicines put nothing in our minds that is not already there. They reveal what's there. A correlated question is, can you trust the heightened bonding that comes online with these medicines? And I think Anne's research bears this out. It's my experience as well. But first off, don't underestimate the power of our own minds to override these medicines, even high-dose psychedelics. I've been with clients on 600 micrograms of LSD who are quite able to stay, quote unquote, in their right mind. That is what I would call their defended mind. But the closeness and the bonding I felt with my wife on this medicine was absolutely real. And it revealed the true depth of my love. And MDMA didn't cause it or engineer it. It just opened up. It made it safe for me to be able to express it. And then the question which Anne also addressed in her research is, does it last? I mean, did this heightened bond last between my wife and I? Did I feel afterwards, in the words of the REM classic, oh no, I've said too much? As if the medicine made me say something that I didn't actually want to. And I would say for me and for clients I've been with, is absolutely not. On the other hand, the gig was up. I now had to take responsibility for those feelings of inadequacy, which long predated my marriage, and for finding a new way of orienting in the world. So it's clear in my experience that these medicines are not quick fixes, even if they can be powerfully transformative. My experience is that when you utilize these medicines, it's typically the beginning of a new journey of healing, and certainly not the end. Because the model that I hold is that our hearts are broken in and through relationship. And very early on, we construct a personality to ensure that our hearts are never broken again. And while that serves us in terms of helping us survive childhood, in adult life, it undermines our capacity to be more open to life. But what happens over time is we confuse this construction of a personality with our true nature, which is that we came into the world to love, to connect. So the medicine can reveal this, but the work has just begun. And that, to be specific, is the work of dismantling the defense system that was put in place to protect us, and which we confused with who we are. In other words, we identify with a system of protection rather than our deeper nature. So one of the fundamental principles that the medicine has actually revealed to me is that our hearts are broken in the context of a relationship, and therefore it's only in the context of a relationship that they're healed. Which is to say, MDMA doesn't heal. LSD doesn't heal. Psilocybin doesn't heal. They reveal. The healing comes through, and I would say this always is the case, the healing comes through a relationship. It can be a professional one, or it can be in the context of our intimate relationships, in which we learn that it's okay to relax in the presence of an other and realize that this person is not out to hurt us, to regain the quality of trust, and to learn to breathe deeply so that life in all of its fullness can return to us. So, which is to say that these kinds of experiences with whatever medicine need to be followed up with integration work. And so for me personally, that meant looking at a lot of shadow stuff. Where did I learn that I wasn't enough? To recognize that because of these early failures of love, I drew premature conclusions, but intelligent conclusions about who I was. You could just call these unconscious beliefs that got set down really early. And I call these core unconscious beliefs, like, I'm bad, I'm not worthy of love, I don't belong, your misery is my fault, I'm inadequate. So, in other words, these peak experiences on MDMA or psychedelic are not typically magically transformative, although they can be very powerful. And I would say that their value therapeutically is precisely that they can reveal the ways in which our hearts were broken and how we're reenacting trauma in our adult relationships and in the context of intimate relationships. And then to take responsibility for that, for our woundedness. And I think these journeys with medicines like this are heroic in the sense that we're making a decision that the trauma ends with us. I am not going to reenact the trauma on my wife or my husband or my children. It ends here, it stops here. I'm going to do the work it takes so that the violence that's come down through me and landed in me through generations of my own ancestry and that lineage is going to stop. I take responsibility for that. And these medicines are powerful aids in that. We haven't talked about at all, at least I haven't addressed the spiritual value of how these medicines can open us up to other dimensions of reality that are lost to us in our materialist, modernist culture. But this potential of seeing through the thin veil of these cultural values that are steeped in materialism is very powerful. That to discover that the mystery that is living this universe and others is love itself, and therefore our intimate relationships have the potential of actually manifesting this deeper reality. And I think that's sort of this love has a ontological reality, in that what we're all seeking in some sense in and through our intimate relationships is the realization of this love that is living the whole thing. And I think these kinds of spiritual experiences also can be incredibly transformative in the way they can contextualize how we're imagining what intimate relationships are about. And To just address, I have a couple of minutes left, but in terms of the question of like the ethics of using these medicines, like I would say that what's critical, I'm glad you asked Anne about her own experience on these medicines, because I think it's critical that if we're going to be employing these medicines as therapists, it's critical that we have the experience of them ourselves. That, excuse me, that we accept the invitation to the deep potential of them to do our own journeying so that we heal our own wounds. Because if we're using these medicines and we're unaware of our own blocks to intimacy, we will be unconsciously limiting where our clients can go with these medicines, because it will bring up anxiety in us. So I think ethically, I would encourage, I mean, this seems obvious, but the therapists be doing their own work with this medicine and be willing, sort of like in the shamanic tradition, to go to the depths of their own suffering, their own sorrow, their own blocks and obstacles to their own expressions of intimacy, what's getting in the way, so that we'll get out of the way of our own clients. So I think I'll stop there and be happy to answer any questions that people might have.
Thanks so much, Bruce. Thank you for such a beautiful personal explanation of this experience and what it did to you. We have titled your presentation Ethics of Altered State Disclosure and Bonding. And so the claim you made is that it is not an altered state, but more of a it was more of a revelatory state for you, that you were closer to who you truly are. And you mentioned the word psychedelic means soul or mind revealing. I wonder whether you could talk just a little bit more about that, about this not being as much an altered state as it experientially bringing you closer to yourself. What was in the way? What actually, how do you know, what happened that you had this revelation? You want more of me.
Yeah, I mean, it was just like one of those intuitive things. I just saw clearly what it was my wife was asking for me. It was like, boom, it was right there, like kind of like, dummy, she just wants more of you. She like, and everything in me just wanted to make her life more beautiful. It's like, how can we do that? Okay. So I want to be clear that, I mean, I did feel altered, but it was altered in the sense of, I was out of one mind. That is my normal waking consciousness, which, and aspects of that are my defended mind. So, I mean, I did feel altered, but I felt like in that quote unquote altered state, I was more truly myself. I was seeing things more clearly the way they were. And I mean, what was clear is the way I'm seeing reality is through a trauma self. Normally is through my experiences of the ways in which this mind that I constructed to defend myself against the deeper truths of intimacy and what's actually going on was in the way of me seeing more deeply. So that's the work of kind of deconstructing, or, you know, in my book, it's called Dismantled. And so the dismantling was aided by these medicines.
So I'm really fascinated by this idea of sort of these drugs taking us back to ourselves. I wonder, when you think about more broadly your experience as a therapist, maybe you have to speculate a little bit when it comes to this, but for people who are not neurotypical, or who have, existing mental conditions, or mental illnesses, maybe people are chronically depressed and so on, I wonder if you have any thoughts about, as far as a therapist, aiding that kind of inner journey, whether there's some special challenges there, or maybe some special potentials for people who are, again, not neurotypical, or who are suffering from mental illnesses, and what you think the approach should be.
Yeah, I mean, I think that the psychotherapeutic process in different modalities can be helpful with or without the medicines, and the medicines are enhancers or catalysts or amplifiers of what's there. So it's a great tool, but I think ultimately, as I said in my presentation, that it's the relationship that breaks our hearts, and it's relationship as well through which healing happens. And it just might take a longer period of time without these medicines for that to happen. But in my experience, when people discover that it's possible to trust that another human being is there to support and resource rather than hurt, and that healing can begin to happen, and that might take place over longer periods of time. So I'm not making the claim that healing can't happen without these medicines. I don't know if that's addressing your issues or your question, but yeah.
We had, I think, a really fascinating question about boundaries, and whether there are any concerns when we start to move towards thinking about sort of some of the ethical issues that these raise. I think that if one problem that relationships have that seem to be, what you had a good experience with, is when people are feeling disconnected. But there may also be relationship situations where people are fighting to self-define, or to define boundaries within their relationship. And I wonder what kind of could be the role for MDMA in those kinds of relationships.
Yeah, beautiful. And, like I put this in the context of, in the therapeutic process and the healing process, we have to find our yes and our no. And it's as important to find our no, that is our boundaries of, like, as you said, the capacity to be self-defined is critical, because unless there are two individuals who have the courage to set up polarity with their individuated selves, then the bond is not real. And what in effect happens is that there's enmeshment, not actual relationship. So relationship, intimacy, is only possible when there are two self-defined individuals who are willing to have the courage to state and claim and be in their individuality. So I've seen lots of experiences where one or the other, in the context of MDMA therapy, had to make a strong claim of where their boundaries were, of what they weren't willing to tolerate, of where they weren't willing to go, and to stand in that. And in my experience, that creates the potential for a genuine polarity. And in the presence of polarity, relationship is possible and vitality is possible. So this can enhance the yes, and this can enhance the no. Just because one of the things that goes offline because of early trauma is our no goes offline. We discover that we're helpless and powerless to be ourselves because that self is either punished or humiliated. And so the recovery of that individual self requires the establishment of clear boundaries. So it's a great question.
And I also wonder, when we're looking at relationships, I mean, we easily jump to thinking about romantic relationships. But of course, that's only one of the many relationships we have. We have family relationships, we have friendship relationships. And so, MDMA can create this intense bond. I wonder if it has a role in helping us understand or address issues in other kinds of relationships.
Yeah. In my book, there's a whole chapter on family. And, again, in my personal experience, what it did was that it helped me to sort of a radical individuation from my own family of origin, where I saw the truth of what was going on, and I was willing to claim it, and therefore invite others into a relationship based on, the truth of what I had seen. And that was very disruptive for my family. But for anybody who was in my family who was willing to respect what I had seen, for me it was primarily through ayahuasca ceremonies, then I was happy to have a renewed kind of relationship and renegotiate that. But I wasn't willing to reenact this false unity that was expected as one of the rules of engaging in my family of origin. So that's a small example.
It's interesting you mentioned ayahuasca, because one of the things that also has struck me about the therapeutic context is that, one of the therapeutic modalities that's had a lot of success is group therapy. And there certainly are, I take it most ayahuasca use is in a kind of group setting. Mm-hmm. And I wonder if there are lessons that we can take away when we look at MDMA and other drugs, whether there are, ways we could structure a therapeutic relationship in a group setting, or whether you think that has promise, or whether you think there's dangers there.
No, I think it has great promise to in a group setting to work with this medicine, and then do a series of integration sessions afterwards, because you don't want to be on a weekly basis doing MDMA. It's just too hard on the system. But set up, 3 months apart or 4 or 5 months apart, and then intervening sessions, I think would be very powerful. A lot of potential there. The thing about doing in the context of group is that, especially with ayahuasca, what tends to happen is that you become so porous to the energetic qualities of everybody else who's participating that it becomes a challenge, but an important learning to distinguish between what is yours and what is coming from the person on the mat beside you. So there's some work that needs to be done around, again, establishing boundaries, seeing what belongs to you, what belongs to this other person, choosing how to be with that. So there are particular challenges when our consciousness broadens out and can tap into the consciousness and be influenced by the consciousness of 20 other people in the room. But that can also be grist for the mill in terms of helping us to see where our boundaries were leaky growing up, for example. And yeah.
Somebody asked about integration issues, and it sounds like you had a good experience, but it was also sort of far along your journey in a certain way. And whether you think that this is, whether therapists need to think about how far along in their own personal journeys their clients are before this becomes appropriate. I mean, is this something that you can sort of say right off the bat, this is, that this is something we can use? Or is it something that when you're screening clients, you want to say, well, you're looking for certain kind of levels of progress before you go to this therapy?
I think it's less of an issue with MDMA in my experience, but when you start into high dose psilocybin or LSD, the primary criteria for screening, and it is important to screen, is whether or not the client might just use this opportunity to release responsibility for life. And it happens that if the client has an empowering sense of life is too much, there's too much responsibility, I'm carrying too much, there can be an opportunity in and through the use of these medicines to escape that responsibility. You could escape into insanity. You could literally escape into just various ways of removing yourself from the equation because it's too much. So you need to be very careful in assessing whether or not this client is looking for an out.
That's great, Bruce. So maybe a final question would be, people are asking about your book, the title of your book, and would you be able perhaps to type it in
Sure.
in the chat?
Here we go.
Any other final comments? I'd suggest that we take 5 minutes off, everybody, to stretch a little bit, and we will be back in 5 minutes. But before we do that, any final comments from you, Bruce?
No, I'm just really honored to be sharing this opportunity with all of you. Thank you all for being here. And this is a very exciting renaissance that we're undergoing. And so I just love the opportunity of being with you all. So thanks so much.
And so are so are we. Thank you so much, Bruce.
I'll write the title of my book in the chat room.
In the chat.
It's called Dismantled.
Dismantled.
Yeah.
Bruce Sanguin.
Yeah.
Excellent. So let's take 5 minutes. We'll put a poll, another poll on right now for you guys if you wanna do that, and we will be back in 5 minutes.
So we're off?
Mm-mm. Okay, we're ready. Hi, Mark. Mark is still muted. Oh, there we go.
Okay.
So here.
Hello, Darek.
Hello, Mark. I'm very excited for this presentation.
Yeah.
Mark Haden is the executive director of MAPS Canada, and Mark is going to speak about the Canadian landscape, the future of MDMA-assisted psychotherapy in Canada, how it might unfold. I just want to say that both MAPS USA and MAPS Canada has been extremely supportive towards us when we were organizing this conference. And we are very grateful about that. And here I give you Mark Haden.
So Darek, I'd like to share my screen and walk through my PowerPoint slides relatively quickly to allow for a fair amount of discussion. My understanding is I have like 20 minutes to present and 20 minutes for discussion. Is that true?
20 minutes to present, 15 minutes for discussion. If you need it, if not, we can take another little break. It's
okay. Well, let's see. I'll rattle through my slides fairly quickly and then hopefully have a spirited discussion. But let me share my screen. Actually, let me do something else first here. Let's see if that works. So Bruce, do you see a single slide? Hello?
I think I can see your slide.
You see a single slide, yes.
Thomas, is this good? Is Mark?
Yeah, we have the small screen in the corner.
You have a small screen in the corner and a single slide in the middle.
Okay.
No, further.
Okay, I'll go with this then.
Yeah, I think it's working well.
Okay,
yeah,
perfect.
I think it's good from my point of view.
Okay, let me see if I can get rid of this. Okay, so here we go. Here is my welcome slide that is in all languages, which I really appreciate. I want to talk about the word that we use. We use the word psychedelic intentionally. We had options. Psychomimetic means like psychosis. Hallucinogen means creating visions. Empathogen means increasing empathy. And entheogen means manifesting of the spirit. Psychedelic is the most accurate. It means manifesting of the mind, and it's also the most neutral. The first two being negatively weighted and the last two being positively weighted. So the word is chosen intentionally, and I'm pleased to find that most researchers are using that word. There has, as you know, been a complete explosion of interest in psychedelics, and here are the universities that have now have major psychedelic that are publishing in the world of psychedelics. In fact, this side, as I notice, is slightly outdated. I should have UBC on there because Zach Walsh is recently doing a psychedelic survey that we will publish. So this is my legitimizing slide. This is the world of academics has stepped up to the plate and looking very closely at psychedelics. If you go to clinicaltrials.gov, where major trials are listed, you can see an explosion of interest as well. When I searched for the word psychedelic in this, I found 298. And it had gone up when 289 when I initially searched for this, and it had gone up to 298 in February of 2020 of this year. When I searched for the word psilocybin, there were 39 studies, and that had gone up again in February to 43. When I searched for the word MDMA, it was 76, and it had gone up to 79. And when I looked for the word LSD, it was 96, and it had gone up to 100. Another way of looking at that is the Web of Science. When they search for the word psychedelic over the years, it has gone up dramatically. So there is an explosion of academic interest, there's an explosion of research publications. Here's a slide from the FDA in the United States, bridging the past, present, and future of psychedelic drug research and development, because as you know, the FDA has to approve the psychedelic work that's being done with MAPS USA, and so they're internally educating themselves around this process. The DEA, the Department of Veterans Affairs, the Department of Veterans Affairs in the United States is also interested, and here's a cover of one of their magazines saying that they need to look at psychedelics. So it's amazing how many people are stepping up to the plate and looking at this. If I was going to choose a date for the beginning of the psychedelic renaissance, it would be when this particular article was published in 2010. The New York Times announced that hallucinogens have doctors tuning in again. And this was really the first major newspaper that I was aware of that favorably reported on the psychedelic renaissance. As the years have gone by, here's one in 2012 from the New York Times. Here's the New York Times again, Can Mushrooms Treat Depression? And in Canada, we were legitimized, I think, most poignantly in October of 2015, when the Canadian Medical Association Journal chose to put the psychedelic renaissance on their front cover. In terms of popular press, Michael Pollan, a very good book. When anybody asked me, how do I...
Mark.
Yes.
Sorry to interrupt. We have some comments that I can see your slides well, but some people say that your slides need to move a little bit over because they are covered by your other smaller slides. Perhaps you can move it to the left. Is that correct?
Let me try something different. Is that better?
Yes.
Ah, yes. Okay. Thank you. I have two screens and I was sharing the wrong screen. Okay. Thank you. Here is the best book to start with, which is Michael Pollan's book. Popular press has also been interested. Here's the Goop show on Netflix, where they are airing a show about psychedelics, and I think they did a fairly good job. There's an amazing film out there called Dosed. I would track it down and watch it because it really tracks the psychedelic healing experience very thoroughly. And they got lucky. The filmmakers got lucky. They found a woman who had a heroin addiction, and they were able to follow her healing journey through her whole process. And it's a remarkably accurate description of psychedelic healing because it's complicated. You know, it was not a magic pill. It really, you really get to see the complexity of the healing process. Fox News, curious enough, has also given us a fair shake because we are, in the American perspective, actually healing veterans, and Fox News has stepped up to the plate and supported what we do, which is quite something, actually. I'm constantly surprised by the number of people who want to look at what we do. Psychedelics are broken into three categories. I'm going to just go through this really quickly. LSD, mescaline, psilocybin, and DMT, which are the classical ones. The empathogens or entactogens that offer connection to self, MDMA, MDA, and 3-MMC. And then everything else, which includes ibogaine, ketamine, 2CB, and salvia. I like this particular study, partly because of the title. The efficacy, tolerability, and safety of serotonergic psychedelics for the management of mood, anxiety, and substance use disorder, a systematic review of systematic reviews. I smile every time I read that title. And so this is a very deep dive into trying to understand the literature, and the conclusion is very simple. Psychedelics are effective in the treatment of a variety of mental health disorders. LSD is to the study of the mind what the telescope is to astronomy and the microscope is to biology. Stanislaw Grof said that a while ago, and it still resonates true today. I want to just go through some of the MDMA process that we've been involved with. The MDMA study started with Michael and Annie Mithofer's publication of this particular research, where they demonstrate an 83% level of effectiveness with chronic persistent PTSD. That led to a stage 2 clinical trial, and the publication of that data is this. So the analysis of that data shows that the comparator dose was 23% effective. The 2-month follow-up after 2 sessions of MDMA showed a 55% level of effectiveness. The 2-month follow-up of 3 sessions of MDMA showed a 61% level of effectiveness. And much to my surprise, later, when they went back at long-term follow-up, the effectiveness had gone up again to 67.8%. So the healing continued in spite of the fact that people were no longer actively engaged with treatment. Some of the lessons learned from phase 2: the cause of PTSD is irrelevant. Many causes can be healed. Low doses, like 25 to 40 milligrams, can enhance blinding, but they can have an anti-therapeutic effect. A small stimulation effect does not work in terms of therapy. It is a safe process that's been clearly demonstrated, and a medium to large effect size on the CAP scale was demonstrated. It's also interesting is MDMA is not associated, or the effectiveness of MDMA treatments is not associated with a mystical experience. That's unique in that the work with psilocybin shows that the higher the mystical experience rating, the MEQ, mystical experience questionnaire, the higher scores on that are associated with greater positive outcomes in the treatment effects. That is not true for MDMA. So people don't tend to have spiritual experiences on MDMA. They have healing experiences. As you probably know, the FDA granted breakthrough status for MDMA-assisted psychotherapy for PTSD. And we have moved on to our phase 3 process. Here's a slide that kind of describes it, where people will have 3 dosages, 80 to 120 milligrams. And 9 sessions of integrative work and 3 sessions of prep work. There's going to be many phase 3 site locations. Here's a list of some of them, including Vancouver, Canada. Here's the European sites. So it's a multinational study that is happening. I got a very excited phone call from Rick Doblin when they unblinded the phase 3 data and the FDA looked at it and saw that they could continue on the process. I hadn't realized what a big process this was until Rick actually explained it to me. And what he said is there are many companies that get to this stage and they unblind their data and it doesn't allow them to move forward. And here's an example where this company, Tonic, spent millions, $100 million was spent with a medicine for PTSD. And when they unblinded their data, they did not let them move forward because the signal to noise ratio just simply wasn't effective enough. So we're in the process of legalizing MDMA. It will be legalized in both Canada and the United States. The Americans are ahead of us because they have this thing called the right to try legislation, and we have a problem here because we can't do that. It's specifically blocked in Canada. But we intend to be, or MAPS with us will be licensing and training therapists and selling MDMA to facilities across Canada. I predict will be an access problem due to costs that we're talking about already. That's one of our studies. We're working with an eating disorder study, which is, we believe that eating disorders can be healed with MDMA-assisted psychotherapy. The roots of eating disorders being trauma, body dysmorphia, family conflict, and anxiety, and society's view of people's bodies. We believe that we can heal 4 of those 5 things, and we have 3 sites, Toronto, Vancouver, and Denver, Colorado. And the goal is to increase the size of the off-label window. The more indications we can prove that it has been effective for, the more it will be used widely in therapy. That's one study that we're supporting. Another one is Anne Wagner's work that I believe is talking at this event. So I'll only briefly mention that she has a number of different tracks, and we're very supportive of Anne. We think that, that what she is offering is fabulous. And she's doing something unique, which is offering MDMA in the context of couples, where one couple has PTSD, but both members of the couple receive MDMA. That's never happened. Nobody without a diagnosis has received a psychedelic in the context of research. I was very excited to get an email a while ago from the provincial government asking me to participate in a discussion with them around how to integrate psychedelics into the healthcare system provincially. That was a wow for me. I was absolutely pumped. So we've started that discussion. So one of the things that I'm aware of is provincial governments need to understand psychedelics through the lens of a cost analysis. So I did my own analysis. My life partner, is a psychiatrist, and I asked her, how much does it cost? And she works in the traditional healthcare system. She works in Vancouver for Vancouver Coastal Health. And I asked her just to give me some numbers as to how much time it costs to do traditional psychoanalysis, medication management in the context of her job in a community health center. And then I looked at the hours that are involved with our research. The MDMA treatment protocol is very exact and specific about how many people are involved and how many hours and what credentialing is required. So it's very easy to come up with that number. There are 2 therapists there. So then I looked at psychedelic therapy with 1 therapist, and then I said, what would happen if we offered these in groups? And I came up with some very specific numbers, and this is the slide that I intend to take to the provincial government to persuade them that psychedelic psychotherapy is incredibly cost effective. It was interesting, as I was doing this work, MAPS USA also published an article doing a deep dive into the same question, is this cost effective? This article is now available, and they came up with a resounding yes, it is cost effective. Some of the other projects that we're working on in the context of MAPS Canada is I met an individual who was microdosing and managing his symptoms of schizophrenia with microdosing LSD or psilocybin. That was completely counterintuitive to me because all of the belief systems about the relationship between schizophrenia and psychedelics basically say psychedelics are destabilizing. And this particular individual found that large dosages were destabilizing, but small dosages were actually incredibly helpful. So I wrote up I was so intrigued with his story, I wrote it up and it's on our website, anybody can go and read it. And his trauma history and his history with schizophrenia and his exploration of psychedelics is now available in detail for anybody to read. And there is some evidence to say that he is not alone. Here was a study that basically looked at it was published in 1958, and it looked at a social group in a psychiatric institution where schizophrenics were given a low dose of LSD and they functioned better when they had that experience. So I'd like to know if anybody else on the planet is having his experience. And so we published a survey, it's on our website. Please, anybody can go and look at it and respond. So it's widely available. And it looks at a number of things, but one of the tracks of the survey is major mental health disorders. And so people can report, what psychedelic they're using and the effect that it's had on a major mental health disorder. It has some other tracks as well. If you say, no, you don't have a major mental health disorder, it asks you questions about how psychedelics should be available. So it's available for anybody, but specifically, I'm encouraging people who would like to talk to us about a major mental health disorder and their experience they're having with psychedelics. I'd be really interested. I'd like to look at a slide, an image that was produced as a result of this particular study. And the image is very popular, and it's this one. And many people have seen it. And it really looks about how psychedelics increase connections in the brain. Now, this image is useful, and it's also problematic. It's useful because to some extent it helps us to understand why healing occurs in the context of psychedelic psychotherapy, but it's also problematic because it gives people an illusion that they don't have to be involved with the process. It's a bit like taking your car to the mechanic. Psychedelics will just rewire your brain if you take them, and then you're fixed. And that actually is an indication that people actually won't do well in the healing process if they have that belief system. So I think we really need to take a hard look at this image. It's very, very popular and out there, and explore whether it's helpful for us or not. Another project that I have is I've just published a manual, actually just a few days ago, on actually how you do psychedelic psychotherapy. It's got a lot of detail. It's actually, no, it's how you do psychedelic guiding. It's not how you do psychedelic psychotherapy. It's how it is good to be with people when they're on an experience of a psychedelic. And nobody's ever actually made that available to people. So I thought I would fill a knowledge gap. And it's now on Amazon. It's cheap. Anybody can go buy it in either Kindle or paperback form. And here's just an image of my partner. Her name is Brigitte, and myself sitting with a guy that I hired from the gym because he had big tattoos. And just to kind of show the process, you know, it's about lying down, eye shades on, headphones on, in a beautiful environment with a huge amount of support from people around them. So there's a lot in this image. It's a crafted image, but I use it to help me discuss what it's like. We are going to integrate psychedelics in the healthcare system, and I'm just talking, as I said, I'm talking to the government, the provincial government, how you do that. And how could we place that? How can we place psychedelics within our context? And there's some questions that I'm asking here. Here's a paper that I wrote on how psychedelics should be regulated, and you can go and read it. And I think it's helpful in the discussion. I won't go through the details here. Just acknowledging that the FDA is disputing some issues with MAPS USA. Should MDMA experiences be allowed for therapists is one question. The credentialing of the people providing the service, and does there need to be an on-site physician? Those are all things that that are important, both in terms of cost effectiveness or in terms of people's ability to have an experience. The goal is to train thousands of people, and how we're going to do that, I'm not sure yet, but it's going to be a long and complicated process as we walk forward on this path. The future of psychedelics, treatment of addictions, treatment of mental health concerns, spirituality, and enhancing connections. I'm just in the process of reading this book, and I'm really enjoying it. Love Drugs, The Chemical Future of Relationships. And I think it's bringing some new information to me, and I'm thoroughly enjoying the read. This is our goal, to open psychedelic therapy clinics, and this is what they're going to look like, at least in urban settings. And for those who say that's way too urban for me, we'll also open clinics in rural settings. One does not discover new lands without consenting to lose sight of the shore for a long time. And the saddest aspect of life now is that science gathers knowledge faster than society gathers wisdom. Thank you.
This start the video. I can start something, yeah. Thank you, Mark.
Thank you, Darek.
I'm unmuted. Yeah. Okay. Yeah. Great. So that was great. So perhaps I'm feedbacking on you, Mark. Do you have headphones or I'm okay. I'm good now. All right. So my understanding is that I just want, if it's possible, if you could talk about American, USA context and Canadian context in right now and in the near future. Yes. And specifically, I understand that MAPS Canada, if this is approved, that MAPS Canada, MAPS USA will have a 5-year exclusivity period to provide training and to distribute MDMA because they've done all of the research. What is the situation in this respect in Canada?
So you've really asked two questions there, I think.
Okay.
So the first question is, what's the difference between MAPS Canada and MAPS USA? And what is the relevance for the window of exclusivity before the generics can come in and compete? I think that's what you've asked. So let's look at the two. So one of the differences between MAPS USA and MAPS Canada is we have a problem, I call it the Schedule J problem. Drugs are controlled in Canada through two mechanisms. One is the Controlled Drugs and Substances Act, the CDSA, and the other is the Food and Drug Act regulations. And in the Food and Drug Act regulations, there is a schedule. It's Schedule J. And it was a sort of a leftover from the Harper administration, who didn't like the idea that heroin would be available. And they lumped a bunch of drugs in there that said they won't be available on special access. And initially it was about heroin, but they also lumped the psychedelics in there. So it means we can't access psychedelics through that process, where the Americans can. They call it, I think it's called compassionate access or special access, where during a phase 3 study, the right to try legislation in the United States allows someone to a group, not an individual, a group to apply to receive the service. So if somebody's halfway through a phase 3 study and it's proving to be effective, they can ask to be treated outside of the research protocol. And the Americans are already doing that. So it's exciting what's happening in the United States. We don't have that option because we're blocked because psychedelics are on this Schedule J. So we're working with our federal government to try and access it through that, and they're being receptive. So we're having positive discussions with them, but they haven't actually changed the problem yet. So that was one part of your question. The other part of your question is the generics, and will the generics come in? So I have to, at this point, gaze in my crystal ball. But yes, a sponsor, that's a technical term, the organization that puts all the money into developing a drug, turning a molecule into a medicine, has the right, because they've spent so many millions, to control how the rollout happens, and the generics can't compete with them for. It's different between Canada and the United States, actually. It's 5 years and 7 years, but I'm not exactly sure of the exact length of time. But the period, there's a window where they get to roll out as they choose. Essentially, the sponsor gets to dictate the terms of the rollout. So that's what MAPS USA will be doing. They'll be training therapists and licensing therapists, and that service will be widely available in both Canada and the United States. And they'll have that 5-year window to essentially establish a brand, and then other organizations, other drug companies will be able to sell MDMA after the generic window closes.
Okay, that's excellent. Okay, and so you mentioned the question of credentials and the question of the on-site physician.
Yes.
And we should probably mention, Mark, that to everybody here, not to confuse people, this is not a race to sell drugs, because first of all, MDMA-assisted psychotherapy, you have 1, 2, maybe 3 administration of MDMA. So there is no money in MDMA. It's the whole package. It's MDMA-assisted psychotherapy. So pharmaceutical companies are not really super interested in MDMA because it can't be used on a regular basis. It doesn't work that way. And we should mention that. Now, going back to the question of credentials, and there is, as you say, a discussion between MAPS USA and FDA about who the therapist should be, and I understand that FDA is pushing a little bit for higher credentials, and that MAPS, for the reasons of access and equity and cost, is asking for for training therapists that are not PhDs and not MDs.
Yeah.
Could you tell me whether what are the developments in that area with FDA and MAPS, and whether these developments will directly affect Canadian situation?
So let's start with the last question first. We don't know the answer to that. Specifically, we don't know what Health Canada will say. So this is a discussion that's going on between the FDA and MAPS USA. So we don't know to what extent that will apply in Canada. The issue is that there wasn't a requirement for an MD or a PhD to be part of the protocol, the rollout, the research. And so MAPS USA wanted to kind of maintain the same level of credentialing. And the FDA was saying, no, when you legalize it, you need to either have a medical doctor or a PhD as one of the co-therapists in the team, because there's two therapists, male and female mostly. And so the cost of that raises the cost significantly, you know, and MAPS USA has done a brilliant job of looking at because they've had so many documented CAP scores of a whole variety of different teams with different levels of credentialing. They can actually show very clearly that higher credentials do not produce better outcomes. You know, they have that data. And so they're sharing that data with the FDA, and one hopes that they would be responsive to the data, but we don't know. They haven't come up with a response yet.
Okay, great. So another question, the people are asking about what can both the regulatory bodies, what should the regulatory bodies be doing right now? And also individually, what if you're a psychologist, a nurse, a counselor, a psychiatrist, what can you do, and what should you be doing? And can you do anything right now?
So again, there's two questions there. So what are the regulatory bodies? Now, I'm not exactly sure which regulatory bodies you're referring to. Are you talking about the College of Physicians?
Like the College of Physicians, the College of Psychologists, the College of Nurse.
Thank you. Okay, thank you. That's helpful. I think really looking at the research is important. Essentially, what I observed is physicians were not engaged in the process of the legalization of cannabis. And the regulatory bodies that saw that became antagonistic to that process. And that was, quite frankly, I think a mistake on the part of how cannabis was legalized. So we're doing it differently. We're actually reaching out to physicians and other regulatory bodies and basically sharing the research and sharing the knowledge and doing a lot of presentations and really engaging them in a process as much as we possibly can. So the process now is just information sharing and really being up to speed so that as people start to engage in this work, it won't be a surprise because it's coming down the pipe, and it's coming fairly quickly. And so there needs to be a process of education. You know, I think we also need to look at, you know, ethics. How does this work? You know, what is the process? What's going to go wrong? You know, the regulatory authorities will get complaints. I can already guarantee you them. And I can also tell you what kind of complaints they'll get, you know, because some of the problems that we will face have already manifested, you know, and I think psychedelics offer huge opportunities for us, and they also offer risks. And just, I'll be clear and precise. So there's a huge level of bonding that happens between the therapist and the subject. And that's very helpful. You know, the bonding process is really, really useful. And then there's what I call the over-bonding problem. And to be honest with you, it happened in our research. It happened in our phase 2 study. And it was quite public. You know, we posted the details, and there's been a lot of discussion about that. So we need to learn the lessons of what happens when things go wrong and why they go wrong. And so colleges essentially need to understand the healing potential and how to do this work, but also have an understanding of some of the problems that are going to happen, completely predictable problems that will happen that we need to have responses to. It doesn't mean the services don't work, but it just means they need to be managed carefully to maximize the benefits and minimize the harms.
Okay, that's great. And speaking about professional regulatory bodies, we have here with us Alan Slasky, who is the executive director of my psychological association. And he's asking whether you could share the PowerPoint with, would you be able to type that information in the chat, in the general chat, so people can get access to your PowerPoint?
Yes, I have a principle here, and the principle is I always share any PowerPoint I've ever given. So all my PowerPoints are available, like throughout history. You can have access to all of them. And I always share them, and I share them not PDF'd. And anybody can use them for any purpose. They're just free. You just take them and you use them any way you want. But I make one request. And the request is, if you are going to use my PowerPoints, which you're welcome to do, please, when somebody asks you for your PowerPoints, you also say yes, and you share them un-PDF'd. So yeah, why don't I send you, I'll put them in a Dropbox and I'll send them to you, and then you're welcome to share them any way you want.
Oh, that way. Okay, so if that's, you don't have an online link to that, then you could share it to me, and Alan, I can send you the PowerPoint later. There's a very good question here, Mark, which perhaps will give you an opportunity to explain the structure of MAPS, because I find that a very interesting and very, very good topic. So the question is, why would MAPS have a monopoly on training for 5 years? Is there any other reason other than financial reason?
Well, they've spent, I'm not sure how much they spent. Yeah, 30 million is the rollout costs. 30 something, that millions and millions of dollars is what it's cost. And Rick, it's taken about 30 years. So the sponsor of the study, the company that has spent that many millions, has the right to receive the income stream from it. And Rick Doblin and myself are hugely devoted to fundraising. And quite frankly, it'd be really nice to actually have an income stream to feed into future research to continue to grow. And so doing less fundraising and actually having an income makes complete sense, especially if you spent that amount of money. But there's more to it than that, because they've worked incredibly hard at trying to understand how to train therapists. And so if you want it to be done skillfully, if you want to do it well, you need to take all of their experience over the last few decades and manifest that before you have other companies that have no experience or very, very limited experience with training therapists. If you want to do it well, you have to build on the huge history that has happened, because as I said before, things are going to go wrong. And so we really want to manage this to maximize the benefits and minimize the harms. And learning the lessons from history that MAPS USA has brought and MAPS Canada has brought would be helpful.
Yeah, that's a wonderful answer, Mark. And I just want to add to that answer that as far as I understand, I am not a part of MAPS or MAPS Canada. I'm not associated with MAPS or MAPS Canada. However, I understand that, and that might be helpful to those people who don't know about it, that the structure of MAPS is unique as well. It's a non-profit organization on the one hand, and a pharmaceutical company on the other hand, which is called MAPS Public Benefit Corporation. Yeah. However, all the profits, it's called Public Benefit Corporation for a reason. And all the profits that go from the pharmaceutical company are channeled directly back into the nonprofit with the mandate of just public wellness, essentially. Do you want to add anything to that?
Yes. So the structure of a public benefit corporation is different than the structure of a normal corporation. So a normal corporation is responsible to its shareholders for maximizing profit. The structure of a public benefit corporation is responsible to its shareholders for maximizing public benefit. That's different.
Okay. So I think we'll, if you have any other questions.
Yeah, I just wonder, Mark, then just to wrap up, whether you could just, I mean, so I'm coming to this as an ethicist. I've sort of got my eye on the landscape, and I'm actually very impressed seeing your presentation, how far along the medical research and the empirical research is, and whether whether you think there are some ethical issues that need more research, whether there's a research program there for ethics.
Well, it's interesting. In my psychedelic manual that I've just published, I decided to identify the problems that I will anticipate. And, you know, I talked about 4 problems, and essentially who shouldn't be a psychedelic psychotherapist. And I talked about, you can go in and get the details, but just one example that I talked about before is the overbonding problem. You know, if there aren't clear boundaries, we have a problem. And we had that in our research, and, you know, we were very public about it. But there are actually 4 problems, and I think it'd be interesting. Go in and read my manual and find the section of who shouldn't be a psychedelic psychotherapist and why they shouldn't be. And I think it's controversial, you know, but it's also something I think our whole community needs to talk about, because some of the problems that we're going to face have already manifested, and I think it's just going to grow unless we, and part of the solution to these problems is actually discussion. And so I think there is a place for ethics, and certainly I've identified some issues in my book.
Well, thanks so much. That's really terrific. So, thank you, Mark. And yeah, we should just say, so Mark will make his slides available to us, and then all you have to do is get in touch with us, with Darek, through the Enhanced Therapy website. There's contact information, and we'll be happy to share those slides on, and we will of course just remind you of the condition that you also be willing to share slides in a non-PDF format, meaning in a format where the images can be used and the text can be used for furthering the understanding of that Mark has offered us.
Yes.
So thank you. So.
Thank you, Mark.
So our next speaker, I think she's ready. She looks ready. Is Julie Holland. She is a psychiatrist and don't make me say this word, psychopharmacologist. She's written a couple of best-selling books, Moody Bitches and Weekends at Bellevue. And she's also the editor of a couple of nonprofit books on ecstasy and on pot, a complete guide to each of those. And then she has a new book, which we can plug for her. It's called Good Chemistry, The Science of Connection from Soul to Psychedelics. So I'm sure you can all find a place to find that. And we're really, really thrilled to have such a prolific author and such a great scientist with us. So thank you so much.
Thank you, Darek and Neil, for inviting me, and thank you to Enhanced Therapy Institute, and also thank you, Neil, for plugging my book. It's true. I came out with a book in June called Good Chemistry, and you'll like it. You should get it. You'll be happy if you do. I have a bunch of things to talk about, but I think since this is primarily a conference focused on ethics, I'm going to start with the ethical issues and then probably branch off into some other things that interest me. I guess I should start. My name is Julie Holland. My pronouns, for those of you who care, are she, hers, and her. And also, for those of you who care, the land where I am sitting was originally, still belongs to the Lenape Native peoples. And I would also just like to officially recognize my place of privilege here. Recognizing my privilege in general as I speak. And thank you, Mark Haden, for speaking before me. So I'm going to sort of pick up where Mark left off, where we were talking about these boundary transgressions. Very big deal, super important. This has been going on for a very long time. When I was putting together my very first book, Ecstasy, the Complete Guide, I was assigning chapters to various people. I gave Dave Nichols the chapter on chemistry. People who were experts, I assigned them chapters. I went to assign one psychiatrist a chapter and later found out from a bunch of other authors that had been assigned that they would not be in this book if that particular person was included. I didn't know anything about it, but it turned out that that particular person had a history of sexual transgressions with his patients. He was an MD psychiatrist working with ketamine, working with MDMA, and there had been several allegations of boundary transgressions and outright ethical violations. And that was my first sort of exposure to the fact that there were some bad actors in this field, and that these were problematic areas that were going to come up again and again. So it is the first point of my talk about ethics, is that these altered states leave us very vulnerable, and there have to be ethical guidelines, and there must be consequences for rupturing these boundaries that are set in place for the protection not only of the recipients of the therapy, but also for the protection of the clinicians, and more important, I think, the protection of the entire reputation of the industry of psychedelic assisted psychotherapy. So this really needs to be our number one ethical concern. And then I would say our number two ethical concern really has to be access. Access is an ethical question. We need to make sure that marginalized people have access to these medicines, especially people who are having a hard time with alcohol and other drugs, people who've been traumatized, people who are traumatized by the racist policies that are in place and the sexist policies that are in place. The psychedelic research space, the research subjects, the people who can currently afford underground work, these are really a tiny demographic compared to the many people who can really benefit from these plant medicines. So accessibility, again, this is an ethical consideration, and it needs to be at the forefront of what we're talking about. And then the third ethical consideration I would mention is sustainability, right? Many of these plant medicines have the potential to be over-harvested. We need to preserve the land. We need to preserve the traditions that grew out of the earlier work with these plant medicines. And then the fourth ethical issue, which again Mark touched on, is ethics in business. You know, how do we behave ourselves within a capitalist structure? You know, corporatism. What does psychedelic corporatism look like? I believe very strongly, not just in sharing PowerPoints, but sharing data, sharing outcome measurements, coordinating with researchers as much as possible so that whenever we can, we use the same milligram strength, the same outcome measurements, so we can pool our data so that we have more power, right? And I understand that that's not the way capitalist companies work. I don't give a shit. We need data sharing. We need to avoid anti-competitive practices. We need transparency, anti-competitive practices in researching and developing these medicines. And then the last thing I would mention that maybe we don't think of as an ethical issue, but I do, is safety. There's chemical safety, there's behavioral safety. We need to make sure, you know, the chemical safety really comes down to drug policy issues, that as long as these drugs are not legal, there are going to be issues with counterfeit substances, and things not being as they seem to be, especially when we're talking about white powders. So I am a harm reductionist, sort of first and foremost. Chemical safety is very important when it comes to harm reduction, but also education is really paramount. And we need to be honest with people about what the risks and the benefits of these medicines are. And then there is this issue of behavioral safety, right? You know, we all love to talk about how non-toxic psilocybin or LSD is, and that's all well and good. But if you're crossing the street and you're distracted by how beautiful the traffic lights are and you get hit by a taxi, they may be physiologically non-toxic, but there's still this issue of behavioral toxicity. So obviously in a medical setting, when we're talking about psychedelic assisted psychotherapy research, a lot of these things are taken care of, right? We've got chemical safety, we have behavioral safety, we don't have people dancing for hours on end without taking a break, we don't have people overhydrating with MDMA. So some of the main risks, right? Counterfeit drugs, overheating, overhydrating, all of these risks are minimized in the medical setting. But we need to remember that in the recreational setting, these risks aren't always minimized. And we have an ethical obligation to make sure that they are. And I really agree with what Zachary Walsh was saying about not stigmatizing recreational use. You know, my very first interview about MDMA in 1985, which was 35 years ago, I was 6 at the time. My very first interview, I made a case that this distinction between recreational use and therapeutic use is really a false dichotomy, that for many people, recreation is therapeutic, and having a recreational experience for many people can end up being very therapeutic. And I would say, as somebody who has been to raves, and I have felt that unified sort of group mind on the dance floor, that's recreational, but for me, it was really therapeutic, you know, feeling part of something bigger than I was. So I think, especially when I think now about where we are now as a culture, you know, we are increasingly isolated. You know, one of the things I talked about in Good Chemistry, which by the way was written before the novel Coronavirus and the Pandemic, but it was all about the epidemics that we're facing as a culture. And there were 2 big epidemic sort of crises before COVID-19 came, and there was an epidemic of overdoses. And then there was also really an epidemic of loneliness and isolation. And that was one of the reasons that I wrote Good Chemistry, is I wanted to talk about how isolated and sort of self-centered and fearful we are as a culture, and how it's a bit of a crisis of consciousness where we have gotten ourselves into. And that I think that these mind manifesting drugs like cannabis and MDMA and psilocybin and LSD and ayahuasca and ibogaine, that these plant medicines, consciousness enhancing medicines, that they have the capacity to make us feel connected to ourselves, embodied and connected with our bodies, connected with our trauma, with our past, connected with each other, you know, whether a dyad or a whole community, connected with nature, and even connected with the cosmos. You know, when we have a mystical experience, the classical mystical experience, there is both the void and the light. And in the void, you may feel sort of alone and that you have nothing, or you may feel like you don't exist anymore, or that you were dead. But sort of like if you eat your meat and vegetables, you get dessert. If you get through the void, you get to a place of light and connection, and this oceanic boundlessness. And that can be a very blissful place. And having that kind of mystical experience, and in the light part, having the sense that everything is interconnected, everything is connected, and that you are a part of something bigger than you. This is a very therapeutic place to be in, feeling like you are small and part of something that is big. So not just on the dance floor, you can have this if you are taking psychedelics and you're out in nature. Maybe you feel very connected to the trees, or you feel that the trees are very connected with each other, but there's this sense of interconnectedness, and the sense that we rely on each other, that people rely on other people, that we are relying on the planet, and that the planet is relying on us. So it's all about this sort of interdependence and interconnectedness. So when psychedelics enhance this sort of ego dissolution, right? When we have the default mode network sort of quieted down, the default ruminations that most of us go to, you know, how am I doing? Who am I? What do I believe in? What is my social status? What happened yesterday with me? What am I doing tomorrow? You know, it's all very self-centered and solipsistic and sort of navel gazing. It's egocentric, right? And a lot of us really live in a very egocentric framework. And then with psychedelics, you have this ego dissolution, and it's a chance for a few things to happen. First of all, the self-centeredness quiets down, but also because this default circuitry is going offline, it's a chance for other circuitry to develop, for other parts of the brain to communicate with itself. So there's enhanced connections, not just within a person or between people, but even within one person's brain. There are new connections, there are new synapses being formed, there's even new brain cells being formed, right? So with neuroplasticity, which we see in psychedelics and we see with MDMA and we see with cannabis-based medicines. All this neuroplasticity, we're talking about new connections, new synapses. There's synaptogenesis, which is new synapses forming. There's also neurogenesis, which is actually new brain cells being formed. This idea of neuroplasticity, to me, it gives me a tremendous amount of optimism that people can relearn, that they can sort of shift away from very cognitive, rigid styles of thinking, right? So there's a lot of psychiatric diagnoses that are really characterized by cognitive rigidity, right? You look at something like anorexia nervosa, where somebody is just dead set on losing weight because they think they need to lose weight. They think they're too fat. Everybody else around them is like, you're not fat, you're thin, you should stop dieting. But that person is rigid in their belief that they need to lose weight and they're too fat. Or some person who is having a difficult relationship with alcohol or other drugs, they've got some rigid beliefs that if they take this drug, or if they drink this drink, or if they do this thing, it's going to bring them peace. You know, they're going, I mean, Alan Davis, I loved, he said, it's not about the drug, it's about the feeling, right? They're going for a feeling, but they end up with this drug that has a lot of other side effects besides the feeling. Anyway, this is another example of cognitive rigidity. And what we see with psychedelics and with MDMA is a sort of a more of a fluid way of thinking, less cognitive rigidity, more cognitive flexibility. This is important. We want this. This can help to heal trauma as well as relationships. You know, MDMA in particular, because, well, I believe the reason why MDMA has such a strong neuroplastic effect is because it does increase oxytocin. And we know that oxytocin enables neuroplasticity. And what specifically happens with MDMA is that there's increased oxytocin, and there is a quieting of the amygdala, which is the brain's fear center. But more importantly, it is sort of a hyperplastic state that the brain is in, similar to the same sort of developmental scale when you're an adolescent. I don't know about you, but when I was in middle school, it was very important to me who was in what group and what group I was in and who was popular and who wasn't. I paid a lot of attention to social cues. And social learning was really at a premium. That's what happens in your adolescence. That's also what happens when you take MDMA. The brain sort of reverts to this very plastic state where social cues are extremely important. There is like a reopening of the developmental window for social learning. And again, there is bonding. And all this is happening via oxytocin stimulation. The other thing that happens with MDMA that's very interesting is something called reversal learning, or sort of like a reconfiguration of traumatic memories, right? So because you're in this sort of very open and relaxed state, right? MDMA markedly increases serotonin or serotonergic neurotransmission. It also markedly increases dopamine and to a lesser extent, norepinephrine. But the big one is serotonin, right? So there's a sense of satiety, of serenity, less anxiety, less agitation. And then the increased oxytocin lends a certain openness and trusting and bonding, right? Now we know oxytocin is a hormone and a neurotransmitter that facilitates trust and bonding and the sort of openness. And oxytocin also facilitates learning. So what's happening when people take MDMA and they revisit their traumas is they have a chance to sort of replay the trauma, adding in a little bit more openness, compassion, and calmness, basically. So there's sort of an integrating of the trauma, and there's a reprocessing and sort of a reconfiguring of the trauma. It's like defanging the memory. You know, the memory is still there, but it just doesn't hurt as much. And there's also a chance to sort of have some equanimity about the trauma. Like, yes, this terrible thing happened to me, but you know, maybe it wasn't my fault, or there was nothing I could have done. There's just a chance to sort of rework the trauma in the bigger picture of who am I and what is my life narrative. The other thing I want to talk about a little bit, and I'm not going to segue because I don't know how to, but I'm just going to talk about something I'm very interested in, which is machismo. the armor that men wear, and this idea of toxic masculinity. And it's not just men. I wear a certain amount of armor, and I have a certain amount of toxicity to me. I think that I have a lot of yang energy, and some people have more yang, and some more women have more yin, or it's not just about men and women. But like, I guess I would like to talk about this sort of yang energy, very focused on achievements. Yang is sort of the penetrative energy, and yin is more a receptive energy. So maybe yin is like a bowl or a cup, and the yang is what goes in it. Or I think of yang sometimes as like missiles and bullets and sort of things that penetrate, that go through. Or if somebody has an agenda or a vector, as opposed to someone who is sort of receptive and willing to take in information and integrate information. So I'm constantly trying to balance and bring more yin to my yang. And I would encourage everyone listening to try to do the same. I think that the machismo and the armor and the toxic masculinity, it all comes down to sort of protecting the sense of self and protecting the ego at all costs. And so we've seen, in some of our governmental leaders, perhaps, what happens in the situation that they don't take in information. And this issue of wearing masks or not wearing masks, it really comes down to, am I going to do something to protect other people? It's not self-serving. Wearing a mask protects other people, not me. So I think the ethics of sort of our public health crisis, there's a huge nugget of resistance in this public health behavior that is about sort of selfishness and greed and protecting the ego, and machismo, and it is all really fear-based. So lucky for us, these things like MDMA and psilocybin and LSD and ayahuasca really can help dissolve the small self, the ego, the fear, can open us up more to the interconnectedness of all things, and how interconnected we are as a species on this planet. Obviously polluting the planet is selfish and short-sighted. And I really think that psychedelics can help us see the interconnectedness of all natural things. And this worldview really can help save the earth. It can help save the planet. We've seen data that shows that people who take psilocybin are more environmentally conscious and more sort of eco-conscious, more eco-friendly, more likely to be environmental activists. So it seems obvious to me that we are at a real sort of crisis inflection turning point with how we are treating ourselves, how we are treating each other, how isolated versus interconnected we are. I really believe that with these medicines that we can learn compassion and we can learn better caretaking for ourselves, for one another, and for the earth. And I'm very open to questions and answers if anybody has any.
Wow, thanks so much. That was terrific. I want to just follow up on that last point while it's sort of fresh in everybody's mind, because, one of the things I sort of sense is that you think this is kind of a tool for empathy in some ways, potentially. I think I really think that all of these medicines are potentially tools for empathy and connection and compassion. Yes. Do you think that what they're doing is sort of activating our existing kind of reserves of empathy, or are they creating empathy? I think about what would happen, for instance, somebody had asked this question, what would happen if somebody was a psychopath, or, someone who had some kind of chronic non-existence of empathy? What happens to that sort of person?
We do, there's a little bit of data that shows that people with narcissistic personality disorders did do well with LSD-assisted psychotherapy, and I believe psilocybin-assisted psychotherapy. So I think that, this is a really important point you're bringing up. I definitely think that most of us have a capacity for empathy that can be enhanced, and some of us maybe have no capacity for empathy. But it's pretty rare, right? Psychopaths are born, sociopaths are made. I think sociopaths are not beyond healing. with psychedelics and MDMA-assisted psychotherapy. So maybe, you know, somebody like a serial killer like Dexter maybe can't get anything out of a session, but I would be perfectly happy to sit down with Dexter and maybe do some work with him and see if we couldn't get somewhere. I think, you know, one of the things we didn't mention about my history is that I spent 9 years running the psychiatric emergency room at Bellevue Hospital. Every Saturday night and Sunday night for 9 years. I went to 14, 15, 16-hour shift over the ER. Saw a lot of crazy shit, and I saw a lot of really disorganized, disordered people, and I absolutely met my fair share of antisocial personality disorders. You know, we had to do a lot of screening of prisoners. You know, there's a prison at Bellevue, and I saw a lot of criminals. And there was one guy who was a real antisocial, kind of scary guy, who would come in a lot high on PCP and like tear up the ER and just be like really terrifying. But this one time he came in and he had found some ecstasy on the street, and he wasn't high on PCP. He was high on what looked like MDMA. And that was when I finally got a chance to work with him. And I spent hours and hours talking with him. And I don't usually do heavy therapy in the psych ER, but I did with this guy. And of course, he had a history of sexual abuse, ongoing anal raping by his uncle. And I just kind of talked to him about how, you know, he had been like literally fucked up by what happened as a kid. But now he was sort of perpetrating the violence on other people, and he was fucking other people, and he had to stop the cycle. We had to stop the cycle. And we had a pretty intense, you know, one-on-one. And I do feel like I got through to him. I wrote about this in Weekends at Bellevue. I do believe that, you know, even somebody like the Grinch with a heart that's 3 times too small, whatever, he still has a heart, you know? It's still something eventually made it grow. So I'm not willing to say that there is a huge swath of people who can't be helped. It's possible that psychopaths can't be helped, but I'm not willing to say that they can't. I am pretty optimistic in general.
So, and just to follow up, what are there concerns or are there challenges or even potentials around other kinds of sort of non-neurotypical people? I mean, people who have, you know, autism spectrum or whatever. Are there, are there, when you're screening potential patients, or even when you're just looking at, you know, research studies or any of this, are there target populations in terms of neurotypicality that you're interested in or you think we should be aware of?
Yes, definitely. I did, in this book, I will say that I do talk about MDMA-assisted psychotherapy for people on the autistic spectrum, and I highlight the work of Alicia Danforth in this book. And I would also like to say, I highlight the work of a lot of women researchers, because I think they don't always, I think we sometimes get sort of short shrift. You know, whenever you see a news show or a documentary about psychedelics or MDMA, it's almost always the men who are being interviewed. So I really made a point in Good Chemistry of including the women. But I do talk about using MDMA with people on the autistic spectrum in Good Chemistry. And you want to know who shouldn't take these medicines. So here's what I will say. In the research, you know, I was a medical monitor for a lot of these studies, and now I'm a medical advisor. I'm not a medical monitor anymore, for anyone who's looking at the program. Just want to make that clear. But in the research, in the MDMA research, in the psilocybin research, we don't let people go through the study if they have a history of psychosis, if they have a history of schizophrenia, if they even have a history of manic episodes with psychosis, or if they've got first-degree relatives with schizophrenia or mania. So anybody with a history of psychosis or a close relative, blood relative with a history of psychosis, not a good idea to take these medicines without a lot of supervision. It may be that you just shouldn't, but certainly you shouldn't be doing this on your own. In general, people, especially the first time you're taking something, it should be with a supportive environment. You know, I'm sure other people have talked about set and setting already. I don't want to reinvent the wheel here. Anyway, history of psychosis, I think for now, is sort of a non-negotiable, at least in the research community. But I will say that I have heard from people who have had very positive experiences with MDMA, who have schizophrenia. And I've heard from people who have had positive experiences with ayahuasca, who have bipolar. I think it's very dangerous, but I know that anecdotally, we are going to learn more than we're learning in research. And that it's always the way, right? I mean, you have very strict criteria when you do clinical research about who can be in the study and who can't. And then once it's FDA approved and it's opened up, more people are using it, we learn more. So I think that the caveats will change over time.
I want to just follow up on your comments about gender, and you framed it in terms of yin and yang, and you said that you think that there's tremendous potential to sort of allow these sort of more ego-focused yang types to kind of dissolve themselves a little bit. I wonder what the advantages or the effects are for the yin types.
Good question. You know, I think that one of the things, you know, I don't think we talk about this a lot, but it's really actually very important in psychiatry, which is just a sense of hopefulness. You know, one of the things that can predict suicidality is a feeling of hopelessness. And so I think that in somebody who is an introvert and maybe they're not doing very much, or maybe they're very passive, but then they have this experience that fills them with hope. And then they can go out in the world and be a little bit more active. So I think optimally there's like a balance. You know, everybody has their sort of proprietary blend of yin and, by the way, it's officially yang energy, but I'm not going to say it that way. So everybody has their balance, and I think everybody's balance can be tweaked. And I think the other thing is that my partner Jeremy and I are working on a book right now about couples and how a couple can sort of balance their yin and yang energy between them. I think is also important. We know, and I read about this in Good Chemistry, that that MDMA can be very useful in working with couples. So I do think that people who are more sort of passive or introverted or introspective obviously can benefit tremendously from these consciousness enhancing medicines.
Are there any issues that you see specifically? I mean, informed consent is always a big issue with medicines, and particularly ones that are, you know, newer. How do you think, are there any specific worries or needs that we have to approach just making sure we have fully informed consent from somebody had asked this in the questions, but just making sure that people are fully on board with what they could be in for?
What I will say is that within the research setting, absolutely informed consent is crucial. The consent forms are very long. They are worked on ad nauseum and reviewed by institutional review boards and the government and the medical monitors and everybody working on this. So informed consent is sort of the basic paramount building block of research ethics and medical ethics. So that work is done and you don't need to worry about that. But if what you're asking about is once these medicines are available to a wider population and it's not research, what will the consent form look like? That is an excellent question. You know, I don't run a clinic. I would ask people who are already running them. And, you know, what's nice is that we have ketamine sort of laying a lot of groundwork for how things are going to work. You know, that people are getting used to this idea that you can have an altered state from a medicine that helps with neuroplasticity and with depression. So there are already a lot of ketamines in place, ketamine clinics that are in place. And they do have informed consent for the most part when people go through this process. So I imagine it will be similar to that. But obviously it's important, and anybody who's undergoing any sort of a treatment like this, you know, this is like a disruptive technology. We're in the very early stages, you know, of sort of baby steps, of an infancy, of a whole field of medicine, a field of psychiatry that really doesn't exist, right? And this is potentially a really disruptive technology and a disruptive, it will be disruptive to the field of psychiatry and even to the field of medicine, I would say, once these medicines are FDA approved. So there's a lot of work to be done. There's a lot of groundwork to be done. And this issue of informed consent is very important. And obviously this issue of sort of shamans behaving badly is very important. You know, we need We need ethics to be at the forefront whenever we're talking about this. And again, I would also encourage sustainability and this issue of access to marginalized populations as also being super important when we're thinking about ethics.
That's great, Julie. It's wonderful. I really like how you pointed out a number of ethical issues and a number of issues that we should keep our eyes on at this stage of the development of these therapies. Maybe we should finish with a broader, more visionary question. You seem to me like a little bit of a visionary. If you go into the future and if everything goes right with these healing technologies, what would you hope for? What would you hope for that will happen on individual level, relationship level, broader relationship level, et cetera, et cetera?
Well, one of my personal hopes, it's almost like a bucket list for me, is I'm particularly interested in people with schizophrenia. I feel a compassion and kinship toward people who have chronic psychotic illness. There's no cure. People can be sick for decades. It's not, it's not necessarily a lethal illness. So people really just have to suffer with this, chronic relapsing psychotic illness for decades. So I'm very interested in somebody seeing whether MDMA-assisted psychotherapy may be helpful for people with schizophrenia. So that's sort of a pie in the sky issue for me. But I think what will happen really, so many of us are traumatized right now. So many of us have been traumatized. I mean, here in the country where I live in, many of us have been traumatized just by the last 4 years of having somebody so traumatized himself and so chaotic and so unpredictable as the leader of the country. And obviously the first responders with COVID-19, they have been traumatized. So I think what we're going to end up seeing is more and more PTSD. And because MDMA will end up being FDA approved to treat post-traumatic stress disorder, I think that you are going to see more people getting used to this idea of MDMA-assisted therapy or psychedelic-assisted psychotherapy to help integrate trauma. And what I imagine we will see is more sort of group work. It's not really sustainable. The current medical model, which is the research model, is that you have 2 clinicians for 1 research subject, and they spend about 8 hours 2 or 3 times, not to mention all the preparation and then the integration after. It's a lot of hours. And I think what we're going to end up having is that there will be there will be group processing for prep work. And hopefully there will be group processing for the experience itself, and then maybe some group processing for integration, but also some individual processing. But I don't think it's going to be these hours and hours of individual attention, which is really the way the research protocols are set up. So I think we're going to have to get more used to the idea of group work. And, there already is plenty of precedent for group work. I mean, certainly anybody who's familiar with ayahuasca circles is familiar with group work and how it works. And how, people sort of share their experiences. And there is something really bonding in that situation.
Julie, thank you. Thank you so much for this wonderful presentation, for being with us, for your generosity.
You are very, very welcome. It's my pleasure.
Thanks. So we're going to take a break for 45 minutes, and during the break, if you want to see, we're going to play you later on during the break. I'm going to play you an MDMA psychotherapy demonstration video. We created a kind of a hypothetical demonstration video about how MDMA psychotherapy might work in the future. And most importantly, I have interviewed Rick Doblin a week ago, and I'm going to play 17 minutes excerpts from this very, very interesting interview with Rick Doblin. So that will be at the end of the break, 20 to whatever your time is. So we will see you in 45 minutes. I want to say Julie Holland once said this about you. She said that she sees you as a little kid on a tricycle ramming into a brick wall for 30 some years and just keep ramming into this brick wall until this brick wall starts crumbling. But
he told me this massive surprise is that he had actually decided to donate $1 million, and he'd gotten 4 other people to also offer to donate $1 million, and that
right.
he would do a $5 million matching grant.
$5 million.
Yeah, but we only had 90 days. It was like a time-limited matching grant that he did to try to motivate the donor, so that we would have, and it was also all or nothing. If we raised 4.5 million, we wouldn't get it at all.
Get anything. Oh my gosh.
No.
Oh my gosh. Speak about pressure.
Yeah, in the analysis. So tomorrow, we're going to find out if the first of our 2 phase 3 studies was statistically significant.
Wow. Tomorrow. Wow, Rick. And the prediction is it probably will be based on your preliminary analysis.
Yeah, because going down from 100 to 90 people is not that
right.
much. I mean, if we went from 100 to 40, I'd be a lot more concerned, even though we have had statistical significance with studies even smaller than 40. So what we're planning to do, we've given the New York Times an exclusive on reporting the results. And because of the election and all that, we think it'll be coming out around November 15th.
New York Times.
Yeah, New York Times, around November 15th. A bunch of meetings with the donors who gave us money for this most recent 30 million and some of the earlier donors for the first 34 million in 2018. And what we're planning to do is that if the study is statistically significant, then what that means is that we think we have raised all the money we need for approval for the FDA, Israel, and Canada. So in phase 3, the FDA wants most of the data from the US, but it doesn't all have to be in the US. So for strategic reasons, for family reasons, what we have is 15 sites in phase 3 for our first phase 3 study. 2 were in Israel, 2 were in Canada, 1 in Montreal, 1 in Vancouver, and 11 were throughout the United States. And so because we're collecting phase 3 data from both Israel and Canada, as well as the United States, what happens is once we're done with our second phase 3 study, and if it and the first ones were significant, then we're going to submit the data to the FDA, to Health Canada, and the Israeli Ministry of Health for approval in all 3 countries. So we're anticipating somewhere around the middle of 2022 to finish the second phase 3 study. And then there's a roughly 8-month review process. So depending on when we finish the second phase 3 study, either the end of 2022, early first part of 2023 is when we hope for approvals. Now,
so many exciting developments, Rick. So many exciting developments, and you're steep in it right now. You're obviously very excited, and a lot of people are watching. A lot of people are excited about this. It looks like if everything goes right, MDMA-assisted psychotherapy will be approved somewhere around 2023. The approvals will start coming in, and then it will be available. The breakthrough status that FDA granted MDMA-assisted therapy is a very rare thing. And the definition of the breakthrough status is that it's better than any existing therapies.
What we showed is that in these most difficult cases with this therapy that you've just described, that 23% no longer had PTSD at the 2-month follow-up that were in the control group, the people that got the therapy without active MDMA. And what that means is that the therapy itself and the therapists were trying their best to actually help people, and that there was a pretty good outcome, 23% no longer having PTSD when they failed before, and that they're treatment resistant. Now, when we added MDMA, when they got therapy with active MDMA, 56% no longer had PTSD. What we found at the 12-month follow-up is that 2/3 no longer had PTSD.
2/3, right.
And 2/3. And what that means is that people learn how to process trauma, and they can keep getting better on their own. That we have sort of turned this around so that what was previously experiences that were too painful for people to process, but also they were unable to really put in their past, that would come to them in nightmares, that would come to them in reminders during the day, in triggers, that they would be feeling like this trauma was still happening. It wasn't in the past. They were always vulnerable, that they couldn't really get past it, that they've learned how to process trauma, and then they can use that without the drug and without the therapy going on. And that's where I said that MDMA is easier to integrate than the classic psychedelics.
There is something very interesting happening in that respect, that right after, a week or 2 or 4 weeks after the therapy is over, 1/3 no longer meets the diagnostic criteria. A year later, the same group, 2/3 no longer meets diagnostic. If it's true, and if this holds, if this whole oxytocin hypothesis holds, we have something really big on our hands in terms of healing relationships.
That MDMA stimulates oxytocin. And that not only that, but that the oxytocin stimulates new neural connections.
Neurogenesis.
Well, it's neurotogenesis. So it's not clear yet that it's the birth of new neurons, but it's the growth of new neural connections. So the synapses go to more different connections. And
so neuroplasticity would be a better term.
Yes.
Okay.
Yeah, neuroplasticity is a better term, and that it does it in prosocial areas of the brain. And that helps to explain why the changes can be long-lasting, right, because you are actually rewiring your brain. So what it shows is that MDMA produces prosocial behavior in ways that go so deep in our evolutionary history that it's pre-verbal. Mm-hmm. And it's also speculated this is because of oxytocin. It's not why, well, you just take a pill and everything feels better. People actually go through some very difficult emotional experiences, physical sensations, crying, shaking. It's like the trauma that was, when it was happening to them, people didn't know how to respond, or they couldn't, or they had to focus on survival, or they just dissociated. Right. Or, various strategies to happen when you're being hurt and traumatized. And so what the MDMA does is it permits these dissociated memories or memories that are have been submerged to come to the surface, and you can experience them, you can express them. What we understand now about memory is that it's not like you take the memory like a book off the shelf, you read it and you put it back. You have to reprint the book in a way. We're changing our memories over time, which explains a lot about why we remember things the way we wish they were instead of the way they really were. But what's happening is that when you're experiencing these memories, these traumatic memories under the influence of MDMA, and you're releasing them and you're able to put them into the past, and when you reconsolidate the memory, you've enhanced the memory, so it's a better sense of the memory, but you've also replaced the fear valence to the memory with something that's peaceful, it's in the past, I accept it, it's part of my story.
It's essentially, exposure therapy has been the main paradigm for trauma treatment. So what MDMA does it simply allows exposure treatment to be way more effective from what we understand so far. Consolidate those memories and then act in different ways in your life and get a feedback from the world and from other people that gives you actually what you need.
Yeah. Now, the other, I think, thing that's very important to say is that we have worked with people who have had complex PTSD from decades before, and they're still able to get better. We've worked with PTSD patients who had PTSD from Vietnam. Mm-hmm. Mm-hmm. who are still able to get better. So that even though we have these sort of ingrained patterns of response that are dysfunctional, that there is still hope for healing. And so I think that's just important for people to understand that no matter how long you've had it, it is still possible to heal.
One point that I find very, very important is that you have, it's a very new form of therapy. There hasn't previously been a psychotherapy that was combined with medication. You do your medication, you do your psychotherapy. They are not necessarily combined. Here we have a healing substance, and then the psychotherapy is designed around the properties of the substance. And we have, for a reason that hopefully we'll get into discussing, we have a team of 2 therapists, and we have a prescribing doctor. So there's a team working with you. So the structure of this therapy, just for people who, again, are very new to this, I like to make a kind of 4 points here, because screening is a very important point. So first, it's screening, meaning, are you a good candidate for this therapy? You could talk about that a little bit more. Then you have preparation sessions, and usually there is maybe 3 preparation sessions where you actually prepare for the dosing. Then there is dosing, which is a long, several-hour session, and then there's the integration session. And this form of therapy is often referred to as integration therapy, because the point of this therapy is not so much to have the experience, although some will argue that the experience itself is a wonderful thing, but the point of therapy is to integrate the insights and the gains that happen during the experience into everyday life. So I just want to make these few points. Do you want to add anything to this?
And then the integration process is key, because I would say that the difference between recreational use of psychedelic drugs and therapeutic use is that in recreational use, what's happening is that people are looking for an experience in the moment. You know, this is going to be fun. They're looking for an experience in the moment, but they're not thinking about how do they change their baseline. In a therapeutic thing, the experience in the moment is important, but what's most important is what you bring back from the experience and how you change your behavior without the drug. So yeah, so I'd say one of the explanations too of why for the last several decades it's only been nonprofit pharma that's been looking at this. It's only a few years that there's been for-profit new companies trying to look at this, is that we're not trying to make people use a drug every day for the rest of their lives. Our model is completely different. We want to do short-term, profound, deep interventions that make a change, and then through the integration process, make it so they don't need the drugs anymore.
The same substance that was put on Schedule 1, meaning can't use, can't possess, evil, the same substance, if the research results hold, is going to turn out to be, in combination with psychotherapy, one of the most powerful medications that we know. It is a powerful mind-altering medication. How do you protect from potential abuse by therapists? Because, you know, people who are on that medication might develop way more prone to develop loving attachment feelings, including towards the therapist that they spent 8 hours in the session with. How do you protect from that? A separate question, and I notice it's not outlawed in your ethics guidelines, the question of therapeutic touch.
Touch, yes. So part of our approach, the 2-person therapy team, is designed to prevent those kind of abuses from taking place. They're more likely to happen when there's a one therapist for one patient. Also, at least in the research, everything is videotaped. We're not quite sure if in the future they'll be videotaped post-approval, but it's not as reliable of a way to reduce abuse as two persons, because a lot of stuff can happen off camera. But I think that's very important. And I think the other part of that is the training that we give to the therapists. And we see that kind of sexual abuse that you're talking about happens a lot of times, way too many times, I'll just say, in regular psychotherapy too. So it's not unique to psychedelics, but we have to be especially careful. So we're going to have
especially careful, though, for sure, because of the psychoactive properties of the MDMA.
Yeah. So we're going to be having a patient bill of rights. We're going to be having complaint lines. We're going to be having all sorts of things where we can gather information about that. So I think that's really the one of the solutions that we'll have towards trying to deal with this idea of sexual abuse of the patient. Now, your other question was
therapeutic touch.
Touch, yeah. Okay, so because so much of it is somaticized, there is value in therapeutic touch, and sometimes the logo of MDMA, and I don't know if maybe when you show it, the logo of MDMA is two hands. So it's about humans. It's not about, it's got a psychedelic background, but it's two hands, about people helping each other. So sometimes just holding somebody's hand can be very helpful as they're going through something very scary. So therapeutic touch is something that's very delicate.
I just want to say that what I call a MAPS Public Benefit Corporation is the most ethical pharmaceutical company in the world. And I hope I'm right. I'm not sure where I am, but I hope I'm right. And so I would really encourage people who are interested in contributing to the progress in research, especially in relationship research. If you guys want a direct link to the hottest relationship study that is getting set up right now, you can even go to our website at enhancedtherapy.ca and donate.
We do intend to sell MDMA. We do intend to sell it at a profit, but it'll be maximizing public benefit, not profit. But to supplement philanthropy, because there's an endless number of things that we need to study. But I want to say that the Public Benefit Corporation has only one investor, which is the nonprofit. So the nonprofit is the 100% owner of the for-profit. So whatever profits are made are not going to go to me or to my pocket or any of the MAP staff. It goes directly to the nonprofit and to our mission. So that's our corporate structure. Yeah, thank you. Tomorrow's going to be a big day.
Big day. Another big day on November 3rd. Okay, Rick. Okay. All the best to you. Thank you so much. Bye.
Okay, I think we're on. Yeah. Okay, people seem to be able to see us, so that's great. We're back. So hopefully most of you have had a chance to do the poll about where you're from and what your profession is. It will take us a few days to count the mail-in ballots, so please just be patient. When we conceived of this conference, we conceived of it in a way quite narrow. We wanted to focus on MDMA relationship therapy, but we also wanted to make sure that we placed it within its broader context. I think it's impossible to discuss it without fully understanding the context of psychedelics and psychedelics use in psychotherapy and their often misuse. And we are fortunate to have someone who's an historian who can give us the historical context, can tell us some, I think really, I mean, she's written some wonderful stuff, and I know her written research, and so I'm really looking forward to have her just sort of give us some general historical background about where we're coming from and how we got here when it comes to these sorts of substances. So her name is Erika Dyck, and she teaches in the history department at the University of Saskatchewan. And you can see her full bio on the website, and I will just turn it over to her.
Thanks so much. Thanks for having me here. Treaty 6 territory and homeland of the Métis, and currently I'm not going outside because there is a snow apocalypse outside. I'm going to see if I can share a screen with you. And hopefully this will work. All right, can everybody see? I'm gonna go with a thumbs up from one person. All right, thank you very much. It's been really delightful to hear presentations this morning, some from familiar friends and also some new faces for me at least. It's always wonderful to be part of these conversations. So as Neil mentioned, I'm a historian venturing into this territory. So in some ways I feel a bit like a fish out of water. Bringing a kind of humanist perspective to this, and sometimes a social scientist perspective to looking at clinical trials historically. But today I'm going to try to make some sort of historical observations about how I might compare some of what's going on today in the psychedelic renaissance. So I'll try to keep this about 20 minutes. So I would be remiss if I didn't point out Aldous Huxley. This is somebody who I've done some of my own research on, and of course is a major player within the history of psychedelics. He of course was one of the people who had helped come to bring the word psychedelic to fruition. So here he's just reminding us that we should learn from the lessons from history. I thought that was a fitting way to open up this presentation. All right. I started doing my research on this project on the history of psychedelic, mostly the history of LSD in clinical trials in 2001. And at that time, looking back, there were a lot of controversial conversations in the 1960s and even into the 1950s about whether LSD might be, it wasn't described this way at the time, but whether it was a breakthrough therapy, that was kind of the sentiment that it was associated with it, or whether it was signaled the downfall of many different forms of civilization and concerns about the way that LSD might cause insanity, but also it may actually rupture the way we use different chemical substances to challenge authority. And today, as Joe Biden was just recently elected, I think these kinds of sentiments are still with us today as we think about the relationship between drugs and power. So I wanted to make some comparisons, and these are really just selective images. These are not comprehensive at all, but I wanted to walk us through just a little bit of a sort of comparison. So we know that some of the ways that we remember LSD, or the ways that we remember psychedelics more broadly, have continued to characterize the way we understand it today. And particularly, I want to think about the ways in which the stories that we tell about the past have continued to create stigma and discrimination and sometimes hesitancy around the embrace of psychedelics in the psychedelic renaissance, but certainly as it gets integrated into our drug regulation systems, into our healthcare systems, and potentially, we've been touching upon this in some of the other conversations, what this might look like if people were to take psychedelics on their own outside of a clinical context. And are we ready to deal with that? Are we ready to sort of would we want to keep the genie in the bottle, or what happens when the genie is out of the bottle, and will we have the resources and the know-how to contain it so that it doesn't go off the rails again? So we saw in the past, certainly, a characterization of drugs like LSD, sometimes mescaline, sometimes peyote. Acid, though, became a really sort of hot spot, and I think that the legacy and the discrimination associated with LSD continues to this day. But we saw it woven into elements of activism, human rights activism, and I don't think anybody here today would say that there wouldn't have been a civil rights movement or there wouldn't have been an anti-war movement had it not been for acid. But we see the ways in which the narratives, the stories we tell about psychedelics are either used to propel that feeling, those powerful positive feelings we might associate with something like human rights activism or anti-war activism in this case. But it was also used as a powerful weapon from a more conservative side, suggesting that these civil rights activists, these anti-war activists, these anti-homosexuality activists, a variety of different activists in the 1960s were not really authentic because they were taking drugs. And so this became a powerful weapon that of course related also later to the war on drugs. We also saw, these are just a few of my personal favorite examples of some of the ways in which a kind of acid culture or acid counterculture was moving its way into a variety of different cultural products. So I have some CanCon here for us since we're in Canada. So Maclean's magazine, Life magazine, of course. These are sort of popular periodicals that people were having, that a lot of people had access to. These weren't secrets. Of course, the Beatles' Sgt. Pepper's album is hardly, we can hardly dissociate that from their increased LSD use at the time. The Doors, Jim, why am I forgetting his name off the top of my head? This lead singer from The Doors claimed that he got the idea of calling his band The Doors because of reading Aldous Huxley's book, The Doors of Perception. So we see ways that psychedelics were capturing the imagination of cultural entrepreneurs and making their way into cultural products in the 1960s that had these kind of mixed results. There was a really sort of exciting flirtation with these ideas, but it also started to create different generational divides, which isn't really on display here, but we know that featured later. So for historians, and really a lot of these books were written by journalists, for people writing about this topic 20 or 30 years after 1969, after 1971, the UN Convention declaring LSD and other psychedelics to be banned substances, after that point, the reflection on this period tended to side with a more conservative view of this period, in my view. That is, associating the research, say in John Marks's book, The Search for the Manchurian Candidate, associating this research in this period in psychiatric history as one of unethical research with psychedelics. So ones that were motivated by ideological considerations, CIA-funded research. You see that reflected again in Acid Dreams. You see in Jill Jones's book about Cats, Narcs, and Pipe Dreams about a war on drugs where she's actually relatively open to the war on drugs and sees a really meaningful line that is drawn between drugs that cause healthful effects and drugs that cause unhealthful effects and addiction. And of course, in that version, this is a 1996 book, LSD falls into the unhelpful drugs. And so not only were some of the products that were produced in the 1960s feeding this kind of division, but I think the way that historians and journalists reflected on it later continued to amplify this division of drugs that fit on one side of a line, a white market, if you will, and the others that were fitted into a black market, and I think importantly, an unethical context. That story we know is changing. We're seeing, of course, in today's news, and I again just picked a few examples here, we see things changing both on the political horizon. Of course, Oregon and DC very, very recently had recent changes in their laws decriminalizing psilocybin. We see a variety of examples. Mark Haden had a few examples in his presentation as well, of leading newspapers, leading magazines, popular publications that are starting to talk about psychedelics using different language, or I would argue, using the same kind of language that was used in an earlier part of the 1960s, one that was more optimistic, one that was more excited and saw psychedelics as a provocative way of seeking change on a very cultural level as well as a medical level. And again, like Mark Haden has already told us, we see LSD making its way into popular films, popular television shows. I don't know if Ratchet is popular yet. I'm not sure what we think about LSD's portrayal in Ratchet, but I couldn't help but put it on the screen here. You cannot go on to Netflix these days and not find something that has LSD related to it. And we also see major players, best-selling authors coming out telling their own stories about how LSD has changed. In this case, it changed Michael Pollan's mind. And we also see a new generation of historical scholarship. So historians, and again, some journalists as well here. I've also included Ben Sessa in this. But there are a new group of people who are starting to look back at the 1950s and 1960s research and change the way we think about it, capture these histories and tell different stories about this past. So I put my own book on here as well, which of course I can say the most about, but I think that in general, this smattering of examples, and there are many others, and I apologize if I've left anyone off the list. I just wanted to give a few examples of ways that historians and journalists are now going back and retelling stories about the history of psychedelics in the 30s, 40s, 50s, and 60s. Of course, the word psychedelic wasn't coined until 1957, but I will borrow that term anachronistically to capture some of that research in the 1920s as well, looking into mushroom-based research as well as peyote-based research, primarily that done by anthropologists. In this generation of literature, we start to see not only a rethinking of the way that psychedelics fit into medical research and cultural changes, but we see a more specific focus on the way that psychedelics fit into the history of psychiatry. And if I were to flip back to that earlier screen, the characterization of psychedelic histories in the past, even 20 years ago past, tended to focus on psychedelics in culture, in society, and the sort of how they wreaked havoc on our notions of ethics or safety or risk assessment, but also how they contributed to countercultural mayhem often was the case. In these studies though, what we're seeing are a number of historians who are asking different questions, who are looking at the way in which psychedelics fit into a different moment in the history of psychiatry, a moment that also saw the introduction of psychopharmacological products on a wide scale basis. And I'll talk a little bit more about that in just a moment. These historians, I think, are starting to get us to think a little bit more about psychedelic medicine, psychedelic science, even in ways that weren't articulated even 20 years ago. So we know that by the 1970s, the context of psychedelic research from the past, and I will mark that as, from the late 1940s until the late 1960s, there was a lot of psychedelic research that was taking place. Clinical research, published research, research that doesn't conform to today's standards of controlled trial regulations, but that's because those particular methodologies were not in place. They were conforming to the highest standards of ethics and trial methodology that were available at the time in most cases, and of course there are outliers to that. There were thousands of studies conducted between 1948 and 1961. These studies took place in a variety of places around the world, and they tended, I'm talking here about clinical studies, that tended to focus on questions about the efficacy of psychedelics in psychedelic-assisted therapy, even when it wasn't called that exactly. But this was, as was discussed in the podcast there, this was taking psychedelics and going through psychotherapy, often with a psychoanalytical basis to it. By the end of the 1960s though, and we kind of know some of this story, I think it's been alluded to already, the war on drugs made a dramatic change to the way that different substances were being studied, but also how different drugs were being criminalized and what that meant for people sort of more flamboyantly or even openly discussing psychedelics. I had to have some Canadian content here as well. It wasn't just Richard Nixon who famously declared Timothy Leary to be one of the most dangerous men in the world, but our own, at the time, leader of the opposition, Canada's leader of the opposition was John Diefenbaker, and he was also railing against the use of psychedelics in a countercultural context, but he also focused, as did his health minister and others that followed, were also quite concerned about the ways in which psychedelics were being tested in what they described as unethical or untoward ways. I'm going to talk a little bit more about that in questions. I want to just really emphasize, and this again is just a few examples, but there are literally thousands, if not hundreds of thousands of ads that fill the pages of medical magazines and medical journals. These are, peer-reviewed publications as well as popular sort of medical and health journals that are emphasizing a psychopharmacological revolution during the 1950s. So the same time that drugs like LSD and mescaline are being tried in clinical trials, clinical case studies at the time. So were drugs like antipsychotics, antidepressants, a whole variety of antidepressant medications. In fact, these are the blockbuster medications that fundamentally change the way we do psychiatry and break that relationship in some respects, as some historians have argued, break that relationship with psychotherapy, or differently prioritize psychotherapy and decouple it from medication taking. Some people really embrace this idea that you can take pharmaceutical products and live independently. People no longer have to live in institutions for the rest of their lives. This is seen as a major improvement, and of course there are many, many benefits from that. There are also some downsides, and I would argue that this also allowed governments to defund things like housing or safe employment places, and there were all sorts of changes, but those tended to move off the healthcare agenda. And so there's a tremendous focus on the optimism associated with embracing psychopharmacology as a way that will revolutionize the way we treat mental health. We also know that from the 1950s and a little bit into the 1960s as well, but in the 1950s, a number of anthropologists and even psychiatrists, Humphrey Osmond is the fellow in the glasses in the back there, Frank Takes Gun is the man with the whalebone pipe, who's leading a peyote ceremony. This was held in North Battleford, just in Saskatchewan near the Alberta border. They participated in a Native American church ceremony as psychiatrists at the time, and Osmond's not alone in this, but I think he is quite remarkable nonetheless for paying attention to what was going on in Indigenous ceremonies, in the ways in which cultural rites were also being included in the ways of thinking about psychedelics. And I think we are seeing that again today, a desire to see opportunities for reconciliation with Indigenous communities, Indigenous ways of knowing, but also in ways that help us to think about disarticulating mental health from a medicalized system, one that might allow for a different set of vocabulary and a different set of experiences to be included in what we think about when we're considering mental health, mental healing. So I wanted to just make sure that I didn't ramble on too much, and I have a few specific points that I wanted to emphasize here. So the next two slides are meant to just really try to draw this comparison out. So historically, his psychedelics emerged, and I'm using the term anachronistically, so even before 1956 or 1957 when it was first published, there was a period of intense medicalization of behaviors. During the 1950s, the American Psychiatric Association introduced the first comprehensive catalog for psychiatric illnesses, which we now know as the DSM, or the Diagnostics and Statistics Manual. It was in its first edition in 1952. So there was a tremendous push to categorizing and labeling certain disorders, dysfunctions, distresses, and some people have argued that this also set us on a path of medicalization. So we saw things like addictions moving into expressly medicalized territory, even things like sexuality, and of course that became controversial. It is to date, though, homosexuality is the only thing that has been removed from the DSM. But we also see other categories like loneliness, moving through a sort of pathological set of vocabulary and being placed in the DSM at this time. This was not without considerable debate. This didn't just happen because everybody had consensus on these issues. These were contested conversations. But we sort of know what happened. That's the power of doing history, right? We have hindsight. It was also a period of tremendous polarizing in politics. The Cold War, of course, made this crystal clear for how that polarizing was, how it manifested. We also have intensive nuclear weapons testing. So we've heightened cases of anxiety, of existential angst, of fear and trauma that people are facing on a regular basis, and sort of a desire by psychiatrists and mental health professionals to figure out what to do with this sort of global sense of angst. And we see that articulated in specific catalogs, but also in investments in research at the time. This is also a period of changes within psychiatry and psychotherapy. As I mentioned before, the psychopharmacological revolution. So psychopharmacology historian David Healy has argued that the 1950s represent the decade where the most psychopharmaceutical products were introduced ever before in human history. This is important to bear in mind. So when mescaline and when LSD were being tested, it was at the same time that all of these thousands of other products were being tested. It's also a period of intense psychiatric deinstitutionalization. This begins in the 1960s. It takes place in varied ways across different jurisdictions, but major psychiatric hospitals begin closing their doors and moving people out into communities in very uneven ways. But the optimism and the critique of that combined to create this sort of intellectual space for expressing different ideas about how we recognize and how we treat mental health and wellness. Again, this was not without critiques. One of those lasting critiques, I think, was the sort of emergence of what we now call anti-psychiatry. So deep critics of critiquing the way that psychiatrists had wielded power over patients. I won't get into that in great detail, but I just want to point that out because there were critics at the time. So now if we fast forward to, I'll say, 2010, I will choose relatively at random because historians aren't very good at identifying specific precise dates because we usually want to talk about how much nuance there is. So I won't pinpoint it to a specific moment, but I would say over the past 10 years, we've certainly seen a change in that conversation, a change in the narrative about not just how we remember the past, but what those lessons from the past might have to tell us about going forward. I think today we continue to see similarities with what people saw in the 1950s, an exhaustion with current mental health approaches. If before the exhaustion was with long stay custodial institutionalization and psychodynamic or Freudian-based approaches for people who weren't living in institutions primarily, we see an exhaustion with current mental health approaches. Despite the optimism that came with the introduction of psychopharmacology, what we see are rising rates of mental illness. We see increased rates of suicide. And of course, these are not evenly distributed in our population either. There are, of course, hotspots in certain areas. We see increased rates of suffering. We see new addictions, some of which are medically caused or iatrogenic. And I think there is a deeper sort of cultural or social questioning of the efficacy of our current models. This is an opportunity, I think, for psychedelics to reinsert. There is also an exhaustion and a growing critique of the war on drugs. We see decriminalizing efforts around, we've seen it in Canada with the decriminalization of cannabis. We see it at a state level in various different states in the United States, but we also see it in different areas in Europe. Israel is also exploring decriminalizing efforts. We see activism to defund police, and I'm not going to say that the defunding police effort is exclusively related to the war on drugs, but I think it's part of a broader, deeper questioning of the way in which we criminalize drugs and drug use and the consumers of drugs. And we see a growing desire, even across ideological lines, in reevaluating harm, bringing in questions about the financial costs of not treating someone or the financial costs of criminalizing particular behavior. And I know other speakers have already touched upon this too, so I won't go on in detail there. I'm almost done. I think I'm getting close to the end of my time. I want to sort of point this out as a bright spot, and because as a historian, I love it when there are these lovely little historical ironies, so I can't help but bring this up. One of the things that I think is very fascinating also about psychedelics and the history that I worked on beginning almost 20 years ago was the relationship between socialized medicine and the introduction of psychedelics. So the word psychedelic was coined by Humphrey Osmond while he was working in a large mental hospital in Saskatchewan, where he had come at the request of Tommy Douglas, who was trying to fund a publicly funded healthcare system. They recognized even early on that there were real advantages to bringing an alignment between psychedelic therapy or psychedelic assisted therapy and socialized medicine. So I point that out as a Canadian innovation. Palliative care, a concept that was coined in 1987, is also a Canadian innovation. This one done in Montreal by Dr. Balfour Mount. And this is an area where we're starting to see a lot of conversation also picking up around the role of psychedelics. I think that the Canadian healthcare system itself is a place where we have a lot of flexibility. There are drug regulation challenges that create obstacles, but there's also a lot of optimism, and I think a lot of potential for thinking about a Canadian-led innovation here and bringing psychedelics in a responsible and an ethical way, to borrow from Julie's conversation about the ethics that also include accessibility. And I think Canada has the opportunity to be a leader in that regard. And palliative care may be one of those wedge issues where we begin to see this. One of the reasons why, this was an example from a palliative care article, one of the reasons why I think it's palliative care is one of those wedge issues is because it also aligns a variety of characters or players who are not necessarily pro psychedelics, but they are pro dignity and dying with dignity. I think it brings a variety of different actors into the conversation, and it may be a sort of more palatable place to start thinking about wedge issues where we can start to get some guidance and some leadership on bringing psychedelics into our healthcare system in a responsible manner. So this was my question to end with. And I would be remiss if I didn't give a shout out to Shakruna, who has been supporting some of the work that I've been doing. I've been working with a number of young scholars, precarious scholars, to bring attention to some humanities and social sciences work on this. One such feature that we have now is on the role of women in this history. And so I just wanted to acknowledge them as one of the sponsors of this conference as well. Thank you.
Wow, thanks so much, Erika. That was really fascinating. I'm really glad that we were able to step back and look at it more broadly, because I just don't think you can understand these issues if you don't have that perspective. So that was so valuable. I want to ask you, one of the things that struck me, I know we're all just processing what has happened in the United States in the last week, but one of the things that struck me was that even though there didn't seem to be a move towards the left, I guess you could say, that people were expecting, nevertheless, all of these referendums on drug legalization, including one on decriminalizing pretty much all drugs, passed. And so there seems to be an ideological decoupling, whereas once upon a time, certainly in Richard Nixon's time, you had anti-drug warriors in Reagan's time, and anti-drug warriors on one side, and drug, and you could predict pretty easily by where people stood on the war on drugs what their other views would be. And now you don't seem to be able to do that at all. It seems to have just totally split apart. I wonder if you could comment on that.
Yeah, I'd love to. I wish I could like haul out a friend or call a friend. You know, I've got some friends who do really amazing work on drug regulation in the United States. David Hertzberg has a new book out on this topic. One of the things that I find really fascinating is if we can allow ourselves to think beyond drugs as those that fit into the criminal category, or drugs in the way that Richard Nixon talked about them, and think about drugs that include pharmaceutical products, then we start to see an alignment in a way that I think has a different logic. For example, Reagan was a crusader against so-called black market drugs, or lots of different drugs. He was a fan of the war on drugs, but he was also an actor in California during the AIDS crisis. And Reagan, in many ways, did more to change drug regulations to allow for moving antiretroviral drugs and drugs that were being tested at the time, I won't claim to know all of their drug names, through a regulation system to allow for treatments for AIDS patients. Now, if we put those into the same category, we also see that drugs that were commercialized and drugs that fit into a pharmaceutical market, and we know now also had a tremendous pharmaceutical lobby, fit into a really different category along the political spectrum. The Kennedys were fans of the psychedelic work that was being done. Now, they also had a variety of other reasons for doing that. Sorry, I guess I should name who they are. John F. Kennedy and Robert Kennedy, their sister Rosemary had been institutionalized for a long time. They were very keen to try to find different solutions. They reached out to people like Humphrey Osmond. They reached out to researchers at Maryland and were quite keen on following what was going on with LSD research. Aldous Huxley, who died in 1963, November 22nd, 1963, this date might be significant to some. He died while taking LSD, not because taking LSD. He took it as a kind of palliative response. It was the same day that Kennedy died. And there were letters going back and forth then with some of JFK's brothers with the researchers using psychedelics at the time, saying, how can we keep this research going? So I think there are some really interesting moments to sort of see where the big name politicians were, but also if we scratch beneath the surface and see how their policies and some of their decisions actually align with a commercial medicalization of pharmaceuticals and not with psychedelics, which Nixon had put on the other side of that frame. It's more messy, I think, in other words.
Yeah, and I think maybe, yeah, sure. I mean, my question was sort of, isn't it now messy? And I guess your answer is it was always messy.
Yeah.
So that's interesting. I wonder if I can push you a little bit on, when you look at the history, what a kind of gender lens tells you. And whether we see, I mean, for instance, is it more likely that a drug that is used by women rather than men is going to face stigma and legal restriction? Or, I mean, any sort of insights that you can sort of see when you look at your research about how gender has affected the history of these substances?
Yeah, this is such a wonderful topic, and I'm sort of ashamed that when I first started doing research in this, I was sort of blind to some of these questions, and it's taken me a long time to really appreciate how to reread the sources that I looked at myself, or even people I interviewed, and sort of rethink some of these questions and these nuances. So I'm really, really pleased to see that there's another generation, a new generation, a new group, I should say. I don't want to age people. There are people asking these questions in really interesting ways, and I'm really heartened by that. I'm optimistic by it. So the couple things that I want to highlight. One is that in the 1950s research that was done, most of it was led by male investigators, but this was kind of typical, right? I mean, more men were in the workplace and more women were housewives at the time. So this is not altogether unremarkable. But what I found was that some of the folks that I would describe as psychedelic pioneers, most of those men took psychedelics the first time with their wives. They were worried in some cases that going out of their mind, they may never come back. You know, there was very little information about this at the time, and they wanted to do it with a trusted partner. And it's a really interesting moment to sort of think about where people found their baseline for trust, and that moment where they wanted to work with their wives. And many, many wives took LSD with their husbands. So we've been sort of sifting through some of that correspondence to understand the role that women played in helping to make sense of these experiences. We also see this reflected often then in the design of different therapies or different, I say trials, but it's a bit anachronistic. So whether I was looking at trials at Weyburn Hospital in Saskatchewan or at Hollywood Hospital in British Columbia, or my colleague is looking at trials that were done in the Netherlands, or another one who's looking at trials in Germany, often they wanted to have a male and a female investigator at the trial. And some people even theorize this as having a mother and father figure present. And we might think about sort of resurrecting some kind of Freudian ideas about what that meant. Of course, people were working in Freudian environments at the time. But there was also an open discussion about the ways in which sometimes patients themselves or subjects asked the men to leave the room. They wanted the woman sometimes, and the woman I say the woman because sometimes they were nurses, sometimes they were trained, sometimes they were wives who just had experience. It's a whole variety of different experiential expertise in the room. They wanted someone there to hold their hand, but not to judge them. And sometimes just the presence of a woman made someone feel more comfortable. And we can argue as to whether or not that's fair, but there were requests from patients sometimes to have a woman present, such that some people began to argue that that was the ethical way to proceed, was you needed to have a kind of family mirroring in the room. This was part of the set and setting, part of that conversation. There were also women involved in making musical selections. Helen Bonney is a music therapist who becomes quite famous for working with psychedelic therapists to calibrate musical selections in a way that she feels, and her theory on this is to bring out emotional responses. And it's very gendered at the time. It's 1950s gender almost working against itself, you know, embracing those gender discrimination or those gendered ideas and characterizations to think about the positives that women were bringing into this situation. Huge generalizations here, but that's just some examples.
That's great. So we had one question about sort of what the legacy is of the Timothy Leary period. So when we think about psychedelics, we think of Timothy Leary, we think of the hippies, we think of the 1960s. And I guess what they're kind of wondering about maybe is whether that set the cause backwards or forwards. I mean, lots of people see Timothy Leary and other people like that as kind of heroes. And then other people would say, well, that was when the backlash really started. So can we can we say on balance whether that was a disaster, a wrong path, or whether that was the first step towards where we are now?
Yeah, I mean, I've written about this. I have not perhaps been so flattering towards Timothy Leary, but I don't think he is to blame. I don't think he single-handedly, wrote it for everybody else, or became the most dangerous man in the United States or anything like that. I do think it's interesting, though, to see the way that Leary really championed an idea and became someone who the psychedelic movement at the time did not really put limits on him. They continued to sort of catapult him into the spotlight. And he ultimately, I think, played upon some kind of narcissistic tendencies where he was in front page news, he was on the podiums, and he was fairly reckless in his recommendations of using psychedelics with almost no caution or no restrictions. And I think, it's a failure of the psychedelic movement at the time to continue to give him a platform for that kind of stage. He made a whole bunch of really obvious mistakes that I think we would have a hard time defending. One of my favorite examples, he was invited to come to Toronto at one point to help to develop a safe room for creating psychedelic experiences in 1967 during a festival. But he had a bunch of marijuana in his pocket as he tried to cross the bridge at Detroit. And so he got on a megaphone and gave his address from the Ambassador Bridge. I'm not sure how many people are familiar with the geography, but Detroit is not close enough to Toronto that anyone could hear him. He made some strange choices that I think suggest that he thought of himself as bigger than I think he was. And it's too bad that there wasn't a taming effect. And I think that people are kind of cautious about that in creating these characters that become larger than life and letting them kind of run away with the Kool-Aid, if you will. And I think that we really need to create space to hear a variety of voices. We need to pay attention to the abuses. We need to pay attention to the places where we have work to do as a movement, as a community, and hopefully as we try to mainstream things, I hope that we don't create new Learys, but we need Learys, just like we need people who are more cautious. We need to kind of work together to sort of think through, I think, a whole variety of dynamics. I think we have to be careful about giving the microphone only to the Learys, and we have to be careful to make sure that we also pay attention to the people, for example, in the Amazon rainforest, who were saying, like, we need to conserve the rainforest too. We can't just embrace tourism for the sake of promoting a movement. We need to have some kind of harmony and balance that allows for a variety of voices to be heard.
Thank you.
That's not really an answer.
That is a great answer. We're almost out of time. I guess I'm a bit of a history nerd, so I'm going to ask you a bit of a history nerd question, which is, when you look ahead, either at your own research or the research by others that you're excited about, what are some of the big questions that you think are still unanswered that you're looking forward to hearing people weigh in on, or you're looking forward to weighing in on?
Well, I'm very excited at the prospect of thinking about what Canadians could do with this. I think Canadians have a real sort of, maybe it's wrong-headed, but we have a cultural and a social investment in a kind of healthcare that we identify as a Canadian human right. And I think we have an opportunity to roll up our sleeves and work across partisan lines to think about how this moves forward. And then the last thing I'll say is the global history of psychedelics is rich and varied and understudied. And there are so many communities that have different experiences with these that I think decentering North America from our conversations could really bring some important new voices to the mix. That's it.
That's great, Erika. I really enjoyed your presentation. I was just thinking about how confusing it must be for some people who have not been showing a lot of interest in so-called drugs, when on the one hand you say that there is, everybody says that's the message, that there is a humongous drug abuse epidemic. On the other hand, in the same statement, they hear that psychedelic assisted therapies are being legalized. That messaging, do you want to say something about that?
Yeah, it's really fascinating. I've been trying to work with some harm reduction communities here in Saskatoon, but also talking with Indigenous communities in the surrounding area. And these are places where I learn a lot. Learning from, you know, a police officer who's like, wait, you can't treat drugs with drugs, you know, this kind of thing. And there's a lot of education that we need to do, but we also need to listen to people, I think. And it's not just me going out and, you know, telling them that actually, you know, a one-dose therapy is really positive, and think about all the lasting effects. Although I agree with that. I think there's also an opportunity to listen. And there are peyote ceremonies that take place in Canada, and there are some really incredible stories that are coming out of places where people have a very different relationship with healing, trauma, and drugs, and a real suspicion, and I think a very logical suspicion about medical communities telling them that this will be a new way forward. So I think we have a lot of listening to do as we move forward too, and a lot of healing to do.
Thank you very much, Erika.
Thank you.
Thank you for agreeing to be with us. So we have Jazmin ready there. Jazmin is our next speaker.
Hi.
Hi. So Jazmin graciously agreed to be with us here today. And I just want to say on a personal note that after Jazmin became a part of this conference, I actually met Jazmin personally at some point during the COVID epidemic with proper distancing in Kenora, Ontario, which is for me, that's where Jazmin is from, and that's where my family, we spent quite a bit of time there. And I personally feel very, very connected to that place. And this is the traditional territory of Jazmin and Jazmin's people. And Jazmin is an ethnobotanist and a traditional healer from Kenora, Ontario. And we look forward to what you have to say, Jazmin.
Well, thank you so much for having me. I'm very, very grateful to be part of this. And, you know, Darek, when I met your daughter, she taught me some really awesome things. So we had like proper social distancing. We had a little bit of lunch. But the wall behind us had a whole bunch of, it was limestone, and there was a bunch of little fossils in there. And I kind of distracted her and had her look for the little fossils. And I was telling her about putting tobacco down for plants when we take a plant to show our gratitude. And I said, well, since you're 5, you're not going to have tobacco, so put a candy out and make sure not to put the wrapper out. And she said, but Jazmin, can't I just plant a seed? And she really taught me that day. She really taught me. So I really like what Erika said, where we have to spend our time listening to others and their perspectives, so that we can do our best in this psychedelic renaissance. So yeah, I just wanted to share that with you, just to let you know that your daughter changed my life. Really lovely. And Kenora is my home, and I'm sure you feel that same connection to home as I do, because coming here to we can just plant a seed. Yeah, I love Kenora too. Kenora is really great because the rocks here are really, they're almost really heavy in a way. Like when you enter this place, you feel more full. But a lot of people, when I from what I noticed from my work in this area, a lot of folk feel the heaviness of the place and attribute it to the sickness of the people. Now, Kenora, a very beautiful, beautiful place, but there's a big but. We have a terrible methamphetamine epidemic, the diabetes epidemic. Like we are struggling in a bigger way, and we have a very conservative perspective. Not just our government in general, just conservative, where people do have the idea of the war on drugs and how it's not really going to promote anything good for anyone. It doesn't matter who you are. It's not going to that perspective is not helpful. So it should stop helping. Now, MDMA, it's not a traditional plant medicine, obviously. And like some people will tell you like MDA comes from sassafras, and it does have traditional roots, but it's okay. People don't have to, you don't have to know where it comes from. You have to know that it's come to help. And that's same with all of the plant medicines too. The plant medicines come to help. What I understand about using MDMA is that even though it is very powerful and very effective, I never felt a plant spirit entity with that medicine. I felt the entities with peyote, with ayahuasca and chacruna, with psilocybin, but things like MDMA or ketamine or even 3-MMC, they're absent of that spiritual aspect. Now, I don't know if that's just me inside myself. This is just my perspective. But the most powerful thing that I could say about MDMA is that it made me feel very close to what I thought of as God. Everybody can have their name for it. Some people use the Great Spirit or Kichi Manadu to say the all-encompassing spirit of this place, of life. I just want to note that MDMA promotes this connection that we're all have lost. And we lost this connection through colonization. And like, I'm the perfect example of colonization. I'm mixed breed. My father is Ukrainian and my mother's Cree. And we were raised in the Ojibwe territory in Kenora. So there's a lot of moving of people. So what I can tell you for sure is I can't tell you what exactly every Indigenous person would say. That would be preposterous. There's a number of First Nations in Canada, and they all have different ways of being, different ways of healing, different ways of practicing, different languages, different dialects. And our dialect is specific to the land that we're on as well. And many of the practices that are used, and many of the languages are starting to be diminished because the practices that were related to that language aren't being used anymore. So I mention that because when we're talking about healing traditions or perspectives on healing, there is what appears to me is that the psychedelic renaissance is bringing a diffusion of cultures. So there's no way we could institute MDMA into like a Medea Ojibwe healing tradition. They have their ways and they have their ways of efficacy, and people have their faith. It's just like, I'm not going to tell a Christian that they can't eat the body of Christ during their masses. Like, it's preposterous. But everybody can, even though we have different traditions and different practices and different ways of believing, we still take a Tylenol, or we would still take something to help our bodies to get through to the next day. So I don't want to separate medicines. Like I don't know how to say it exactly, but I don't want to separate plant medicine from everything else. I want to say that they're medicines made for us, for our benefit. Maybe benefit's not even the best word either, for help. Now, from a traditional aspect, when I'm looking at when I'm helping others to heal themselves with plants, I teach everyone about the spirit of the plant and about how the spirit of that plant will actually help you to recover. What's great about the spirit of those plants that help people to recover. It could be any plant, and every plant in the boreal forest, in the prairies, in the Great Lakes, St. Lawrence, it doesn't matter. They all have an entity. And when we give our gratitude and we give our honor and we give our respect and our love and our wisdom to our plant teas, then we get that in return. So there's an automatic reciprocity. Just make sure you always make your exchange. You have to always make your exchange. Now, historically, Indigenous people across Canada, it doesn't matter who you are, we lost our way that we had before. Like there was an automatic disconnection from the land, and I say automatic because it happened in 100 years. Like I still know individuals who lived strictly from the land, and to a lot of people that is like that's a 200-300 year far cry from what reality is. But I always tell people, if you live in the First Nations and in the northern communities, you have a better chance of being able to use the land to help you heal, because you're still pretty connected, very connected. When I've lived in a city, like I've lived in Ottawa, and wow, the disconnection that I feel in that area is very big, because it's just a concrete jungle. Like I'm used to the bush. I'm used to being able to go for a walk and being able to connect with myself. But when I'm so disconnected by physical things like concrete, I don't feel myself. And when I don't feel myself, I don't feel right. I don't feel right, and I don't feel like I'm healing. So the opposite of addiction is not sobriety. The opposite of addiction is connection. And that was Johann, can't remember the last name, but that's a very familiar quote that I'm sure everyone could note. And Gabor also talks about this emotional loss and trauma in childhood is the core of addiction. Well, I think they're kind of talking about the same thing. Like many Indigenous people in the country now are so disconnected from the way of being that I'll do anything to try to make myself feel better. Like I'll drink the scariest ayahuasca ever just to try to feel something that I'm not trying to shut off. It gets really problematic when we're every single day being barraged with being separated, constantly separated. So what's great about MDMA is that it helps you feel this connection. Like it helps you to produce that oxytocin, that mother's chemical. And I like to talk about that as well, because in many of the sweat lodges that I've been to, especially ones for people that are being treated with trauma or just addiction, or the list goes on, they commonly put bear root on the rocks to steam and to give that vapor. And bear root, I can't remember its scientific name at the moment, but it helps to release oxytocin in the body. So this is something that we use normally in the sweat lodge to alleviate these addictions. So there's plants that provide these effects, and we use them in a specific way to provide these specific effects. So this happens often. Like if you've ever been to a sweat lodge and they ever put beaver casters on the rocks, you're going to know it. You're going to know that it's going to help you to recover. Doesn't matter what culture you come from, it's going to work, because it's an antiviral and an antibacterial. It's a very powerful medicine. But same with bear root. And the reason why we refer to it as, oh, thank you, Ligusticum porteri, osha root. Yes, very helpful. But bear root helps to do this as well. So that's when I have a friend who's having a really hard time, I just give them the bear root. Like I even purchase it online, because I don't pick it in this area. We just pick things like wike, calamus root. But all the plants are there to help support. And when I'm thinking about the use of MDMA and how it can help us reconnect with ourselves in a clinical setting, I consider the people that come from a very hard background. So a very difficult background where, you know, you could go to treatment, and I've heard this from a number of people working on the front line, is you go into treatment for 90 days, you hate it, you're not allowed to get high, you're not allowed to do whatever, and you're having a hard time. 90 days passes, and then you go back to the same environment. Well, how does that help to recover? I think that's the question that people are going to want to, they're going to want to know. How are you going to help treat those addictions or those lack of connection or this trauma when we just go back to a similar environment? So I understand that the psychotherapy can be an assistance in that regard, but that's where I would consider is, would people be left with a want after they try MDMA in a clinical setting, a really good, healthy setting, but then they go back home and they're in a bad environment? Well, I'm going to keep searching. Like, if it were me, I'm going to keep searching for MDMA. And then what am I going to find on the street in Kenora? I'm going to find methamphetamines, and it's hell. Like, that's like, you take hell in. That's what methamphetamines are. So, you know, there's the great heaven of MDMA, and then one little turn of a functional group, and then you have like these methamphetamines that are causing a lot of damage to the people, and they're not recovering. Like, I know a woman who I was helping to treat in one of the disability organizations that I just go in and assist every now and again. One woman, 28 years old, never taken any drugs. She has mental health issues, and she knows to stay balanced, and she makes sure to eat. And then all of a sudden she got a friend who liked to do methamphetamines. I just would get concerned about someone who never used any compounds, went to a clinical setting, you tell them it's MDMA, and then they go back and then they take that information, oh, MDMA, oh, a methamphetamine, and then they translate it to, oh, I can get methamphetamine on the street, no problem. That's where I get concerned, because you're going back to that terrible environment. And not all Indigenous people, most Indigenous people who live in the North have a very great environment. And it would be very effective, and I think it would be very warmly welcomed with some of the even more Christian communities. But when it comes to the traditional Meday, the traditional shamans of the area, Winnipeg area, to Thunder Bay-ish area, they're all about their own medicine, and they want to use their own medicine. But I'm going to tell you that there's for sure they're going to take a Tylenol, or for sure they're going to take something that's from a pharmacy. So I think there's a lot of learning, and there's a lot of us trying to get through colonization, and little by little, I think we'll be able to get through it. It's always a struggle, but the whole remedy of everything here is education. Like, if everybody was educated about what's going on here, I think if we had a good set and a good setting, like if we were able to do some of these therapies with family members, I know that for some people it wouldn't work, but then a lot of other people it would, because there, a lot of Indigenous communities right now are doing family therapy. So there's this fund out there called Jordan's Principle, and it's so that no child is left behind, so that any family and children that needs a type of treatment now have access to the funding to get it right now. So maybe in the future, Jordan's Principle can help, you know, some of these children that are suffering with trauma, or they're suffering with loss, their best friend killed themselves. Like, maybe this can help recover that. But it's just going to take little by little. We're going to need education, and yeah, it's going to need a lot of work. And I really hope that that we can head in a really good, positive way, in a positive direction. And I know that the MDMA psychedelic assisted therapy would be very effective for alcoholism and any narcotic use, even opiates. But we introduced opiates into the Western world, and then now a lot of people are stuck on legal opiates. Well, that's causing a problem as well. So I'd like to put in all the perspectives so that we can see all around it. Every Indigenous community, it's a First Nation, it can decide its laws the way it chooses. But we just have to be gentle and careful. And yeah, so thanks for having me. I hope that was, I answered some questions for you guys, and if there's any more.
Well, thanks so much. We have a couple that I think are important. We had one about the tension between, you know, the need to respect cultural origin and the tension between wanting to use beneficial medicines that we see promise and respecting that these come from particular cultures and we may be in some sense appropriating them. And I wonder how you balance that, the need to sort of heal and the need to take advantage of wisdom that exists with the need to respect cultural, you know, cultural autonomy.
You know, when I think about that, I think about myself as a human first. Like, when pain is a really great teacher and pain is a bridge to understanding. When you're in excruciating pain, you'll do anything. You'll do anything. You'll do anything to recover your body. So my teacher, Juan Flores, gave us the medicine and gave us the teachings of the medicine for the Indigenous people in Canada so that we could help ourselves to recover. It was a gift. So when I think about cultural appropriation that way, I'm like, well, they're our brothers. And I'm not from that land, but I'm going to graciously accept this wonderful, amazing gift of ayahuasca from my teacher. But you're right, there's a issue with the balance. Like, there's going to be some people that are not going to be okay that you're taking peyote, or they're not going to be okay that you're using psilocybin. And then there's some people that are going to be, but you have to stand up and be strong, be courageous, and, you know, say your truth, say your belief. And I know these things will be very effective, but just to be gentle, very gentle. Does that answer?
Yeah, I think that's terrific. So we have, I mean, I think we have a lot of therapists, a lot of practitioners who are with us today. And I think a lot of them are going to be wondering, so as we move forward with these kinds of therapies, what is, you know, is there a way, what is going to be the role of more traditional healers and traditional knowledge? Is there a way that I, as a practitioner, I'm not a practitioner, but is there a way that a practitioner can, you know, make sure that there's a role for that, for them? You know, does it mean partnering with traditional healers? Does it mean, you know, understanding the culture? Or is there training? Like, do you have any thoughts about how you make sure those two stay in dialogue as we move forward?
I teach. That's the first thing, is you teach any psychotherapist that would be wanting to take on that role. And the best way to teach is just to get the plants themselves to teach. So what we do, and this is just a traditional way of doing it, is we don't eat salt, sugar, or grease for 10 days. And then I drink a plant 3 times a day, whatever the plant is. The South American ones, they're kind of my favorite right now because I know more about them. But spending the time on a dieta would help prepare you for some of the teachings that would follow. So just doing a dieta and then maybe taking psilocybin during in a higher dose, like once, even at the end, that would educate the person. Now, when it comes to a psychotherapist, you know, trying to help other Indigenous people, maybe go into a sweat lodge, go and see what that feels like. And, or even, you know, go to a drum circle. I know if there's a discomfort with a lot of, you know, therapists, they feel out of place in places like that. But if you're in a really good spot, they'll always welcome you to teach. So yeah, that's what I got for you. I hope
Yeah.
I was going to say everything I meant.
Yeah, no, that's really great. Darek, did you have any thoughts or questions that you wanted to?
Here in Winnipeg, we had this initiative. I'm not sure whether it's still going, a reconciliation initiative, and there were, I don't remember the name of the guy who spearheaded it, but it was after the Truth and Reconciliation report was released, and my wife Jessica, she volunteered for these groups, and she found there was a lot of value in these groups. Half of the members of the groups were Indigenous people, and half of the members of the group were non-Indigenous Canadians. I wonder if you in any way foresee that this area of broader kind of psychedelic assisted psychotherapy might in any way play into the forces of reconciliation and healing and, kind of wellness for everybody. So hopefully the world will be moving that direction, do you think that that's just general idea of these sorts of forms of healing, whether it can play a role in the near future to make this world a better place for everybody?
Yeah, I do believe so. I believe that the psychedelic renaissance is gonna birth a whole new generation of peoples that will actually contribute to the broader understanding of what medicine really is. Now, I don't want to downplay medicine practices from the past. What I want to say is that they were not allowed. We were not allowed. We were murdered. We were hung. We were told we weren't allowed to do any of this. And so I think that the Indigenous, I can't even say it in my perspective is going to help us move this along, because I know where I come from. I know I come from the land. I know I'm made of the land. And I know that with this little bit of a renaissance happening, that maybe our old practices are going to resurface. Now, not just maybe, but the great thing about ayahuasca or any other connecting kind of medicine is that I remembered things that were in my bones. And I know other Indigenous people that remembered things that are in their bones. And they were more cultural because of what they were doing. They were more cultural because of using psychedelics. So like I said, it's just going to be little by little. This is reconciliation. This is one of the actions of reconciliation that was not in the recommendations. This is it. This is our recovery. We can recover very quickly. Like if we got the chance of using Ibogaine more consistently and at a cheaper price for people that are, got stuck on the Western medicine of opiates, like really that would save us. So this is reconciliation. This is part of it. And this is the psychedelic renaissance. And one day when the Enlightenment's here, maybe we will be reconciled. I just pray. I pray for that.
And so do I.
Mm-hmm.
There was another question, Jazmin. You talk a lot about the connection with the land, and I very much echo your sentiment in that way, in my own way. Psychedelic assisted psychotherapy is currently the research. I feel like I should be quiet for a bit. Psychedelic assisted therapies for the research currently is done in very comfortable clinical settings, away from more natural environments. Do you have sort of like anything to say on that? And once this psychedelic therapies, when they become safer, we know more about them, etc., etc., would you see the role of psychedelic assisted therapies as sort of tools to reconnect with our ailing ecosystem and our little green lining that is not doing extremely well?
That's a great question. And right away, I have this wonderful vision of my healing center. Even though I just got the land, it would be wonderful to see some of this psychotherapy be done in a more of a landscape of the land. So where I am, I'm pretty close to town in Kenora. I'm 5 minutes from the hospital by boat. But if we could use eco lodges, like they're small kind of structures that you can stay in that are built on and in the land. So doing psychedelic psychotherapy in eco lodges would be really, really awesome, be really effective for people. I know that we're going to be building within the next 5, it should be done in the next 5 years, a space where, other therapists can come in with their psychedelic psychotherapy and perform what they need to from where I am. So that's what I see for the future of this, is that I will be helping to house as many people as I could to be able to deliver this therapy. When I told my neighbors I wanted to have an addiction and treatment center, I don't think they knew what I meant. This is what I mean. Exactly is that we will be closer to the land to be able to connect and use whatever medicine to be able to do that. That's my dream.
Wonderful, wonderful. And I think if you would like people to stay connected with you, Jazmin, maybe in the general chat you could write down whatever it is that you like, wherever people can find you. And
I'll give my email, and I have a Facebook group too, as well.
That's great. And I personally look forward to reconnecting with you after this COVID epidemic is over, in person. And Jazmin, I'm really honored, and thank you very much for being with us today.
Thank you so much for having me, and good luck, everyone. I look forward to everything.
Well, thanks so much. So I think what we can do, we can take about 5 minutes, shall we say? I think Ken is ready, so I don't want to hold back too much, because I want to make sure he.
In case somebody wanted to cut, you have 10 minutes. You want to do that?
Okay. Okay, so we'll say we'll be back in 10 minutes, 3:20, and we can stretch our legs, and then we will have our 2 final amazing presentations.
Hi, Thomas, can you hear me? Are you able to speak to me?
Hey, Ken.
Oh,
Yeah,
hey.
we
Okay,
we
great.
can hear you. You're doing very well there. So
Perfect.
we're gonna be on in like 3 minutes. Yeah.
Okay, so I will. Should I actually just set my?
You unmute. You muted him.
I know because everyone can hear it.
That's okay. I think no. Hey, Ken. So everybody can hear us, just so you know.
Okay.
In case you
Hi,
wanted
everyone.
to say. So did you want to ask a question?
Nope. Just when are we going to get going?
Yeah.
And just let me know if my slide deck isn't sharing properly right away, but hopefully it'll work.
Oh yeah. Hopefully it's gonna work. All is looking very well. Okay, we'll be back in 2 minutes.
Sure.
People back?
Okay, you guys want to come back on? Yeah.
So I think we're back. I think people can hear me. I'll just say a couple of general housekeeping things before we go. So I really want to encourage people to put questions in the Q&A. We can't always address everyone. There's quite a few, and they all look really interesting, the ones I can see. But you know, we do have the limitations of time. But I hope that doesn't discourage people from participating. And I think that even if your thoughts aren't addressed by the speaker, I think it's often really helpful for people to see what questions other people have, and maybe there are people out there who have some answers. So so we do have two separate venues. One is Q&A, which are questions to be directed at the speaker, and we're monitoring those for our own use during the question session. Then there's the chat, where everybody can just connect to one another without necessarily it being directed at the speaker for the question period. So I encourage you to participate in both of those. So we have two sessions left, and then hopefully everyone knows how to get in touch with us if they're interested in follow-up. And have any further issues, questions, or are looking for copies of presentations, we can find out if the speakers want to share those. So so I think we can get started. I think I'm really looking forward to this talk. Ken Tupper is somebody who's done a lot of really interesting, really fascinating academic work, but then he's also been very active within government. And I think that and within various kinds of levels of government, I think that it's really easy when you're talking about a topic like this to sort of demonize government and to see government as a kind of enemy to progress. But I think maybe Ken shows how even within government there are all kinds of processes that go on that are interesting and allow for interesting debates. So Ken is he is an adjunct professor at the School of Population and Public Health of the University of British Columbia, and his doctoral research developed the concept. I hope I'm getting this right. Maybe Ken, you can just nod here. Entheogenic. Actually, maybe you should say it. Entheogenic.
Yeah, entheogenic education.
Entheogenic education. So it's an actual, it's a really interesting theoretical framework for understanding how psychedelic plants and substances function as cognitive tools for learning. So I'm not sure if he's going to talk about that explicitly, but I think it's really great to see that kind of model. I think that's a really sophisticated, interesting model. So I encourage you guys to find out more about it. And he's working on some issues around government regulation and cross-cultural adoption of drug practices and so on. And I don't want to preempt what he's going to say, so I'm just going to turn it right over to him. Thanks so much for being with us.
Okay, thank you, and hello everyone. I'm not going to speak about entheogenic education. I mean, if questions come up perhaps at the end, but I'm going to stay focused on MDMA-assisted therapy, and particularly sort of training and regulation, training, education, regulation sides of what's unfolding in the sphere of the reemergence of psychedelic medicine. So I just want to first of all acknowledge that I'm presenting from the traditional unceded territory of the Sanguin-speaking Coast Salish peoples, including the Songhees and Esquimalt First Nations. I just want to also do a bit of a conflict of interest disclosure. I'm a director at the British Columbia Ministry of Health, but want to make very clear that my ideas here are my own and not representing those of my employer. I'm also a member of the advisory board of MAPS Canada, which is conducting MDMA research. I was co-investigator for that project when it got going. I've also received speakers honoraria, and I'm doing part-time ethics and research strategy consulting for Entheon Biomedical. So with that out of the way, I'll just start off by just speaking about the eclectic practice of psychedelic therapist training, or essentially psychedelic therapy. I should also disclose I am not a therapist and not a clinician. I'm an academic and policymaker, but I hang out with a lot of clinicians and therapists, so I'm drawing on my understanding of this from their practices and from the academic research that's been happening. So psychedelic therapy is, yeah, essentially a unique and eclectic clinical practice. It draws on lots of different types of experiences that clinicians already have in their toolbox. It certainly requires to be informed by understandings of trauma, adverse childhood experiences, which obviously can be strongly related to many of the issues that people may be facing and why they're seeking psychedelic therapy. And then also to acknowledge there's a spiritual or transcendental dimension of the experience that perhaps differs from some of the traditional therapeutic approaches that are more grounded in sort of biomedical, psychological frame. I'm going to give a shout out to the California Institute of Integral Studies, which is certainly the first formal institutionalized training program for psychedelic therapists. Although I understand there's others that are going to be coming online, certainly lots of interest in how to do further work in training therapists. So that is going to involve pre-service education for students who are in current programs planning to become, not yet accredited, but planning to become therapists, for learning about this area of clinical practice. I often tell students that it's a growth area, that the real sort of limitation of availability of psychedelic assisted therapies is not the medications, it's the trained clinicians who are qualified and able to deploy them. It also requires continuing education and professional development, including unlearning past false beliefs about psychedelic substances, many strong opinions about these substances, and often they're based on misinformation and sort of war on drugs paradigm. This could also include academic detailing programs where people like pharmacists or nurses go and visit clinicians to speak about the potential therapeutic benefits of particular medications. This is modeled on what pharmaceutical industry does for new drugs that they're marketing, but academic detailing is more a sort of public benefit approach. and continuing medical education accreditation for conferences or workshops. I don't believe this one has, but certainly some psychedelic conferences are now starting to get this, and other currently accredited conferences are including psychedelic topics on their roster. So that's often an important way for clinicians to learn. There's also the expanding scope of practice for health professionals. So the various types of folks could become psychedelic therapists. So physicians, licensed practical nurses, registered psychiatric nurses, potentially there's going to be a role for pharmacists, naturopathic physicians, psychologists, et cetera, et cetera. Also spiritual guidance counselors may be well suited for this kind of work, although they're not a sort of health professional. But again, it kind of bridges that health and spirituality concept. There may even be a new classification of a psychedelic supervisor, a new professional designation that would emerge out of the research and the clinical experience that's being garnered. One of the issues that also has to be considered is health professional liability insurance, where currently accredited clinicians need to ensure that their insurance bodies are able to and willing to cover the work that they're going to be doing in this regard. All of this is sort of seeds to plant for how to bring these types of clinical practices into the mainstream health system, which I'll speak to more later in the presentation. Sorry, just trying to get my slide there. Yeah, so also professional colleges, boards, or associations, which are the self-regulatory bodies that ensure that their registrants are qualified, competent, and following ethical standards of practice, need to be educated and brought on board. And this is happening already. But as more evidence comes to bear on what's happening, these professional oversight bodies certainly need to be understanding how they can best ensure safety and efficacy. Well, more sort of safety and public interest benefits are realized through these practices. In terms of the more practical side of things, preceptorships, basically having experienced clinicians mentor new clinicians who are getting experienced and offering that sort of hands-on type of opportunity. And that's, for example, the CIIS program that I mentioned is trying to do that and giving people the opportunity to do this work where it's currently available. And mostly that's in research projects, although compassionate access seems to be very, very close on the horizon, or for example, in Oregon, very recently, perhaps a whole new sort of industry is going to sprout up. And also developing and refining professional guidelines and competency. So I won't get into the details. Janice Phelps at CIS has done some good thinking on this already, and certainly lots of other people starting to really think about integrating the psychedelic clinical practice knowledge into their professions. There's also questions around social justice, certainly lots of discussion about who has access as patients, but also who has access as trainees, and questions around how gender, race, sexual orientation may affect the therapeutic relationship and patient outcomes. So that's certainly a topical discussion these days, and certainly needs to be considered by everyone who's involved in this. I want to speak, however, a little more length on the importance of firsthand experience and what I describe as psychedelic empiricism, and sort of recognizing that self-experimentation or firsthand experience has a long history in science, especially in psychoactive substance research. So the discovery of, for example, properties of distilled alcohol by Arab alchemists, sort of very early modern science, but then with the sort of development of modern chemistry, some of the great discoveries in psychopharmacology were by individuals who basically experimented on themselves. Humphrey Davy working with nitrous oxide in the late 18th century. Arthur Hefter, who worked with mescaline. William James also experimented with nitrous oxide. And then perhaps most famously, Albert Hoffman's discovery of LSD, or discovery of the psychedelic properties of LSD by self-ingesting. So it's an interesting sort of phenomenon in terms of and I really frame this as an epistemic sort of philosophy of knowledge question. There was a shift in the 19th century towards objectivity as an epistemic virtue that was grounded in part because of the new tools such as photography that tried to remove the scientist or observer from the equation. And through this process, gradually self-experimentation began to be regarded as suspect or delusional and certainly not acceptable professional practice, which is what emerged in the 20th century. A good example of this is the sort of popularization of the Jekyll and Hyde sort of, the dangers of self-experimentation and what sort of the moral lesson as to what might happen in this regard. And with the dawn of psychedelic science in the post-discovery of LSD, when some of the early clinicians were starting to do research, they very much embraced the idea that clinicians themselves should have personal experience and actively encourage their colleagues to have this experience to better understand what they were working with. And it actually became a bit of a challenge for the randomized control double-blind methodology that was starting to become the gold standard in medical research. So this is certainly well explored by Oram in this article that I've got cited here. So essentially first-hand experiential knowledge is desirable, maybe even necessary. That's a debatable question, but to establish empathy with research subjects or patients, to validate the interpretation of experiences and data, and to participate in emerging discourses of intersubjectivity, which may not lend themselves to quantification. So it's really a sort of different kind of paradigm of knowledge that we're talking about here. And then sort of come full circle with MDMA, of course, Anne and Sasha Shulgin, Sasha sort of rediscovered MDMA and again, through self-experimentation, found it a highly interesting molecule and then started to talk about this in a small circle of first friends and then clinicians who started to work with it underground in the 1970s, which is the current clinical research is certainly drawing on this. So Sasha Shulgin and Anne wrote 2 books, PCAL and TCAL, based on their self-experimentation practices, a sort of true scientist or natural philosopher. So this is sort of a characterization. I'm going to move now to the sort of regulation side of things and how research and evidence is drawn upon by policymakers and the sort of hierarchy of evidence. This sort of so the first-hand or experience or anecdotal report is certainly very much at the bottom. I actually realized I didn't put traditional Indigenous knowledge in here, and it probably should be included, although I think it would also be at the bottom currently, and one might hope that it gains greater currency for health policy making going forward. But the sort of gold standard randomized control trial assay is at the top, and then the systematic reviews of meta-analyses of these is what's most sort of solidly drawn on for policymakers. And so where we're at right now in terms of research, this is the different phases of clinical trials that result in policy decisions. We were able to now the phase 1, 2 work. Well, phase 1 actually, I think Rick Doblin can speak well about this. Is how MAPS was able to draw on some of the NIDA-funded safety data on MDMA and sort of bypass some of that and move straight into phase 2 clinical work. We're now at sort of multi-site phase 3 study with expected results, I think, in the next couple of years. And that's when, and I'll go through this in more detail, the drug review process kicks in for regulatory approval. And then following that, there's post-market safety and pharmacovigilance. So this is the sort of pharmaceutical industry steps going from 0 to 4 in many, often takes many years and multi-millions of dollars. So I'm going to speak specifically to the drug review process in Canada. And I'll go through each of these sort of columns in greater detail, but a drug sponsor or pharmaceutical company, in this case, I think I'll use the example of MAPS, will, following the completion of phase 3 clinical trials, if they bear fruit and there's some solid evidence that this may be something they want to bring to market, then they submit an application. It's called a new drug submission to Health Canada's Health Products and Food Branch. And they look at safety, efficacy, and quality control standards, including information about production and manufacturing, packaging and labeling, and information about therapeutic claims and side effects. So all of the data that's gained from the phase 3 studies is submitted to Health Canada, who then goes through this very rigorous process and ultimately makes a decision. If they conclude that the benefits outweigh the risks and that those risks can be mitigated, then the drug's issued what's called a notice of compliance and a drug identification number, and then it becomes essentially a medicine. And at that point, it could be approved and marketed in Canada. However, that's not the end of the story. In Canada, of course, the constitutional division of powers is such that provinces and territories lead health and fund and deploy health system resources. So there's a next step, pan-Canadian drug review process. Canadian Agency for Drugs and Technologies in Health basically will take, once a drug is approved for sale in Canada, it's gotten the Health Canada approval, then CADTH provides an evidence review on behalf of various government agencies, drug plan managers, regional health authorities, hospitals, health professionals, and consumers. And they do what's called a common drug review and review the evidence and then make recommendations about whether or not these should be funded in provincial or in some cases federal drug formularies. And that's where it really becomes accessible to the masses. Otherwise, a drug that's marketed but isn't approved for inclusion in the provincial health plan, it's available sort of privately for folks who can afford it, but not more widely. So this third step happens where provincial governments take the common drug review done by CADTH and consider themselves what kind of coverage this might get, whether it's a regular coverage, i.e. broadly accessible, or limited, perhaps based on certain kinds of criteria. Then look at procurement processes, health professional compensation structures. So how are, in the case of MDMA-assisted therapy, it's a really, and psychedelic therapy more broadly is a challenge because it brings together the pharmacotherapy side of things with psychotherapy, and those are two very different worlds in our current health system. And bringing them together in terms of compensation structures is going to be not an insurmountable impediment, but certainly something that's going to require lots of thinking. Health human resource planning, again, speaking to the training of therapists, capital expenditure decisions. Will sort of custom or bespoke clinics need to be created for some of these types of practices, and health economic modeling. And ultimately, I think that's what's going to be the most convincing for policymakers, is looking at cost effectiveness, the ratio of the cost of an intervention to the relevant measure of its effect. This is, and then we can look at individual patient outcomes, population level outcomes in terms of reduced burden of illness, and then health system outcomes where you can demonstrate reduced expenditures on treatments that have limited effectiveness and start spending where we see more bang for the buck, so to speak. And fortunately, just last month, MDMA-assisted psychotherapy has been reviewed for cost effectiveness, and I think that's a really great step towards seeing these MDMA at least, and we'll see other medications like psilocybin probably coming online with these types of analyses as well. So with that, I think I've blasted through quickly. I'm going to stop here and welcome any questions that people have.
Unmute. Okay, finally I managed this one button. I can. So if you were to sort of just recap for people are probably interested about the near future. So you were talking about Canada, so maybe you should stick with Canada. if you were to make some predictions so that people understand about the timelines, for example, and so that's one question about the timelines. And then a related question I have is about the role of private healthcare system and then public healthcare system. How do you see, which is related to access, cost, and all these issues. Do you want to talk a little bit about that?
Sure. So, well, with respect to timelines, I'll actually defer that question to Rick Doblin, because I think he's got the master plan in mind. My understanding is, when the phase 3 clinical trials are done, and they're planning to take the results to the U.S. Food and Drug Administration, and then probably Health Canada and European Medicines Agency to start off with. I think U.S. FDA is their first target, and then we'll see again. The process of Health Canada's approval takes a bit of time, but I think less than a year would probably be sort of envisioned, and then the next step of CADTH review and provincial government reviews will probably take a few more years after that. But there may be a case for compassionate access to be made. Again, I think Rick can speak to how they've achieved that in the United States. And recently here in Canada, we've seen compassionate access granted for psilocybin mushrooms for people with end-of-life anxiety and depression by a project called TheraSil, actually based here in Victoria. So there may be other avenues to see these therapies become more widely available, even before the completion of a phase 3 clinical trial and something being brought to market in the sort of traditional channels. Okay, and your next, sorry, the second part of your question was...
I still want to ask this part of the question. So the way you just talked about it, once MDMA-assisted psychotherapy is approved by FDA in the States, and it's available, widely available, it will still take, as far as you understand, several years for the approvals to come in Canada?
Well, so it sort of depends on the sponsor. It has to be done by a sponsor, so it's going to actually, the ball will be in MAPS's court. Sorry, I keep throwing out this to Rick, to basically take it forward, and they're going to have to make decisions about where to invest their resources. And I think my understanding is they're going to start with the US, but then assuming they do bring it to Health Canada, I mean, I can't speak for Health Canada, and certainly they have, I say, a very rigorous process that they would follow, and they wouldn't I don't think make any exceptions for this necessarily. They would apply the same rigorous approach to this. And then, as I say, if Health Canada then grants a notice of compliance and a drug identification number, then it is available for a sort of essentially private funding. So private clinics, and I believe with using MAPS, produced MDMA, MAPS trained therapists will be required. And so there are some already in Canada, and hopefully it'll be more. They would be able, presumably, to offer it on a cost recovery basis. I'm not sure of what sort of economic models are, but that would, again, be fairly limited access for people who have the means. The broader access would come once a provincial government, and I should also say the federal government, so for First Nations health and for Canadian Armed Forces, those are actually, the healthcare for those groups are funded through
Veteran Affairs.
Yeah, Veterans Affairs and First Nations health bodies. So right. There is a role for the federal government to play in delivery of health services, but the most access is going to be coming through provincial governments, and each provincial government will make its own decision based on their own assessment.
Okay, so there will be a little bit of a delay with the public health system to adopt this technology.
I wouldn't say delay it. It's just it's not going to be an immediate process. There is a process, yeah. And it'll take a while to unfold. Yeah.
And you work with the BC Ministry of Health?
Yeah, my day job is the BC Ministry of Health. But again, I want to reiterate, I'm not here speaking on behalf of the Ministry of Health.
Absolutely.
This is my academic work that I do on evenings and weekends.
Okay, wonderful. Neil,
but certainly, I draw on some of my professional knowledge from my day job to inform my academic work.
Can I ask you about the cognitive model, since we do maybe have a couple minutes that you could maybe just get into it a little bit?
Yeah, how long do you have?
Well, we got a few minutes. Yeah.
Sorry, what specifically?
So I'm just wondering what the model is, and how how you apply it to sort of understanding cognitive process.
So, I mean, very loosely, I guess, or sort of off the cuff, entheogenic education was my original interest. So when I first became interested in sort of psychedelics as a topic of academic research, it wasn't so much in the therapeutic uses. It was in the cognitive enhancement, or sort of educational, is the way I described it, ways that these could be considered tools for learning. I drew specifically on a Soviet psychologist named Lev Vygotsky, who's sort of very big in education. And he talks about cognitive tools being a sort of crucial mechanism for the development of our facility with different types of cultural repertoires. And he uses literacy as his sort of primordial cognitive tool. And I would argue that there's also, if you look at traditional indigenous knowledge practices, where these types of plants and substances have been used for hundreds or thousands of years, there's a sort of body of learning and practice, and often explicit metaphors of like plant teachers. The indigenous groups who use plants like ayahuasca in the Amazon, or peyote cactus, psilocybin mushrooms, have all got examples of descriptions of these experiences as learning experiences, in addition to being healing mechanisms.
That's really fascinating. I mean, I'm wondering how you think that could be institutionalized. Is there any way to import that kind of model into any kind of educational setting, a university, or?
Well, I would first of all distinguish between schooling and education. So I'm speaking sort of education at a very sort of abstract philosophical level, and schools, I think, are in some places, in some ways, the sort of least likely places to have these, and they're institutions of the 19th century, largely unchanged. But experiential education model like Outward Bound has been something I've mulled about. In fact, a friend, John Ince, suggested we could use the term inward bound for a program of education that would, in some ways, again, draw on looking at traditional indigenous knowledge practices for enculturation, that there would be ways of taking not very young people, but late teens, early adults, into a kind of ritualized, perhaps, experience that would be not just for people who are seeking treatment, but for the idea of being, Bob Jesse describes it as better than well, that people who are healthy can also benefit from these kinds of experiences. When they're used, these substances are, the metaphor of tool, I'll sort of elaborate, it like a knife, a very powerful tool in the hands of a master chef or a skilled surgeon. A knife can be extremely powerful, but in the hands of a child who thinks it's a toy, it can be dangerous. So there's a certain sort of import of respect and a sort of cultural container that these types of practices need to be set into to realize the potential benefits.
So somebody was just asking about just the terminology and where they could follow up for a little more understanding of that. I mean, have you published on that, and have other people published on it?
In fact, the Canadian Journal of Education, I published one of my first papers, I think 2003, on the idea of entheogenic education, existential intelligence. I was drawing on Howard Gardner's multiple intelligence theory, arguing that there's a sort of type of unrecognized or unrealized intelligence that might be fostered through the use of these kinds of substances as cognitive tools. So I think almost all I've written on this is available on my website, that I have up on the end of the screen, the end of my slide deck there.
Okay, that's great. So I want to push you a little bit on the policy end. Again, not asking you to speak on behalf of any government and from a policy perspective, but
Sure.
Just somebody was asking about what the policies are going to, it would be in an ideal world and might be more realistically, if these therapies start to be approved, in terms of getting them paid by Medicare, and how we're going to be able to approach government about a payment model.
Well, I mean, I'm an optimist, and I think ultimately, as I say, the health economics argument is going to become so persuasive. I mean, right now, governments are spending in Canada, huge amounts of money on treatment models that are of very limited effectiveness. So, for example, for anxiety and depression, post-traumatic stress disorder, the medication options are pretty limited, and the ones that they have are, I describe it as help some people some of the time. But it seems from the research that's been done so far on MDMA-assisted psychotherapy, psilocybin-assisted psychotherapy, that the effects may be for a select treatment population. So again, we need to see more broad-based phase 3 clinical trials to really see how widely generalizable these findings are. But the health economics logic will be incontrovertible, that governments will take a look at the books and say, we can spend a lot of money on something that doesn't work so well, or we can, and again, these medications that are often given to people are daily dispensed, daily consumed and go on for regimens of months or years or in perpetuity, which does great for the shareholders of the pharma companies that are selling it, but costs governments a lot of money, and most importantly, doesn't often get to the root of issues for patients. And that's where psychedelic therapy just seems like such a transformation, a real paradigm shift, where we do see significant, I mean, just a couple of days ago, the new randomized control trial out of Johns Hopkins showing full remission for people with major depressive disorder in over half the patients. It's really, astounding results. It's exciting.
That's great, Ken. And the last question for you. If we consider the worst case scenario in terms of approvals, what do you think? Is there anything that you can envision going wrong, and what would it be in the process from now until these therapies are approved from the regulatory point of view?
Yeah, well, I mean, it depends, I guess, on what you describe as being wrong. I mean, certainly, adverse event or events, plural, would derail things if there was some very high-profile adverse reaction like death or suicide or something like that. That would certainly set things back. I don't think it would necessarily derail it completely. There's certainly a lot of discussion about the concerns of the sort of venture capital world that's getting involved into psychedelic medicines, and that there's the potential sort of co-opting by big pharma of these types of things. I think there's a role, in my own opinions, I think there's a role for all different parts of society, including the sort of market-based approaches, but certainly would like to see public benefit as our most important. And that's where, our elected officials ultimately need to be accountable for, ensuring that it's the public that benefits, not just corporations.
Right. Okay. Great, Ken. Well, we know you're a busy man, and we really appreciate you being with us. Thank you so much.
I appreciate you being able to share. It's a pleasure. Thank you.
Great. Thanks. So this will be now the last presentation of the day. I'm very excited for this presentation. And Rick Doblin is the founder of MAPS. He's the activist and the visionary behind MDMA-assisted psychotherapy. So Rick Doblin founded MAPS in 1986, 30-some years ago, just around the same time that MDMA was put on Schedule 1 by FDA. And he's been working on this for a long time. And I really like what Julie Holland once said about Rick Doblin. So I'm going to say it again. I said it a week ago. By the way, I interviewed Rick Doblin for 2 hours a week ago, and that will be the first episode of Enhanced Therapy podcast. So I'd encourage everybody to go to enhancedtherapy.ca and just sign up for our blog. We will have Rick's interview there very soon. So Julie Holland said that when she thinks about Rick Doblin, what she sees is a little kid on a tricycle ramming into a brick wall over and over and over again until the brick wall slowly starts crumbling. Here we go, Rick Doblin.
Well, thank you very much for that interview. Wow, for that introduction. And but I'd like to say that the whole time that I spent running into the brick wall, I wasn't actually hurting myself. And, you know, I took the long view. And so it was something that I had to do, but I felt like I was gaining strength over time, and the wall seemed to be on very crumbly foundations. You know, listening to Ken about the counterproductive nature of the drug war and all the changes that we need to make for that. So I'm going to see if I can share my screen and if this will work really quickly. If not, I'll just talk, and I'm really looking forward to various questions, but I'm going to see if I can share the screen and see if this works. Let's see. Okay, does that work? Do you see that?
Yes, I can see that. I
Okay,
think everybody
great.
else can. You see that?
And do you just see one slide, or do you see the
I see the side slides and the main slide.
Yeah, maybe press F3.
F3. My tech guy says F3.
There, yeah.
Okay, how's that?
That's it.
That's good.
Okay, great. Okay, so this I'm going to go through this pretty quickly, just to leave more time for discussions. But I'm just going to present some ideas here, and give the vision for the future as well. So to start with, I just want to really remind people, this was during the 60s, Zap Comics, Mr. Natural. That's what we're all doing. We're going on this quest into the unknown. I had a t-shirt of this, and whenever I wanted to take LSD and I wanted my friends to know what I was doing, I would wear this t-shirt, which I still have. It's kind of ratty now, but we're off into this quest into the unknown together. This is just the structure of MAPS. I heard also Ken talking about public benefit. So we have MAPS as the nonprofit, which is the 100% owner of the Public Benefit Corp, which is a for-profit. Around 2/3 of our staff are at the Benefit Corp. Now we have about 100 staff, and around 1/3 are at MAPS. And the public benefit is basically the pharmaceutical arm that will develop MDMA-assisted psychotherapy for PTSD, hopefully into a medicine. A very promising preliminary data from our first phase 3 study. And then we will actually market MDMA as a prescription medicine for PTSD. And whatever profits are made go back to MAPS and to the mission of the nonprofit, because it's the 100% shareholder. So this is sort of, people get tax deductions for donating to MAPS. MAPS goes, invests in the Public Benefit Corp. And just to talk a little sophisticated, we didn't really need it until we had a product to sell. We could have kept all the research inside the nonprofit, but by creating the public benefit in December of 2014 and moving all the research to that Public Benefit Corp, we're building up net operating losses. And so we're going to have somewhere in the neighborhood of 50 million or so, 60 million net operating losses, and that'll shield the first 60 million of profits from the sale of MDMA, and at a 20% federal income tax, somewhere like $10-12 million. So that's why we created the Benefit Corporate. We also wanted to really communicate success, that we're envisioning success. What made it possible to think about a sustainable nonprofit and selling MDMA actually is this law that Reagan passed, signed into law in '84, providing data exclusivity, incentives for developing drugs that are off patent. And so while we have exclusive use of our data, somebody else could develop MDMA for PTSD, but they'd have to use their own data. And the data exclusivity is for 5 years. We're going to have to do studies in pediatric populations. If it works in adults, we get 6 months data exclusivity extension for that. And it takes FDA around 6 months to evaluate generic manufacturers on purity, potency, stability, all of that. So basically 6 years, and 10 years in Europe for data exclusivity. So, and then if we make MDMA into a medicine for things other than PTSD, it's a 3-year data exclusivity. So that's the period that we're going to try to use to make some money, but in a reasonable way that maximizes public benefit. Since its founding, we've raised over 100 million in donations. So it's kind of been astonishing to add it up. But none of those are investors. Not a penny of that is investment. It's all donations. Now, we talk about integrating psychedelics into society, and that's our goal. And our goal is mass mental health. And really, it's important to recognize that this is not the first time. We're not trying to integrate psychedelics into our society for the first time. From 1600 BC to 396 AD, almost 2,000 years, the longest running mystery ceremony in the history of the world, the Eleusinian Mysteries with a psychedelic component. And everybody that's anybody from the Greek times that we think of as the cradle of our Western civilization, you know, Plato, Aristotle, Pythagoras, everybody, they all participated in these ceremonies. So there was a psychedelic core to the Western society. It was wiped out in 396 by the Catholic Church. People that want to exert power and place authority between you and spirituality. And so now it's taken 1,624 years or so to the current psychedelic renaissance. So it's a long historical sweep, and we are trying to re-spiritualize, but with the addition of science at the time. Now we have really science to separate out what's accurate, what's not. Just to give you a sense of the publications in psychedelics as the Web of Science, you can see in the 60s and 70s, there was a lot, and then it went way down, but it's been starting to increase. And now it is a psychedelic renaissance, but more than ever before, more than even in the 60s. And the culture has learned a lot. So I think we're in a lot better position to integrate without a backlash. Just to give you a sense of where we are politically with regulators, this was a psychedelic looking slide that was made by the FDA themselves, the Department of Psychiatry Products. And they announced that they're going to be doing guidance documents that would be for sponsors of research that want to do work with psychedelics. So they're going to be working on a psychedelic research guidance document. This just shows for me how mainstream it is. This was my TED Talk, and I went to just check on how many people were watching it, and I saw that the National Security Agency had bought an ad on my TED Talk. And I think they just had a deal in general with TED for a whole bunch of things, but it just seems like, yes, the National Security Agency is looking for trippers who might want to work for the government or so. I don't know if that's really the case, but just shows that this really is being mainstreamed. And another example, Sarko Gregarian, a police officer who's actually a psychotherapist who's going through our training program to become an MDMA-assisted psychotherapy to help police officers with trauma. And it'll end up like this. There'll be thousands and thousands and thousands of psychedelic psychotherapy clinics. And why I'm saying here, MAP certified MDMA, Compass certified psilocybin, Unitas, USONA certified, is that we will train people to deliver MDMA assisted psychotherapy, but then they can innovate. They can do all different things that they want to. The FDA, DEA can't limit the practice of medicine. But if you're certified by MAPS, then you will be delivering the therapy that we taught you, and people will know what they're getting. And so these different psychotherapy clinics will have therapists that are all wanting to be cross-trained between MDMA, psilocybin, ketamine. Now, ketamine-assisted psychotherapy, it has no company certified because it's been made into a medicine without psychotherapy, just as a pharmacological treatment, which I think is not benefiting the public the most. It's not maximizing therapeutic outcomes, but again, pharma companies generally don't know about psychotherapy. So a lot of the therapists are innovating and developing therapies to accompany ketamine for depression. So anyway, we'll have psychedelic clinics, we'll have thousands and thousands of them, we'll have certain different kind of networks of them, and the people will come to them for a lot of different purposes. The way it's going to be regulated by the FDA, by Health Canada, elsewhere through the REMS, risk evaluation and mitigation strategies. It's because it's therapy, psychedelic assisted therapy, it will only be prescribed by people that we've trained, and only therapists that we've trained will be able to provide the treatment. Now, not all will need to be therapists. We have a 2-person therapy team. One will be a therapist, the other will be a student, could be eventually a body worker, a music therapist, but the idea is an apprentice, some kind of an apprentice working for free or for a low cost. The idea is that we want to keep the 2-person model because we think it enhances safety and efficacy, but we want to keep the costs down so that it would be adopted by insurance companies and national healthcare. There'll be certain kind of safety screenings that must be done for certain kind of populations. It's only administered in clinics, meaning it's only administered under direct supervision. The FDA is now starting to say that maybe sometimes, particularly when we do, if we ever get it approved for hospice or end of life, that therapists could go to people's houses. That might be possible. But it's only under direct supervision. And then the pharmacies are centralized. They only ship to the prescribers, not to the patients. These are all things that we think we're going to have. Under the line are things that we might have. This patient registry, which is the case for ketamine, for GHB, for a lot of other drugs. And maybe FDA could even say there's a lifetime limit of doses you get of MDMA for PTSD, which would be okay for us. We don't want this. But if 10 or 12 doses of MDMA haven't helped your PTSD, it's not likely to keep working. Maybe it doesn't work for everybody. You need to try something else. But this is how I think it'll be regulated post-approval. We have now done a cost-effectiveness study. One of the big ethical questions is going to be this idea of, can we get insurance companies and national healthcare to pay for it? So we've just published this paper in PLOS ONE cost effectiveness study, and what it showed is that it's break even after 3.5 years for MDMA-assisted psychotherapy. That's what MAT means. So we believe that we will be able to make the case to insurance companies and national healthcare. So this was Elliot Marseille, who's a healthcare economist at UC San Francisco, did this. Another ethical issue is going to be providing access to all the populations that are suffering from PTSD. And we've had in our phase 2 studies and also in our phase 3 study, underrepresentation of African Americans. And it's generally true throughout all clinical research of all kinds of drugs for all different things. So this was September 27th, 2020, just a month and a half ago. And this was the cover article of the Washington Post Sunday magazine. And it was about our project training therapists of color and the question, who will benefit from psychedelic medicine? So we feel, though, that the key to getting patients of color is to get therapists of color. So, indigenous, from all different minorities. Not to say that those are the only people that should treat people in their cultural group, but that we want to make sure that there are enough culturally sensitive people that can provide it. This is our therapy. It's pretty rigorous in parts. There's an online course. This week-long in-person training, because of COVID, has now gone virtual as well. There's one going on right now for a bunch of European therapists and therapists from Somaliland, Africa. We're trying to globalize. Then people do this experiential elective, learn something else about non-ordinary states or something related to this therapy. Then we have a protocol where people can volunteer to receive MDMA as part of their training, receive it as a patient in a therapeutic setting, not that they have a clinical indication, but we all have issues to work on, and MDMA can be helpful in that way. So we think giving MDMA to opportunities for therapists to take MDMA is really important. And we're negotiating with FDA about expanding this study. We've been approved for 120 people. We've done about 90 or so. The results are really strong. But the FDA, it's not so clear that we're having to do a lot of negotiations, expensive negotiations with FDA about expanding this. But we think it's important. We think it's one of the most important training tools. But it should always be optional. It should never be required, but it should be an option for people. The same way that you wouldn't go to a yoga teacher that never did yoga, or a meditation teacher that never meditated. You might prefer to go to an MDMA therapist that's actually done MDMA, or the same with psilocybin. Not that it's essential, but that it's helpful. Then we also have this role play, which is videotaped, and our team reviews it. But then the final part is people work with a PTSD patient under supervision and get feedback from our therapy training team. And so this requires a protocol for them to work on a legal context. Eventually, once it's approved, if it is approved as a prescription medicine, then we'll supervise people with their first patients. So that's really this thought about medical access. Now, here's a big ethical question: is why should people have to go to their doctors to get this, or make it into a religion of some kind? Why should that be? And the point is that it shouldn't be. That there should be legal access for adults and for children in a certain way I'll describe. And what we see is that legalization follows medicalization. People are so scared by propaganda and misinformation, not that there aren't risks, but they've been presented in such a way, exaggerating the risks and minimizing the benefits, and that's sunk in for 50 years or more for people, or more than 50 years. But this is a chart of American attitudes towards the legalization of marijuana from 1969. So this is almost 50 years to 2017 of attitudes towards marijuana. And what we see is that from 69 to the late 70s, it goes from 12 to 28%. That's where a lot of people thought, oh yeah, it's inevitable. It'll be legal before you know it. But then there was a backlash. Ronald Reagan, Nancy Reagan got elected. Just say no. The parents groups objecting to trying to protect the kids from drugs. Massive backlash, lasted for multiple decades, no progress made. And then starting around 1996, attitudes started moving up towards the legalization of marijuana. And what happened in 1996? The first medical marijuana states in Arizona and also in California. So the medicalization, as it got distributed throughout the United States, it changed people's attitudes about risks and benefits, and then made them question legalizing or criminalizing marijuana. And so we just had an election. Drug policy won. Incredible number of initiatives passed. But even before this particular election, Denver, Oakland, Oregon have done drug decrim, or have made mushrooms the lowest enforcement priority in Denver. Plant medicines in Oakland. Oregon just passed the Oregon Psilocybin Initiative and also decriminalized other drugs, all drugs really, for possession. This just is a few days ago. Oregon becomes first state to legalize mushrooms as more states ease drug laws. And psychedelic renaissance. And Oregon decriminalizes all drugs, while DC decriminalizes psychedelics, plant psychedelics. So attitudes are changing. And I think what's going to happen is a decade of psychedelic clinics. We think 2023 is when we'll have FDA approval for MDMA-assisted psychotherapy for PTSD. We think we'll have, if we can do the fundraising, we're about to start another 30 million fundraising campaign to go to Europe globalization. We completed a 30 million fundraising campaign, capstone campaign, we called it. And that's, we think, will be sufficient for us to get approval for research and approval, we hope, FDA, Canada, and Israel. Then another 30 million for Europe and globalization. And then I think psilocybin will be a year or so after us. Ketamine is already legal, and there'll be more clinics that are combining therapy with ketamine. So we'll have a decade or so of these psychedelic clinics rolling out, thousands of them. And what we've found from polling about marijuana legalization, why people would be in support of marijuana legalization, the most important factor was if they knew a medical marijuana patient. Then it was direct information. They knew the risk benefits were okay in a certain place for certain protected times. That just changed everything. So that's what we think we need with a decade of these clinics, loads of people telling stories about how it's helped them. Then we're going to go to licensed legalization in 35. What a lot of people are not aware of, in the US, the laws against alcohol, 23 states have a parental override to laws against alcohol use by minors, meaning that as a parent, you can legally give alcohol to your kids as you see fit. So it's basically family values. It's saying who should decide about educating the young? Should it be the government that prohibits it all, or should it be families that take charge of it? And you'll have some families that are irresponsible at the same time, but this is the way it should be for psychedelics and for cannabis and for other drugs. Really give it to the parents, the parental override, and licensed legalization. I think that's a more responsible way to do it. And then the kind of uses that we'll be able to put it to. One of the projects we have is Israelis and Palestinians are using ayahuasca and MDMA together. Not very many, all underground, but we're trying to study it. Conflict resolution in Israeli and Palestinians. And it is happening, and it's very interesting. Lior Roseman is coordinating the project, and he's at Imperial College working with Robin Carhart Harris's sponsorship. Antoine Saka is from Bethlehem, Palestinian, and Natalie Ginsberg is MAPS's Director of Policy and Advocacy and is working closely with Lior on this project. And this is a marijuana farm that they were at in Israel. One of the people that was at one of the ayahuasca sessions said, there were moments, this was listening, there were moments of love and open-heartedness that we were all together. There is no, you are Jewish, Arab, Muslim, Christian. Everything was stripped. All this nonsense was out, and only acceptance and love were present. There'll be lots of now work blending psychedelics with meditation. Vanya Palmers did an incredible study with the University of Zurich, lifelong Zen meditators. Zen has not been too sympathetic to psychedelics, but lifelong Zen meditators benefited substantially from an experience of psilocybin in the meditation retreat and brain scans before and after, and it helped them deepen their meditation practice. Roland Griffiths is near the end of finishing a study with religious leaders from different religious traditions who are taking psilocybin, and it's going to be really profound, this whole question about, is there a mystical core of the different religions? And we do think that the mystics of the different religions are less fundamentalist, have more in common with the mystics of their own religions than the fundamentalists of their own, the mystics of other religions than the fundamentalists of their own religion. So we hope to really spiritualize people in general through psychedelics, through supportive settings. When drug prohibition is over, we're going to need a lot of psychedelic harm reduction. We're pioneering that already now with our Zendo project, and we're going to expand that to train lots of people in these cities where mushrooms and psychedelics are being lowest enforcement priority. But we've had all these different events that our Zendo project brings therapists, and we are training people basically for peer support. So what we need under prohibition, what we need under post-prohibition is pure drugs, honest drug education, and harm reduction, and understanding among the community. So we now have a contract for the first time ever with the Zendo project with the city of Denver to train their first responders, police, fire, ambulance, hospitals, if they encounter people that have difficult psychedelic trips from going to Denver for mushrooms. So we need that all over America. There's a lot of catalysts of a sense of global interconnectedness. On the one hand, the coronavirus has made us feel connected in ways that the world has never, ever felt so connected. And then global warming and, being aware of this big system, bigger than any one of us, bigger than any countries, or our psychedelics. And I'd rather work with psychedelics. And this is Robert Mueller, written in 1984, the Assistant Secretary General of the United Nations. And he wrote this book, New Genesis, Shaping a Global Spirituality. And he didn't mention psychedelics, but I wrote him and he wrote me back and we met. And he's very sympathetic to this idea that really we need to move beyond people's primary identification with their tribe, their country, their gender, their religion, but this global spirituality, which both helps us feel all connected and also paradoxically helps us appreciate all the differences. And this is where we want to get to. Einstein said it's become appallingly obvious that our technology has exceeded our humanity. So that's true. And we are destroying the planet, and humanity is on a difficult course. But we can develop our humanity through psychedelics and psychotherapy. And Edgar Mitchell, when we see our fundamental unity with the processes of nature and the functioning of the universe, as I so vividly saw it from the Apollo spacecraft, the old ways of thinking and behaving will disappear. A lot of the astronauts have said that. So it's a lot more expensive to shoot people up into space than to bring them to a psychedelic clinic. So that is our practical strategy. By 2070, we're thinking that 2035 is when we have licensed legalization. Hopefully we reach psychedelic utopia. The island is the entire world. This was Aldous Huxley's final book, Island, about the psychedelic utopia, but it ended up being destroyed by the oil companies. So there is no island. The island is the world. And we really need to embed this spirituality in the whole world. And I think the psychedelic renaissance is contributing to that. And I would just say, from Goethe, what you can do or dream you can, begin it. Boldness has a genius, power, and magic in it. So, thank you very much.
Well, thank you, Rick. So this is your cost effectiveness pitch. It's
Yeah.
it's much more expensive to catapult astronauts into space than to bring them to psychedelic clinics. That's pretty good. I like that.
It's hard to argue with that, huh?
Hard to argue with that. You don't even have to count the numbers. I think everybody will agree. So first of all, we had one huge announcement today all over the media. And I wonder if you have another big announcements for us, or if you don't, could you tell us when will we find out the news?
Well, yes, I'll say that we have given the New York Times an exclusive on reporting whether our first phase 3 study of MDMA-assisted psychotherapy for PTSD was statistically significant or not. And so we need to kind of be quiet in public settings about that. We did get some information about that, and so.
So you're sitting on this information and you're not going to tell us, okay?
Well, let me.
When will we find out?
I'll just say that I have a smile on my face.
Okay.
The other thing that we need to do is, of course, present it all in a scientific paper. And that'll take another couple months for all the details, but.
Right.
I think that this idea that depending on COVID and how that does for delaying research, we hope to finish our second phase 3 study by the middle of 2022. We've already started screening for it early 2023, or maybe even we can accelerate it late 2022. We hope for FDA approval, and we know that Health Canada and Ministry of Health in Israel will follow the FDA.
Okay, great. So it seems to me like you always have a smile on your face, Rick, so I wouldn't know if the news is good or bad. I have a personal question for you.
My life.
I have a personal question for you. MAPS is currently going through a boom, very big period of growth. And what is this like for you? And what's the most fun parts of it for you? And what are the kind of parts of that you don't like so much?
Yeah, that's a fantastic question. I mean, the parts that I like about this boom, so, it's now 100 people, all supported with them and their families, by donations. So the scale of things that we can do and the phase shift that we're going through as we anticipate phase 3, well, first off, moving from phase 2, small pilot studies, to moving to phase 3, which is much, much larger, and then thinking about the real potential of commercialization and growing for that. So the growth is really enjoyable in the sense of knowing what we're trying to do. And just yesterday, I've been thinking about, this big $30 million fundraising campaign to bring MDMA for PTSD to Europe and then around the world. So I've also been thinking, after that, the next step after that is to raise $100 million. And that'll be to explore other indications of MDMA and potentially to work on ibogaine for opiate addiction. But the main thing for us is the other indications of MDMA. And by that point, I think we will have really set such a base that the income from the sale of MDMA will fund, further research, and we will be responding to the needs. So being able to respond to the patient needs, even think about $100 million campaign is outrageous. You know,
Yes.
I mean, it's so the scale of things. The thing that is hard for me, I guess I'll share this, is you know, it's so it's yeah. There's people I don't even know. There's things we're layering on bureaucracy. We're laying on things. You know, we're getting more public, and so we used to have a. We used to have a program of psychedelic therapy for staff as part of the healthcare plan. So, you know, as we get bigger and, you know, more scrutiny and FDA audits, you know, we have to take that out of the healthcare plan, stuff like that. So it's just a different level of review and scrutiny, I'd say.
And public benefit is at the heart of your organization, and is there any risks to eroding any of that main goal as your organization grows?
Well, it depends. So here's the challenge. You know, now that there are these for-profit examples, you know, and they have access to capital, and patients are suffering, you know, and can we fund it all through donations? So far, as I said, $100 million. So the challenge is, how do we balance this the need to respond to patient needs, knowing that we have something that can be helpful, or believing that we do, not just for PTSD and beyond, but also trying to develop a sustainable organization, so we're not constantly you know, seeking more donations from people. But on the other hand, if that's necessary, maybe we can do that. So I think not having as close a touch with things, you know, I miss, but we still have these, you know, relatively small groups that are interacting with FDA. I still get to get high and edit our documents before they go to the FDA. So that's one of my most pleasurable things. But the other part of it is that building an organization that survives me, that sort of, you know, goes beyond the founder, that it has a mission that keeps on going, and it has a staff and an engine. So that's I'd say the most important thing. And so, I mean, because the need is there, it makes sense. So it's been hard to let go control from having, you know, the first board of directors was me, an old girlfriend of mine who we had one of the most beautiful breakups on MDA, and were super friendly, and a friend that I used to go to Grateful Dead concerts with. So it was kind of minimal in the level of board oversight or board, you know, so getting bigger, you know, and trying to make it so that it's got this, you know, will survive beyond me. That's been really hard to kind of, you know, surrender control in that way. But also it's been reassuring, really reassuring. So it's great. The part that's hard, that I've never been able to really address, is that there's still so much flow coming in. You know, this sense of being overwhelmed, and, you know, even with an assistant now, and, you know, all these people, but that's just but the need. So that's our challenge, is sort of, how do we take the flow that's coming toward us and, you know, find out how to respond as best we can.
And from my vantage point here, MAPS has been all the people I've been in touch with have been extremely generous and kind and helpful with this conference and anything else that I was communicating. So that's really great.
We have such
a lot.
Team. Let me say, just, we have people that are really mission driven, that are inspired, that are dedicated, skilled. We have a whole bunch of people that we call the refugees from big pharma. You know, people that have the incredible skills that they got from pharma, but really want to work in a different model, in a public benefit model, in that way. And also are appreciative of what we do on the drug policy reform side as well. That even though we're trying to spend all this money to get MDMA into a medicine for PTSD, and eventually other things, we'd like to look at ibogaine for opiate addiction. I know that Atai is going to be trying to do that as well, and maybe we can find complementary ways to explore that space. We're working on cannabis for PTSD. We're trying to get a $10 million grant from the state of Michigan from their marijuana taxes. So I think we've got a lot of opportunities, and it's just great to dream big.
Wonderful, wonderful. You know, a lot of people are asking about training. Could you say something about when clinicians training will be available? What will it look like? And will Canadians also be eligible to apply for that training?
Yeah, oh, for sure. Well, actually, we're working on negotiations with a for-profit company in Vancouver, Numinous, about training. We have a training that's going on right now, as I mentioned, with around 55 people or so. A lot of the Europeans and some of the Africans are being trained, but they're only being partially trained. So what we want to do is set up in all the different countries opportunities for people to get MDMA as part of their training, and we want to train the trainers. So the people that we're training now, centered out of the University of Leiden, are going to become trainers in the Netherlands and for Europe. There's also Ben Sess and his team are going to become trainers in England. We've got Karen Sarfati and Ido Simeon, the husband and wife, are going to be trainers in Israel. We are wanting trainers also in Canada for sure. And because our phase 3 is 2 sites in Canada, 2 in Israel, and 11 throughout the United States, we will submit the data to FDA, but also to Health Canada and also to the Ministry of Health in Israel. And it will be approved FDA first and then the other countries. But Canada is a big part of what we want to do.
Right.
And also we're doing a lot of work in Toronto with people at Ryerson University, with Candace Monson is going to be working on MDMA for, it's called cognitive behavioral conjoint therapy, where one person has PTSD, conjoint is dyad or couple, the other has impacted by the person who has PTSD. And so both get MDMA. There's going to be an MDMA eating disorder study that's going to be taking place in Toronto and also in Vancouver and Denver. Sanjay Singhal is the donor from Toronto who's supporting this project. There's also going to be a study combining MDMA with cognitive processing therapy in Toronto with Anne Wagner, exploring new ways to deliver MDMA. And I just wrote a letter to Health Canada on behalf of people that are working in Canada who got the exemptions for psilocybin for people with life-threatening illnesses. And now we're trying to see about getting an exemption to give psilocybin to therapists as part of their training inside Canada. So,
and that the training you're planning to provide clinicians training before the legalization, right?
Yes. Now let me, I guess, talk a bit about it. So from our public benefit perspective, what we think the real public benefit is helping people with their PTSD or whatever their clinical conditions are. So the training of therapists is a vehicle to do the public benefit. So therefore the training we want to do at our cost. We're not trying to make the training a profit center or a business. We want it to cover at cost, but we do want therapists to pay for the training. We think that's legitimate. And so we're trying to get the training as inexpensive, and it turns out that doing virtually does dramatically reduce the costs. We did prefer at the very beginning, and for all of our phase 2 and phase 3 therapists, to do that in person. And we may do some of that in person, some going forward. But so you go to the MAPS website and you can see to participate. There's the therapist training program. You can sign up for that. You get more information. For now, though, therapists, it's been about $10,000 or so for the training. The big thing that costs a lot is actually giving people MDMA, because it has to be in a protocol. There's 2 therapists for 1 person. That's the most expensive part of the training. The supervision while they're working with PTSD people is less expensive. So we're exploring different models, but for people to pay for it, we paid for the training of people to work on phase 2 and phase 3 on our research studies. We didn't require them to pay to work on our studies. But for training people to treat patients, we don't have the resources to just pay for all their training. And so we'll make it, so that's why we want to do the training as, cost breakthrough. And we want to work with other academic institutions, like in various institutions, the University of Manitoba. You could have training programs that would be part of your psychology program or a master's level program of training therapists, and you'd have a component, a semester or whatever, is about getting trained to do psychedelics, and you have these protocols where they could get MDMA too. We're doing that. We just did with Naropa in Boulder, Naropa University. We're negotiating with people at the University of Maryland because one of their big funders, Bob Parsons, is a funder of veterans and helping people with PTSD, and he wants to support training therapists of color at the University of Baltimore. So we're open to collaborations, and training the therapist is the key rate limiting factor towards getting the healing out the door. And so we want to find all different ways to facilitate.
Right. And for those people, I see there are the questions rolling in here. For those people who missed our discussions earlier, MAPS is currently in. There's a question: what level of clinical training will be required to receive training from you? And that question was discussed earlier, and you're in negotiations with MAPS. You want to answer this?
Yeah, I'll just say that the things that we're negotiating with FDA about, we do have a two-person team. Right now, the one person has to be a licensed therapist. The other person can be a student with mental health training, but does not need to be a licensed therapist. The FDA, and this is a negotiation with FDA, they want the second person to have a bachelor's degree. We don't think that's necessary, but we may have to do some sort of studies with people with different kinds of credentials to help the FDA feel comfortable. But the FDA has gone, because they're now starting to see that this is going to work, they think, possibly, and they're, like any bureaucracy, trying to be cautious. For a while, they've said that the lead person needs to be an MD or a PhD. And the second person needs to be this, mental health training, bachelor's degree, something like that. And there needs to be a physician on site in the clinics. We don't think that there needs to be a physician on site. Our safety database doesn't demonstrate that. There should be medical screening and medical prescribers, but there doesn't need to be a physician on site. We think the FDA is going to yield on that. We think that they're going to yield on MD or PhD as the lead person. It'll just be a licensed therapist. The second person, we got to go after the need for a bachelor's degree or being, and have. So even we're looking at, can we call this psychotherapy if there's one person that's not a psychotherapist? We're looking, we want the credentials to be as open. And the other thing is that through the Zendo project, through the psychedelic harm reduction, we're training anybody to do peer support. No credentials required. It's all about, building a psychedelic therapy knowledge base in the public for personal growth, for, just to sort of have self-healing going on all over the place, or support or peer support in the whole culture to try to prevent backlash.
Hey, Rick, I have one more question for you and I'll let you go. You've been very generous with us. We really appreciate that. So you seem to me like a very joyful person. Could you tell us about your views of the role of joy in healing?
Oh, well, one of the things that I've noticed, okay, so I have done, sitting for people throughout. At 18 years old is when I first decided I wanted to be a psychedelic therapist. And so I've practiced now and then with various people. And there are moments where humor and joy and laughter are the most healing. People somehow think you're working with PTSD patients and they've been through, horrible traumas that humans should never even do to each other, never even think of. And, it's a super serious thing, and they've been abused or almost killed or all these different things. And there is time for humor even in those moments. And in fact, some of those moments, there's time for tears. There's time for humor. I think it lifts the mood. It's sort of, well, here's a good example, and maybe this is a good one to close on. I was working with a young woman in her early 30s, so not that young, but a woman in her early 30s was dying of cancer, and her mother and I were the co-therapist for this person. And we did a whole series of studies, of sessions, some with MDMA, some with mushrooms, some with LSD, some with different combinations. And the mother and father had been divorced. And several days before this woman died was the final MDMA session. And the father came for the first time after this whole sequence to be part of it. And the mother took MDMA. So the mother takes MDMA, the daughter takes MDMA. I'm not. The father's there, he's not. But there was one moment when this woman, Mara, couldn't move herself up. She was sort of stuck in bed. And so her father had one arm and was sort of holding her up, and her mother had the other arm holding her up. And it was like this family triangle kind of thing. And the MDMA took away the pain. The MDMA blends super great with opiates, and you have better pain control. And the opiates are sedatives. The MDMA stimulant wakes you up. So you're open-hearted, out of pain, able to really alert and express for a certain period of hours. And Mara at one point said how beautiful it is to be able to die with your mother and father with you. And it was like rising out of the tragedy was this beautiful moment of happiness and of joy, and just how grateful she was to be able to have been alive at all, to have her parents back together, and to be experiencing this moment without pain, without fear of death, of just joy of being together. And that felt like it was a lifetime moment of rising through the pain to the joy. And so sometimes joy and celebration have an integral part, but so does sadness and grief. It's just this flow. But yeah, I think, joy, laughter, humor, it's really important in therapy sessions.
Thank you so much. Thank you so much, Rick. Thank you for being with us.
Thank you for having me. It's a great moment in history.
It is a great moment in history.
And I think we've come out of America a little bit, the dark night of the soul. Now we're starting to worry about what happens 4 years from now. So I think the real work is now going to be to look at these parts of our culture that are in such pain that they're willing to suspend belief, to knowingly go with stuff that's not true, but just for tribal, how do we reach those people, the pain that they have, build them a sense of connection. And I think psychedelics and psychedelic healing can play a big role in that.
Okay. Thank you, Rick. Okay, so am I on?
You're on. Did you mention the survey before you shut it down?
Okay, so we're going to post a survey for the conference right now. So if you guys have a moment, we would really appreciate if you answer just a few quick questions. Won't take you very long. I want to apologize to those people who the question and answer. We try to do our best. We are new at this. We're trying to do our best. I recognize that many questions haven't been answered, and hopefully you will understand that our intentions have been the best here. And yes, and I want to thank everybody for being with us. This does feel like a very great day in the history of the world, and I really personally hope that it's going to start moving the other direction right now. Do you want to make a final statement?
Sure. Just from my perspective, as coming from the academic world, I really appreciate the different perspectives we've had. We've had people who are coming from universities. We've had people who are practitioners. We've just had I think a wonderful diversity of experience. So I've as far as fulfilling the Ethics Center's mission, which is just to have debate and greater understanding of issues of public importance, I really feel like this has been a great moment for that. So thank you to all of our speakers, and thank you to everyone. These days on Zoom are not the way we'd like to do it. We'd love to be in person. We'd love to see you all, but this, on the other hand, has allowed people who are all over the world and who could never have made it to Winnipeg or anywhere else, any other one place, to be part of this. So we'll discount our blessings, and thank you so much.